Collection of articles on HIV/AIDS by various authors. Part 1. Articles by David Rasnick, Ian Young, and Kary Mullis. Articles by David Rasnick. Inhibitors of HIV protease useless against AIDS. Because HIV doesn't cause AIDS. By David Rasnick. Reap Praising AIDS, August 1996. David Rasnick earns his living as a designer of protease inhibitors, the class of substances touted as the latest anti-AIDS miracle drug. Dr. Rasnick agrees that these drugs do indeed block HIV protease, and thus stop HIV replication. But he is sure that this action can have no effect on the course of AIDS. Why? Because people diagnosed with AIDS are sick from a variety of non-contagious factors, not HIV. Here he explains. As everyone knows, what is now called AIDS was first noticed around 1980, among gay men in Los Angeles, San Francisco, and New York. I had just moved to the San Francisco Bay Area that fall to help establish a small biotech company. Within months of my arrival, stories were going around about a strange new disease that was affecting the immune systems of gay men. It was exhilarating that such an urgent and complex scientific conundrum appeared at a time when I had just reached a measure of confidence in my powers as a scientist, and there I was right in the middle of it, the most stimulating medical puzzle of the century. I haven't stopped learning and thinking about AIDS since then. Whenever I gathered with other scientists for whatever reason, we invariably got around to discussing AIDS. What made AIDS such an interesting scientific subject was that it was bizarre and seemed to break all the rules. The technical aspects of this unprecedented disease marveled us. However, being an organic chemist, not an immunologist or physician, I felt there was little I could contribute scientifically toward unraveling the mysteries of AIDS. That inadequacy in no way dampened my enthusiasm or interest in studying the new disease, however. Then Robert Gallo unveiled his HIV at the famous April 1984 press conference. All the speculating, discussing, and hypothesizing about what causes AIDS ended in applause and backslapping. Gallo's virus provided clarity, and even purpose for me personally, in the form of a subject for my art as an organic chemist. The example of the other retroviruses suggested that a likely constituent of HIV was an aspartyl protease. As a designer of protease inhibitors, I immediately began studying the possibility of designing inhibitors of HIV protease, even before such an enzyme had been characterized. About 6 months into the project, I gave up trying to design inhibitors of HIV protease, figuring others had already cornered the market. A friend at Abbott Laboratories, Jake Plattner, had for years been designing antihypertensives by developing inhibitors of renin, a human aspartyl protease that regulates blood pressure. Jake already had thousands of these compounds in the bottle, and I was sure some would inhibit HIV's protease as well. Today, Jake's group is one of the leading producers of HIV protease inhibitors in the world. One of his inhibitors was recently approved by the FDA for treatment of AIDS when used in conjunction with AZT and other nucleoside analogues. I'm glad I pulled out of the race for HIV protease inhibitors. It wasn't long before I had serious doubts about the viral hypothesis of AIDS. I spent countless hours, as did many scientists throughout the world, devising ingenious explanations for how the so-called AIDS virus, HIV, destroyed the immune systems of its victims. By the end of 1985, the number of exotic hypotheses necessary to account for HIV being the sole cause of AIDS convinced me that something was fundamentally wrong with the basic assumptions that had become entrenched in the mega institutions of science and medicine. The more I examined HIV, the less it made sense that this wimpy virus could cause such devastation. Sometime in 1987 I realized that HIV could not cause AIDS. Although I couldn't prove that HIV was innocent at that time, I could show that the arguments for its guilt were unconvincing, though at the time I still thought AIDS might be infectious. As late as 1988 I had no ideas that there were many other people equally bothered by the inconsistencies of the HIV hypothesis of AIDS until I came across books and articles by such authors as Jad Adams, John Rappaport, Harris Coulter, and John Lauritsen. I learned about Peter Duesberg, the UC Berkeley biologist, from these sources. I immediately looked up Duisberg's 1987 cancer research paper refuting the HIV theory of AIDS. After reading it, I felt confident that the HIV theory would soon be discarded as the prevailing view, and replaced by a more logical explanation. Sadly, that still hasn't happened. I kept studying and thinking, however. The more I looked into it, the more clearly it appeared that AIDS could not be infectious. So what was it? Conversations with Joan McKenna, a Berkeley physiologist, and Joseph Sonnabend, a New York physician, led me to comfortable ground. They considered AIDS to result from a variety of factors, which perfectly fit the various risk profiles that characterize nearly all AIDS patients: gay men in the fast lane, impoverished residents of developing nations, hemophiliacs, etc. Shifting to multiple, combined cases of immune suppression was a psychologically satisfying alternative to the failed hypothesis that pointed to a single cause, HIV. I remained comfortably among the ranks of the multifactorialists for about 5 years. Although I did think that malnutrition could cause AIDS by itself, I resisted Duisberg's proposal that street drugs, AZT, and clotting factor therapy could as well. Such a claim seemed as oversimplified as the HIV theory. However, Peter's relentless logic and superb arguments eventually eroded my skepticism. For 3 years now I have become ever more convinced that he is right. It has taken me 15 years of curiosity, acceptance, doubt, study, understanding, new doubt, followed by new understanding, to come to terms with HIV/AIDS, and I'm a scientist, able to plow through the intimidating technical literature. No wonder the public has bought the contagious AIDS theory. The truth is guarded by experts and hidden by a thick forest of jargon, credentials, and all those papers. The fraud, incompetence, and outright lies produced by the cult of HIV have already been documented. But holding the perpetrators accountable will not be easy. The institutions involved in the scandal have had a long time to hide their tracks. The only way the truth is going to get broad public exposure is for journalists to finally do their jobs, to dig up and examine the truth for themselves rather than parrot the unquestioned claims of pharmaceutical flacks and hack scientists. I have little confidence that this will happen anytime soon. Even though Professor Duisberg's exhaustive expose inventing the AIDS virus masterfully demolishes the HIV hypothesis, I'm afraid we have 2 or 3 more years before the emperor's new clothes become embarrassingly apparent to everyone. In 1989 I decided to do my part by writing a book. There were already a number of excellent titles available that carefully illuminated the HIV/AIDS scandal using thorough referencing to the medical literature. But none had thwarted the HIV media blitz, which used catchy slogans and celebrity endorsements rather than boring data. I wanted to try something new, to present the factual story of AIDS in the form of a novel. My thinking is that people may be more inclined to consider the technical hodgepodge of AIDS if it is presented as entertainment. Whether I'm the person to do it this way successfully I don't know, though I believe the idea is sound. But don't rush out to grab a copy of Germ of Lies. Regrettably, it remains unpublished. The Kuru Guru and I took a break from the laboratory in the fall of 1990 to finish my AIDS novel and spend a short Peace Corps tour in the Chimbu province of Papua New Guinea teaching science and English. My Peace Corps training was conducted in Gorica in the Eastern Highlands province, where the now famous neurological disorder Kuru was described by the American physician Carlton Gajdusek. Gajdusek, you may recall, speculated that Kuru was caused by a hypothetical slow virus, a novel concept that won him a Nobel Prize and provided a model and inspiration for the HIV/AIDS theory. I have a PhD in chemistry, so when I heard about Gajdusek's scientific institute in Gorica I had to go for a visit. I learned from a local that the Kuru Guru still ran the facility, which is the size of a small community college located 3 or 4 blocks from the Gorica airport. As a fellow American scientist who happened to find himself in the highlands of Papua New Guinea, I expected Gajdusek to receive me with the enthusiasm of a long-lost relative. He didn't. I was greeted by a humorless old man who immediately escorted me through the labyrinth of hallways, passing familiar rotovaps, lyophilizers, general lab equipment and a library to what I anticipated would be his office, where we could spend an enthusiastic hour or so taking about each other's science. Instead, the antediluvian gentleman deposited me into the keeping of a very young anthropologist/healthcare worker who nevertheless enthralled me with her stories of helicoptering twice a month to a remote village where a newly discovered tribe was dying out due to extreme infant mortality. I spent less than 5 minutes with Gaidashek. He was the first scientist I had ever come across who showed no eagerness to talk shop. It was just unnatural. It is my experience that scientists have an uncontrollable urge to talk about what they do to just about anyone who will listen. Such reticence to talk with a fellow scientist puzzled me until Peter Duesberg and Brian Ellison explained to me that Gaidashek's Kuru work was as fraudulent as Gallo's, premised on his own false claims that Kuru victims practiced cannibalism and that Kuru was infectious. His outlandish tales and slow virus theory were apparently accepted and even lauded not because they were supported by data or even logic, but because they permitted microbiologists to blame non-infectious diseases on harmless microbes. Following the Peace Corps stint, I returned to the lab. In 1993 I began making proteases inhibitors again for the same diseases I worked on in the 1980s. During my sabbatical, HIV protease inhibitors had become a hot item. Several of the large drug companies had extensive programs underway. Roche had their inhibitors well into clinical trials. Merck had already spent $500 million on their HIV protease inhibitor program, but the grapevine had it that Merck was seriously thinking of pulling out of the field for a number of reasons. The rumor was short-lived since Merck soon began construction of a plant in southern Georgia to produce commercial quantities of its HIV protease inhibitor. Nevertheless, from private conversations with colleagues, I learned that many of them wished they had never gotten involved in HIV work. Some openly acknowledged that HIV protease inhibitors weren't working and likely never would. No mutation to resistant forms. In 1994 I attended the Gordon Conference on Proteolytic Enzymes in New Hampshire, where HIV protease inhibitor results were discussed. John Kay provided interesting information on the clinical trials of Roche's HIV protease inhibitor RO31 to 8959. He made the astounding claim that Roche had synthesized 800 tons, that's right, tons, of this compound. When given the opportunity to change his statement, he stuck to 800 tons. The clinical trial consisted of 400 AIDS patients receiving 2 grams of the Roche inhibitor per day. After 18 months there was not clinical difference between the group given the protease inhibitor and the controls. Kay announced that Roche was putting an information blackout on further reports on the HIV protease inhibitor clinical trials due to the disappointing results. The vogue explanation for the failure of the inhibitors to benefit AIDS patients is that HIV replicates so fast that it eventually develops mutant forms of protease that resist the inhibitors. Even to this day, however, no one has ever found a resistant HIV protease in any patient, even in patients that are claimed to have them. The only inhibitor-resistant HIV proteases anybody has ever examined are those produced in the lab using genetic engineering. Nevertheless, the mutation explanation, just like the HIV theory itself, was completely accepted without question as soon as it was proposed. The mutation theory is preposterous, but not just because its premise that HIV replicates hyperactively is false. The mutation theory is preposterous because it is illogical. Enzyme inhibitors work only because they are shaped like the substrates the enzymes act upon. When an inhibitor fits snugly into an enzyme's active site, then the substrate cannot. This is how inhibitors keep an enzyme from performing its task, which in this case is to produce HIV. Imagine one of these resistant, lab-created HIV proteases. It resists inhibitors because its active site is shaped in such a way that inhibitors cannot fit inside. That's great. But how in the world is the substrate going to fit? Remember, the inhibitor and the substrate have the same shape. They appear identical to the active site, the way a lock cannot tell the difference between a key and a copy of a key. Yet a representative from Vertex presented a poster showing that some of these lab-created mutants did indeed retain most of their ability to act upon particular substrates. But could such a mutant still produce virus? I reminded him that in order for an HIV protease to produce a new virus, it had to cleave 8 different substrates, and pointed out that the ability to cut just one of those substrates did not represent the overall ability of the enzyme to produce HIV. Yet he was claiming that some of these resistant proteases were as much as 90% effective when compared to non-mutated protease. But these claims of high effectiveness were always for just one of the 8 substrates. In every case, the effectiveness on the other substrates was absurdly low, numbers like 0.1% or 0.01% or even 0.001%. In order to calculate the total effectiveness of these mutant proteases, you must multiply together all 8 percentages. And when you multiply even a very large percentage like 90% by a bunch of tiny percentages like 0.1%, what you end up with is essentially zero. In other words, these drug-resistant proteases were effectively non-functional. They could not produce viruses. At the discussion session the next day I argued that the Vertex data did not support the hypothesis that mutations of the HIV protease are responsible for the lack of clinical efficacy of the inhibitors. The drug-resistant proteases were just as inactive as if their active sites were plugged with inhibitors. Other explanations are called for. I went on to propose that the HIV protease inhibitors were performing as designed, blocking HIV production without being undermined by the emergence of drug-resistant mutant strains. The reason that these drugs did not alleviate AIDS is that HIV is not the cause of AIDS. During private discussions, none of my colleagues found any flaws with my reasoning and even thought it was right. I left the meeting thinking that these fellows would continue the analysis where I left off. Well, that, of course, didn't happen. The HIV protease mutation hypothesis has become more entrenched with time. None of the inhibitor-resistant mutant HIV proteases reported so far has come anywhere near the minimum level of overall activity necessary to produce relevant numbers of viable virus. It is extremely unlikely that mutations substantial enough to protect the protease against inhibition will at the same time leave virtually unimpaired its ability to produce viable viruses. The conclusion of my analysis is that inhibitor-resistant mutant HIV proteases are very unlikely to contribute to viral viability in vivo. Therefore, the failure of the HIV protease inhibitors to alter the progression of AIDS is not due to inhibitor-resistant mutations of this enzyme. Asterisk. End of article. Non-infectious HIV is pathogenic. By David Rasnick. Reappraising AIDS, March 1997. I just returned from my first AIDS conference, the Gordon Conference on the Chemotherapy of AIDS, held March 9 to 14 in Ventura, California. I went to present a poster of a paper that refuted one of the fundamental concepts of the prevailing HIV/AIDS model. The paper had just been published in a scientific journal, and I was eager to defend it against the scrutiny of my peers. Also, I knew that David Ho and his co-workers would be making presentations advancing the HIV model. I was determined to subject their ideas to scientific scrutiny face to face. Gordon conferences are some of the world's most prestigious scientific gatherings. Unlike nearly all other conferences, which seek to maximize the number of paying participants, Gordon conferences are generally limited to 100 attendees, all of whom must apply for acceptance. This makes them serious and productive events. All participants get a chance to attend every presentation, and to meet and question every presenter, either during formal Q&A periods, or informally during the social breaks. Over my 20-year career as a pharmaceutical drug designer, I've attended about 9 Gordon conferences, where I have presented papers. Usually those conferences related to my specialty, proteases and the drugs that inhibit them. Ho charms critics. Of the 100 attendees, 90% were American, and 43% were pharmaceutical company employees. I noticed something new to me at a Gordon conference: a non-scientist participant, specifically, a representative of Project Inform, a political group devoted to promoting the HIV hypothesis. The 6-day event began on a Sunday. The special opening lecture was given by David Ho, director of NYU Medical School's Aaron Diamond AIDS Center, and Time's 1996 Man of the Year. His talk was titled, Chemotherapy and Pathogenesis. Surprisingly, I was not the only critic in the audience. Somebody in the front row challenged Ho's criteria for what constitutes an assay of infectious virus, a challenge that has profound implications for the basic tool of contemporary HIV science, the viral load test. He also disputed the mathematical basis of Ho's virological mayhem model, the paradigm upon which Ho wants to base anti-HIV therapy. The specifics of these objections were never made clear because Ho sidestepped the questions with the skill of a seasoned bureaucrat, and in doing so chewed up all the discussion time. Another surprise was an obvious lack of Ho supporters in the audience. In subsequent breaks I found several others who openly rejected the validity of the viral load test and Ho's model of HIV/T4 cell dynamics. Ho could easily become the next Anthony Fauci, who, as director of the NIH's Institute of Allergies and Infectious Diseases, is the government's reigning king of HIV science. Ho is far more charming than Fauci and is coated with several layers of Teflon. Regrettably, Ho left the conference early Tuesday morning, so I never got to talk with him. But I did get to take up the validity of the viral load test with one of his collaborators. Cocktails don't help patients. Martin Markowitz, co-author on some of Ho's most famous papers, including the 1995 Nature article that introduced the virological mayhem model and popularized the viral load test, stayed through the Wednesday presentations, and I was able to question him several times. The first instance occurred during the question period of a lecture he gave on treating early HIV infection. He and Ho have been treating a cohort of 20 patients for close to a year with protease inhibitor/AZT cocktails. The study is ongoing and no results have been published, so Markowitz was discussing preliminary data. According to him, most of the subjects already had AIDS symptoms at the start of the experimental therapy, including 5 who'd previously been hospitalized, although a few had no history of symptoms. Once the therapy began, HIV viral load for each patient dropped below the level of detection and has stayed that way, Markowitz said. He considered this an indication that the therapy was a good one. But did eliminating viral load make the patients healthier? Markowitz had nothing to say about this during his lecture. Surely if the patients had gotten better when their HIV viral load went down, Markowitz would have bragged about it. But the subject didn't come up until I raised it in the question period. "How are we doing?" I asked. "Some are healthy enough to work," he said happily. The implication was that were it not for the cocktails, these patients would not be healthy enough to work, but I suspected this was not the case. Markowitz's smile vanished when I asked, during the 11 months on therapy, when their viral loads were undetectable, did your patients do better, stay the same, or do worse? He didn't say a word. It was an embarrassing moment for the audience. I interrupted the uncomfortable silence by restating the question. Your patients should be doing better, right? Again Markowitz was speechless. He either didn't know how his patients had done over the course of therapy, which is very unlikely, or they were not doing well despite having HIV viral loads of 0. During this revealing silence, the lecture was ended by the announcement of a coffee break. I left with one of my curiosities satisfied. The press accounts of miracles attributed to cocktail therapy, the fabled Lazarus effect, weren't showing up in scientific studies. No viable drug-resistant virus. Monday and Tuesday afternoons were set aside for poster sessions. Since my paper on the kinetics of HIV protease undermined a crucial aspect of the current dogma, I wasn't sure how my poster would be received. The paper, Kinetics Analysis of Consecutive HIV Proteolytic Cleavages of the GAG-Pol Polyprotein, addressed the popular assumption that when antiviral therapy fails, it is because HIV has mutated into resistant forms. Rasnick, March 7, 1997, Journal of Biological Chemistry. In particular, the assumption that when protease inhibitor therapy fails, it is due to the emergence of HIV strains characterized by mutant proteases that are resistant to the inhibitors. This belief is central to the HIV model. Protease inhibitors, especially when combined with AZT into a cocktail, often cause HIV viral load to disappear. When viral load counts start going back up or when AIDS symptoms manifest, it is assumed that new mutant strains of HIV have emerged, ones with proteases that resist the inhibitors. But my calculations show that these theoretical mutant proteases could not be a part of a fully functioning HIV. In order to produce a fully functioning HIV, the protease must cut an HIV superprotein at 8 different sites. Inhibitors work by plugging up the protease's cutting site, blocking it from snipping the HIV superprotein into 9 functioning parts. A protease that would not accept an inhibitor into its active site, one that was resistant to the effects of these drugs, would also not be able to accept the HIV superprotein into its active site. That the protease has to make 8 successful cuts under these circumstances makes it demonstrably impossible that a resistant form could produce functional virus. I noted that there is not one example in the literature of a human infected with viable, infectious HIV that possesses an inhibitor-resistant mutant protease. All the inhibitor-resistant mutants described so far were obtained from the proviral DNA of non-infectious virus. There was no reason, then, to think that drug resistance could explain instances where protease inhibitors failed to resolve AIDS or eliminate HIV viral load. The second major point of my kinetics analysis was that since the viral load test at best measures 99.8% non-infectious viral particles, it should be replaced by an assay that measures the level of infectious HIV particles in blood plasma. I was certain that this proposal would be greeted by a chorus of disapproval. Surprisingly, that did not happen. No one disputed anything I said. A number of people, including Jack Erickson, an HIV protease expert from the National Cancer Institute, openly agreed with my analysis and conclusions. Chasing Markowitz. Erickson left my poster and walked straight over to Markowitz, who was at the other end of the room. I knew Erickson wanted to discuss with Markowitz the points of my poster, and I went over to join them. Sure enough, my poster was the topic. Markowitz greeted me with a smile. Perhaps he did not yet recognize me from his earlier lecture. I started asking about the infectivity assay used in the March 1996 article he wrote with Ho, Science 271, p. 1582, which I held in my hand. The paper concerned the administration of cocktail therapy to 5 patients. Prior to this treatment, the patients had HIV viral loads between 12,000 and 643,000 per ml of plasma. After therapy began, the viral loads for each patient went to 0, and stayed at 0 for the duration of the study. I wanted to know about patient 105, the one who started with the largest viral load, 643,000. He was the only patient for which tissue culture infectious doses, TCID, were measured. Prior to therapy, when his viral load was 643,000, he had 1,000 infectious doses of HIV, per ml of plasma. 2 days after initiating therapy, his infectious doses dropped to 0, but his viral load had not dropped below 500,000. I wanted to know the relationship between the viral load figure and the infectious dose figure. I started by asking, did one infectious dose correspond to one infectious HIV? Yes, Markowitz said, one infectious dose equaled one infectious virus. How did you determine that an HIV, A dose, was infectious? By looking for the P24 protein? Yes, Markowitz replied. Detection of P24 was accepted as evidence of a fully functioning virus. Well, I said, P24 is not good enough. With this, I figured our scientific discourse would proceed along predictable lines. He would ask me why P24 wasn't good enough. I would explain, as documented in my paper, that P24 has been shown by many researchers, including John Erickson, not to be a reliable indicator of infectious virus. I was prepared with references to defend this statement. But Markowitz didn't bite. As following his lecture, when I had asked about the health of his patients, Markowitz simply said nothing. I turned my attention to the disparity between the viral load and infectious dose figures. If infectious doses equaled infectious HIV particles, then the difference between patient 105's infectious doses and his viral load must represent non-infectious HIV particles. I showed Markowitz the graph he and Ho et al. Had published for patient 105. In one case a viral load of 643,000 corresponded with 1,000 infectious HIV particles, and in another case a viral load of over 500,000 corresponded to 0 infectious HIV particles. Markowitz agreed with my interpretation of the data. So I asked him, what was the significance of the hundreds of thousands of non-infectious viral particles per ml that you detected in the blood plasma of patient 105? He frowned, and seemed not to know what to do next. His puzzled look and silence lasted about 30 seconds. Then he simply turned and walked away. It was the first time a scientist had ever run away from me. Typically scientists are bulldogs. They fight for their position. But the HIV guys don't. They run. I noticed at this time that Erickson had vanished. He'd slipped away sometime during this strange exchange with Markowitz, and I never spoke to him again. Were it not for Erickson's devotion to HIV, he and I could have been buddies and colleagues. He is otherwise a sharp scientist who knows enzymes and the technical particulars quite well. Regrettably, though, he yields to the virologists and physicians when it comes to HIV pathogenesis, and he takes his cues from the folks who run the HIV show. As for Markowitz, I was determined to get an answer to my question. I cornered him 2 more times. On both occasions I had to literally stop him from walking away. In each instance I repeated my question about the significance of all that non-infectious HIV. Both times he ran off without answering the question. In the midst of his second retreat he turned and called back with a meaningless response, devoid of even a hint of scientific or logistical merit, "Trust me." I cried back, "Trust has nothing to do with it." It was an absurd exchange, and I would have laughed were it not so pathetic. Dashed hopes. If I was going to get responses for my remaining questions, I would need a stationary target. I found one at the week's most frightening session, Wednesday night's special lecture by John Mellors of the University of Pittsburgh Medical Center's Graduate School of Public Health. The topic, Chemotherapy of HIV-1 Infection, the Past, Present, and Future. Mellors painted an accurate picture of the dismal history of HIV chemotherapy prior to the current era of protease inhibitor/AZT cocktails. I found myself nodding in agreement as he listed many serious mistakes inherent in traditional therapy, which used a single nucleoside analog, like AZT. Perhaps Mellors was a sensible and independent thinker, the sort I'm used to dealing with at Gordon conferences that don't focus on AIDS. My hopes were dashed when he got to what he labeled the greatest mistake of the past 10 years, treating AIDS patients with single rather than multiple antiviral drugs. That's when it hit me, there was nothing courageous about Mellors's critique of the old therapy. In fact, it's the fashion now to recognize mononucleoside protocols as flops so long as cocktail therapy is promoted in their place, which is what Mellors was doing. But the failure of monotherapy was obvious long before protease inhibitors came along. 1/4 basketball game. Mellors's talk assumed its frightening aspect with the appearance of a slide announcing viral load and T4 counting rather than clinical symptoms. He justified this by saying that the recent termination of study ACTG-320 last February put the final nail in the coffin of future clinical endpoint trials. ACTG-320 was a Phase 3 clinical trial involving almost 1,200 people, roughly half taking 2 AZT-style drugs, and the rest taking a cocktail consisting of those same 2 nucleoside analogues plus a protease inhibitor. The trial was stopped early for reasons that are unclear. When the records were unblinded, the data showed that only 8 patients had died in the cocktail group, versus 18 in the group not taking the protease inhibitor. Based on these figures, Mellors and the rest of the medical establishment are saying that cocktail therapy reduces mortality 50% compared to treatment without protease inhibitors. Mellors regards the results of ACTG-320 as conclusive on 2 counts, 1, that cocktail therapy reduces mortality by half, and 2, that this benefit is predicted by viral load. Studies of future treatments should merely look for fluctuations in viral load, he believes. Waiting for patients to die or for other clinical endpoints to manifest would be unethical and unnecessary, since viral load measurements supposedly predict who will and who won't succumb to AIDS. But the leader of the trial, Scott Hammer of Boston's Beth Israel Deaconess Medical Center, admitted that ACTG 320 had not proceeded long enough for differences in the two treatment groups to have reached statistical significance. Boston Globe, February 25. In over 2 decades earning my living as a scientist, I've never before witnessed scientists drawing conclusions of such import based on statistically insignificant data. The concept of statistical significance is essential to the scientific method. Experimental results obtain meaning only after qualifying as statistically significant. Imagine declaring the winner of a basketball game after the first quarter, or the champion of the World Series after the first game. Mellors didn't mention statistical significance, and I didn't get a chance to ask about it during discussion time. So I don't know how he might handle this objection, which I consider to be fatal. Instead, Mellors accepts ACTG 320 as definitive, and sufficient to justify using surrogate markers as the sole criteria of whether or not therapies and drugs actually benefit patients. And he's not the only one. I'm afraid that the mood in AIDS drug research favors Mellors's view. I've heard others call for the end of statistically insignificant results of ACTG 320. This is particularly frightening considering my earlier exchanges with Markowitz, who could claim no improvement in his patients who'd had their viral loads reduced to zero for extended periods of time, and who could attach no clinical meaning to the viral load test. If the Markowitzes and the Mellors of the world have their way, the American public is in grave danger. Killer corpses. In the discussion period of Mellors's lecture, I decided to return to the questions that I'd wanted Markowitz to answer, about the meaning of viral load. After all, that was the heart of the matter. Mellors's call to discard clinical endpoints was only as valid as the viral load figures with which he wished to replace them. For starters, I wanted to compare his answers to Markowitz's. So I repeated my question about the relation between viral load and infectious doses. Mellors responded by proclaiming, "Viral load has nothing to do with infectivity." Aha! Now I had a second HIV big shot admitting that the viral load figures did not indicate infectious HIV. Assuming that viral load testing accurately counted HIV, and that infectious dose testing accurately counted infectious HIV, I offered my 99.8% figure from the Ho/Markowitz paper as the fraction of circulating HIV that was non-infectious. Non-infectious HIV, then, is the source of RNA and proteins including protease from which the genetics and other characteristics of HIV are derived. He agreed. How could he not? Now I had him. Since non-infectious viruses have no conceivable clinical relevancy, then neither could any data derived from them. What's the significance of all the non-infectious HIV? I asked. I had no idea how he could work himself out of this corner, but even I was stunned by his response. The non-infectious particles HIV are pathogenic. Now here was a first. I don't think that anybody's ever gone on record before proposing that non-infectious virus could cause disease. I sat there flabbergasted, noticing the murmur that had broken out. In my astonished state I realized there was nothing else to be said. In the meantime, the session was declared over, the time allotted for discussion having been exhausted by my cross-examination, with no one else having had time to pose questions. My God, I thought. Talk about a rich source of research opportunity. The pathogenicity of non-infectious viruses. Anybody familiar with the antibody response and the premise of vaccinations can appreciate the revolutionary nature, and implausibility, of this idea. My sense is that the audience did, given the intense murmuring, which continued even after the lecture had been dismissed. On the way out of the room an Indian scientist grabbed my arm and asked, "Did you hear that?" Indeed I had. AIDS was caused by a deadly army of viral corpses. Curing the healthy. Though I looked far and wide, I could find not a single controlled experiment discussed anywhere at the conference. It appears that the only thing that exists in the entire world of AIDS is HIV. Anything bad that happens to HIV-positive people is due to HIV, Any improvement is due to therapy. There was even one presenter who took credit for curing people who accidentally pricked themselves with needles tainted by HIV-positive blood. The patients were aggressively treated immediately with antiviral drugs, and didn't become positive. The scientist claimed this protocol was what prevented seroconversion 1 time in 1,000, a fact he did not mention. And neither did anybody else, though this fact is well known, and the attendees were all certified AIDS experts. Not only was he claiming credit for the effects of statistical probability, he was also claiming to have cured healthy people, and nobody called him on it. These HIV supporters are so desperate for good news that they'll say and accept anything that agrees with the HIV model. Cold shoulder. Early on it was clear that certain people at the meeting already knew of me. They avoided me. Others, though, initially showed interest when I raised my objections. It was obvious that these problems were not new to them, they had just never discussed them before or been around anyone who wanted to. However, once these potential allies continued the discussions with people like Markowitz, scientists with status and influence, then they as well avoided me from then on. I found it a lonely business acting like a scientist at an AIDS conference. Asterisk. Postscript, breaking the rules. I know the rules of the Gordon conferences and have abided by them since attending my first one in 1980, no press, no cameras, no recording devices. Nothing revealed at a Gordon conference is to appear in print except by the original authors. You can take all the notes you like, and discuss the information with colleagues all you want. You just can't put it into public domain via print. I openly acknowledge that my report breaks these rules. I don't do this lightly. Gordon conferences are my favorite meetings. However, the HIV/AIDS scandal has compelled me to take this action. The information on what is wrong with the prevailing HIV dogma is almost totally hidden from the public. The travesty of the HIV protease inhibitor clinical trial results, for example, was clearly evident at this particular Gordon conference, as well as one I attended in 1994, CRA August, 1996. This information is just too important to be kept from the taxpayers and consumer who fund it all. The rules might seem sinister, but they aren't. They enable scientists to present preliminary results without fear of being scooped by colleagues, or being held accountable for mistakes. Ordinarily these rules promote honest scientific discussion and exchange of ideas. But the AIDS industry has adopted them to hide facts that shouldn't be secrets. I hope I have done the right thing. I might be banned from future conferences. End of article. Blinded by Science. By David Rasnick. Spin, June 1997. A skeptical veteran of AIDS research bemoans the culture of conformity imposed by government-funded, industry-driven, and media-hyped big science. People think of AIDS research as the crucible of modern science and technology. There are more than 100,000 scientists and doctors working on AIDS, more than the annual number of AIDS patients in the U.S. There are 80,000 AIDS organizations in the U.S., one for each new AIDS patient. As a scientist who has studied AIDS for 16 years, I have determined that AIDS has little to do with science and is not even primarily a medical issue. AIDS is a sociological phenomenon held together by fear, creating a kind of medical McCarthyism that has transgressed and collapsed all the rules of science, and imposed a brew of belief and pseudoscience on a vulnerable public. Like most scientists, I was taught in school that science is a self-correcting activity. All hypotheses, no matter how precious, were put to the grindstone of the scientific process, which was designed to preserve what was true and destroy what was false. But this delicate state of affairs was possible only when science was free, or, in fact, when science was broke, before the tragic union of government and science ushered in by the Manhattan Project and the Cold War. Nuclear physicist Ralph E. Lapp, a researcher and advisor on the Manhattan Project, remembers what science was like before the shift. In those days no scientist ventured to ask the federal government for funds. He gathered together what money he needed from private sources or earned extra pay as a consultant to pay for his own research. But mostly he acted as a jack of all trades and bullet in his own equipment. Graduate students were required to take machine shop practice and learn glass blowing. If he needed Geiger counters, he made them himself, and he wired his own electronic circuits. Before World War II, research and development funding for the sciences, public and private, amounted to about $250 million per year. By 1993, the federal share alone was $76 billion. And what has it bought us? For the $45 billion of taxpayer money spent on AIDS so far, HIV researchers still use statistical methodologies shown by their inventors to be invalid and still conduct experiments without any controls. They take causes for effects, correlations for causations, and constants for variables. Most important, they haven't stopped AIDS. What they have done is successfully instilled fear into human sexual relations, an amorphous fear, which most AIDS professionals as well as journalists argue has been valuable. I doubt even George Orwell could have imagined that an autocratic regime would be able to successfully equate sex with death at the end of the millennium. What the government has bought with this money is a culture of conformity, whereby only HIV research is funded, creating the appearance that all researchers believe HIV is the cause of AIDS. Let's review what readers of this column have been told many times. In 1984, National Cancer Institute virologist Robert Gallo held a press conference, with Margaret Heckler, then the Secretary of Health and Human Services, at his side. Gallo announced that he had found the probable cause of AIDS in a retrovirus he was then calling HTLV3, and which had already been isolated a year earlier at the Pasteur Institute in France. With that announcement, Gallo had publicly leapfrogged straight across the scientific process, across peer review and analysis, across the very checks and balances of science. He made no attempt to demonstrate his claim. In fact, only 50% of his sample patients had any trace of HIV, but fed it straight to the global media, which broadcast it without hesitation. What made the move toward the viral cause of AIDS irreversible was the fact that the federal government supported it, if it didn't engineer it. Now a new standard of brash, unscientific science was set, and all others took their lead from it. Since then, the media have painted a false picture to suggest that virtually every scientist and doctor in the world supports the HIV hypothesis of AIDS, with the lone dissenting voice of Peter Duesberg, who is now defunded and all but exiled from American science. In truth, there are thousands of dissenting voices throughout the world, who have been trying for years to get our opinions heard, counted, factored in. The Group for the Scientific Reappraisal of the HIV Hypothesis was founded by former Harvard professor Charles Thomas in 1991. Today more than 500 scientists, healthcare workers, and other professionals have signed on. What distinguishes this group? By and large, its members are not dependent on grants from the National Institutes of Health for their livelihood. The signatories who are Nobel laureates are immune from bureaucratic intimidation. Many of the academic members of the group who publicly support Duesberg are emeritus professors, whose careers can't be terminated. Younger academics, on the other hand, who have seen the establishment mercilessly punish and excommunicate someone of Duesberg's stature have clearly gotten the message. They keep their mouths shut and bow down before the golden calf of HIV. Serge Lang, the legendary Yale mathematician and member of the National Academy of Sciences, has had so many letters to editors concerning the HIV scandal refused publication that he started sending checks along with his letters, the equivalent of buying space in which to speak. Some editors were sufficiently embarrassed by this tactic that they published Lang's letters and returned his checks. There are countless more stories of censorship, intimidation, and financial and professional manipulation. But the discordant data still sits there, indestructible and unresolved. A few specifics: we have been told for 13 years that AIDS is infectious, and is spreading rapidly into the heterosexual population. If so, why have the Centers for Disease Control's estimates of the prevalence of HIV infection in the U.S. never gone up since HIV testing began? In fact, the estimates have gone down. Since 1985, the U.S. government and various civilian institutions have performed some 20 million HIV tests per year. This is where the CDC gets its estimates of how many Americans are infected with HIV. But because of the reduction in false positive results, the CDC's current estimate is that there are about 750,000 HIV-infected Americans, down from the original mid-80s estimate of 1 million or more. Another of the many anomalies, the prevalence of HIV in the general population is equally divided between men and women. But men account for 90% of all AIDS cases in the US, as they have throughout the history of AIDS. We are told that hemophiliacs are especially hard hit by AIDS. 75% of the 20,000 hemophiliacs in the US test positive for HIV. The paradox is that the average lifespan of hemophiliacs, including those who were HIV positive, doubled during the first decade of AIDS. In fact, the positives seemed to do better than the negatives. But in 1987, the mortality of HIV-positive hemophiliacs began to rise sharply. That was also the year that AZT, the drug now openly admitted to be detrimental to AIDS patients, was first widely prescribed to HIV-positive hemophiliacs. When AIDS first appeared around 1980, I had just moved to the San Francisco Bay Area to help set up a small biotech company. Soon stories were going around about a strange new disease that was affecting the immune systems of gay men. I viewed the new scourge as one of the most stimulating scientific puzzles of the century. But as an organic chemist, not an immunologist or physician, I felt there was little I could contribute scientifically toward unraveling the mysteries of the disease. In 1984, when Gallo announced at that historic press conference that the cause of AIDS had been found in HIV, all speculations about causation came to a screeching halt. At first, I was exuberant. This retrovirus provided the clarity we all needed. I now had an object upon which to apply my art as an organic chemist. I began to explore the possibilities of making inhibitors for the protease, a class of enzymes, produced by HIV. But when I recalled that a friend at Abbott Laboratories had been working for years on just such protease inhibitors, I pulled out of the race. I'm glad I did, because before long I was having serious doubts about the viral hypothesis of AIDS. I spent countless hours, as did many scientists, devising ingenious explanations for how HIV could destroy the immune systems of its victims. But by the end of 1985, I was convinced that something was fundamentally wrong with the basic assumptions that had become entrenched in the mega institutions of science and medicine. The more I examined HIV, the less it made sense that this largely inactive, barely detectable virus could cause such devastation. How could $45 billion of taxpayer money be spent on such an ordinary, humdrum virus? And why has the media functioned as the public relations arm of the HIV/AIDS establishment? Uncovering Watergate now seems trivial compared to what it will take to expose the decade of fraud, incompetence, and flagrant lying that has been going on behind a veil of scientific and medical jargon, credentials, and expertise. In The Rise and Fall of T.D. Lysenko, Russian historian Zhores Medvedev describes the rise to power of an autocratic Soviet pseudoscientist, who over a period of decades corrupted and nearly destroyed Soviet biology and agriculture. Medvedev concludes that monopoly in science by one or another false doctrine, or even by one scientific trend, is an external symptom of some deep-seated sickness of a society. The general acceptance of Lysenko's perverted scientific theories, designed to undermine Western science, primarily Darwinism, was heavily promoted by the government-supported media. The peculiarities of the Soviet press, Medvedev writes, made possible popular support for one or another scientific trend selected by the political leadership, and complete suppression of the opposition. Medvedev easily could have been describing the way our government's public health institutions have commandeered the AIDS debate. Because the NIH and Dr. Anthony S. Fauci, director of the National Institute of Allergy and Infectious Diseases, control funding of virtually all academic research, they can with impunity cut off funds to dissenting voices. Editors of peer-reviewed journals are pressured not to publish papers critical of the HIV hypothesis. Journalists who interview dissenting scientists are denied access to government sources, and accused of acting immorally. The result is a world in which the once cherished process of scientific discourse is treated as social deviance, and punished as such. In AIDS, Perhaps the most devastating effect of this new anti-science is in the realm of clinical trials. Most drugs that are approved by the FDA must complete 3 phases of human clinical trials: Phase I for toxicity, Phase II for short-term effectiveness, and Phase III, the most vital, for the ultimate measure of morbidity and mortality, that is, whether the drugs actually benefit patients. None of the recently lauded HIV protease inhibitors approved by the FDA has yet completed a Phase III clinical trial. In order to satisfy the requirements for licensing, however, 2 Phase III protease inhibitor clinical trials recently got underway, a 1,200 patient Boston-centered study and a 3,300 patient trial in Europe. With AZT, only the Europeans kept their study going long enough to see the true results, despite the fierce protestations of activists and healthcare workers. In the end, the so-called Concord study gave us the answer about AZT: it did not work. But on February 25, a Boston Globe headline trumpet ed, AIDS trial terminated, 3 drug therapy hailed. The article reported that 63 of the 579 Boston trial subjects receiving 2 drugs had died or developed new AIDS-associated illnesses, while only 33 of the 577 individuals receiving the new 3-drug cocktail had died or gotten sicker. It also mentioned that, as late as mid-January, a peek at the results of the 2-drug regimens had concluded that they had not yet diverged enough to warrant stopping the study. When the triumphant results were reported, Fauci dramatically announced that the trial had provided evidence that combination treatments including protease inhibitors can reduce the risk of death from AIDS. You don't have to be a scientist to follow the logical difficulties here. It seems highly unlikely that between mid-January and mid-February, the data had changed enough to stop the Phase III trial. Even the leader of the Boston trial admitted that there was no statistical difference between the deaths in the 2 treatment groups. When the study was concluded, there were 8 deaths among those taking 3 drugs, compared with 18 deaths among those taking 2. Using these mortality figures at face value is a little like using the halftime score in a basketball game to determine the winner. As everyone knows, the lead can oscillate back and forth throughout the game. The same is true of clinical trials. In short, we don't know if the combination therapies work to reduce the risk of death, because it hasn't been proven. So why did Fauci and his allies halt the Phase III trial before it yielded statistically significant results? Protease inhibitors were internationally hailed as miracle drugs in 1996, without the benefit of proof. As long as Phase III trials were underway, they posed a dangerous uncertainty. A completed trial that resulted in an unsatisfactory result would be difficult to explain away. From the HIV/AIDS establishment's perspective, the safest course of action was to stop the game, declare victory, and hope nobody would call them on it. AIDS research has become a virtual puppet for the titanic, symbiotic forces of industry and government. I recently attended a small, elite conference focusing on the chemotherapy of AIDS, where 43 of the 100 people present were pharmaceutical company representatives who ran to the phones after each session to call in the results. Is this Wall Street or science? During one session, I asked a leading proponent of cocktail therapies how the patients receiving the cocktails were doing. He said that some were healthy enough to work. Then I asked whether, during the course of therapy, the 20 individuals did better, stayed the same, or got worse. He did not answer. It was an embarrassing moment for the audience. Then I asked, "Your patients should have done better, right?" Again, he was speechless. Even more disturbingly, one presenter suggested that clinical endpoints are dead in Phase III trials. In other words, he believes that clinical trials will no longer use morbidity and mortality as endpoints. They will no longer be designed to determine whether drugs actually work. The excuse given for dropping Phase III clinical trials is that they are unethical and too costly. We are henceforth supposed to assume that the drugs under evaluation reduce morbidity and mortality before this has actually been demonstrated. To date, there is still no clinical trial that has proven that the protease inhibitors either taken alone or in combination with other antiviral drugs reduce the mortality of AIDS patients. The HIV cult has transported AIDS beyond the domain of science and medicine, and into the realm of mythology. The discourse is controlled by powerful individuals and institutions with a professional or financial stake in HIV, who take it upon themselves to be the sole purveyors of truth. Government institutions have compounded the difficulty of arriving at a true understanding of AIDS by doing everything in their power to suppress the views of scientists who disagree with established opinions. Yet there is always hope for the future. Those willing to challenge orthodoxy still believe that science will ultimately return to its moorings and that their message will be heard. I am reminded of former Supreme Court Justice William O. Douglas's warnings against the tyranny of conformity and the injury it does to freedom of expression and thought. As he wrote in Freedom of the Mind, the curious man, the dissenter, the innovator, the one who taunts and teases or makes caricature of our prejudices is of 10 our salvation. Yet throughout history he has been burned or booed, hanged or exiled, imprisoned or tortured, for pricking the bubble of contemporary dogma. Asterisk. End of article. Chemotherapy of AIDS Conference. By David Rasnick. 14–18 March 1999. This year 105 people attended the 1999 Chemotherapy of AIDS Conference, with 40% coming from industry. Compared to the 1997 conference, this one was more subdued. In 1997, virtually every presenter of new nucleoside analog inhibitors of reverse transcriptase characterized the compounds as DNA chain terminators. This year not a single presenter mentioned the phrase DNA chain terminators. Experimental controls were as absent as they were 2 years ago. From my perspective, the 4.5-day conference was largely a protracted yawn. However, William Cameron's talk Thursday morning made the entire trip worthwhile. Cameron is on the faculty of the University of Ottawa. He is clearly an expert in designing and evaluating clinical trials. He told me that he consults for Canada's FDA. While it was evident that Cameron fully accepts the HIV hypothesis of AIDS, nevertheless, he completely demolished the viral load surrogate marker as a substitute for morbidity and mortality endpoints in clinical trials. He said that people don't die of HIV viremia. He also stressed that viral load is assumed to reflect quantitative effects. There was no basis for this assumption. I should point out that over the previous 4 days virtually every talk and poster, excluding mine of course, relied exclusively on viral load measurements to determine the effectiveness or failure of anti-HIV drug therapies. Cameron illustrated with specific examples how easy it is to engineer a desired outcome in clinical trials using viral load surrogate endpoints. In order to guarantee a therapeutic effect, one needs only to recruit relatively healthy patients and observe them only for a short period of time. This method works even for drugs that have no therapeutic benefit and are actually harmful to the patients. The explanation he gave, I couldn't have said it better myself, was that healthy people tolerate toxic drugs better than sick people. He gave as a specific example the DDI clinical trial disaster. Over a short 12-week study, DDI showed efficacy based on viral load. But after 12 weeks, patients on DDI experienced severe toxicity. Robert Yarchone of the National Cancer Institute had discussed the severe toxicity of DDI just before Cameron's talk, which only emphasized the point. Cameron also showed that the placebo arm of a surrogate marker clinical trial can also show a pronounced clinical benefit, indistinguishable from drug therapy, if only the studies were allowed to go longer. The end result is that there would be no difference between drug and placebo as long as the drug was not toxic. It should be pointed out that to date all protease inhibitor clinical trials were terminated prematurely before it could be determined that people taking the drugs actually lived longer and better lives than those not taking the drugs. Cameron suggested that any therapeutic benefits due to the HIV protease inhibitors may result from their antimicrobial activities, since many pathogens have essential aspartyl proteases. HIV protease inhibitors inhibit other aspartyl proteases. However, he told me later that the people he'd seen on Heart looked like hell. They were wasting away to nothing among other problems. He was clearly not impressed with the drugs. I was sitting at the back of the room during Cameron's talk. I had a good view of how he was being received. A number of people were noticeably uncomfortable, for example Martin Markowitz of David Ho's Aaron Diamond AIDS Research Center. About halfway through Cameron's talk, Markowitz grabbed a newspaper, turned toward the wall and pretended to read it. Cameron's lecture received only short, polite applause. It was the only time I applauded the whole week. On to other topics. By and large the week was pretty boring. Nevertheless, there were a few scraps of information that some may find useful. On Sunday, Angela McLean of the UK defined what is meant by acute HIV infection or acute illness. A person is acutely ill with HIV if he or she has a detectable viral load, i.e. the presence of HIV RNA, and does not have antibodies to HIV as determined by the ELISA antibody test. This definition, of course, does not take into consideration those people who are false positive for the viral load and antibody tests or people who go back and forth. McLean said that at the peak of acute illness with HIV that 6 new cells are infected with HIV by each previous HIV-infected cell. Peter Duesberg told me that in the laboratory 1 retroviral infected cell will produce enough virions to infect 100 new cells. She said that cytotoxic lymphocytes, CTL, kill wild-type HIV-infected cells in about 2 days. She went on to speculate that CTLs do not kill mutant HIV-infected cells, implying that this was the reason for the drug failures. McLean admitted during questioning that no other infectious agent had been put through her analysis. That means there is no way to judge the physiological significance of McLean's studies. McLean made the curious statement that the better the anti-HIV drugs work, the more likely they will fail. Figure that one out. After a week of this stuff I think I know what she was getting at. Shortly after a person begins taking anti-HIV drugs his viral load drops. The greater the drop, the greater the supposed therapeutic effect. However, virtually everyone on the cocktails eventually shows a rise in viral load. This rise in viral load was interpreted by most at the meeting to reflect drug failure. However, there were a number of attendees who pointed out that a rise in viral load did not mean those patients were experiencing an increase in clinical symptoms. Brendan Larder of Virco UK Limited began Monday's session on anti-HIV drug resistance. There are now 5 HIV protease inhibitors available. The ubiquitous viral load is the workhorse of anti-HIV research and therapy. A rise in viral load in people taking the anti-HIV drugs is interpreted as drug failure due to the appearance of drug-resistant mutants. However, responding to a questioner, Larder stated that the presence or absence of mutations have nothing to do with viral load resistance seen in people. This was echoed Tuesday by Philip Furman of Triangle Pharmaceuticals in Durham, NC. Furman said that even a person with multiple inhibitor-resistant mutant HIVs responds to the protease inhibitor combos as determined by a reduction in viral load in the first week. Furman did not explain this curious observation. Later that morning, Jaap Goudsmit of Holland continued the drug resistance story. He began by contradicting the media reports that drug-resistant mutant strains of HIV represent a growing threat. Goudsmit said that inhibitor-resistant mutants are not transmitted from person to person. This was due to the very poor fitness of the mutant virions. In Holland, the appearance of mutant HIV resistant to reverse transcriptase inhibitors peaked in 1995, he said. Goudsmit made the obvious point that with antibiotics, the appearance of drug-resistant strains of bacteria, for example, increase with drug use. It puzzled him that with increased drug use the appearance of drug-resistant mutants of HIV actually declined in Holland. On Tuesday I had an interesting conversation with Chae-Chung Tsai, a pathologist at the University of Washington, Seattle. I learned that T cells pass through the entire lymph system, including all tissues, in 2 hours. At least 85% of T cells reside in the gut. Because of this, he asks, why doesn't AIDS start in the gut? Dr. Tsai works with monkeys in his AIDS research. He said that HIV grows 2 to 3 times as fast in monkey lymphocytes, but monkeys don't get AIDS and do not incorporate HIV proviral DNA. At the evening session on Tuesday the speakers tried to blame the metabolic abnormalities seen in people taking the protease inhibitor combos on HIV. I asked Kathleen Mulligan of UCSF why not treat a bunch of animals with heart-pie combos, and see what happens? The moderator interrupted saying that my suggestion was irrelevant since the animals don't have HIV. That, of course, was precisely the point, to separate the effects of the drugs from HIV. Later a fellow in the audience told me that he was disappointed that my question was not answered. He clearly saw the simple logic behind the proposed experiment. On St. Patrick's Day, our old friend Martin Markowitz of the Aaron Diamond reported on their ongoing study of 27 people still on heart. As in 1997, Markowitz didn't say a word about how those 27 people had been doing over the past 2 years on the drugs. 2 years ago I asked Markowitz if his patients on heart were doing better, the same, or worse while on the drugs. He didn't answer after asking the question 3 times. He knew I was in the audience, but this time I decided not to ask. If his patients had been doing well, I'm sure he would have let us all know, especially me. Wednesday included a discussion of long-term non-progressors, those folks who, in spite of having either antibodies to HIV or HIV RNA, do not get sick after 20 years and longer. Eric Rosenberg of Massachusetts General Hospital said that viral load goes up and down in people whether they take the anti-HIV drugs or not. In people taking the drugs, the therapy is given credit for the reduction in viral load. In long-term non-progressors, the immune system is given the credit for low viral loads or reductions in viral load. Again, Rosenberg admitted without knowing it that the secret to long-term non-progression is not taking the anti-HIV drugs. Thursday, Anthony Japor of Abbott Laboratories cited the 1998 paper by Palala et al. Palala F.J., Delaney K.M., Mormon A.C., et al. Declining morbidity and mortality among patients with advanced human immunodeficiency virus infection. The New England Journal of Medicine, 1998, 338, 13853-860 as the best evidence that heart was responsible for the decline in AIDS deaths. After his talk I pointed out that the paper by Palala was not a report of a clinical trial but was a retrospective survey. He acknowledged that fact. Then I asked him, didn't he think it unusual that he used a survey and not a clinical trial as the best evidence that heart was extending people's lives or at least improving their quality of life? To his credit, after the coffee break he acknowledged to the audience that his earlier reference had been to a survey and not to clinical trial data. Japor made it clear that clinical endpoints are no longer used in clinical trials of anti-HIV drugs. The viral load surrogate is the sole basis for determining clinical efficacy. Drug toxicity is apparently the only clinical outcome that is noted. Current Phase 3 clinical trials are not even blinded, they are open-labeled. Both the physician and the patient know whether they are on the drugs. Robert Yarchone of the NCI admitted that heart has made the process of clinical trial drug evaluations very difficult. He recommends that we go back to extensive clinical trials of monotherapy in drug-naive people. The current process is so complicated that it is virtually impossible to conduct a clinical trial and interpret the results. In other words, we don't know what the clinical trials are telling us. The FDA representative in the audience said that the FDA supports monotherapy on a case-by-case basis. In addition to relating the fiasco of the DDI clinical trials discussed above, Yarchone went into some detail about another tragedy, FIAU. FIAU was supposed to treat hepatitis B and was approved after a short clinical trial. However, after people were taking FIAU for periods just a little longer than the clinical trials, they began dying at alarming rates before the FDA finally pulled the drug off the market. Yarchone admits that the NCI is currently testing AIDS drugs that are likely to have severe toxicity, e.g. EFTA. Jeffrey Murray of the FDA gave a talk on the design of Phase 3 clinical trials. By way of background, normal Phase 3 clinical trials run from 1 to 4 years and cost $30 to $50 million. However, as of 1997, the FDA changed the rules for anti-HIV drug clinical trials. Murray said this change was based on a new knowledge of HIV pathogenesis. Maybe he was referring to David Ho's viral dynamics stuff. Accelerated approval protocol is as follows. 24-week double-blind study, all patients should receive standard of care. He immediately then said this changes by the minute, report viral load proportion below assay limit, show that CD4 cell changes are consistent with viral load, report viral load vs proportion below 400. He said that relying on mean changes in viral load is too limiting. Pediatric clinical trial. 48 weeks based on last patient entered, all should receive standard of care, i.e. AZT, report time to virologic failure, i.e. rise in viral load, report proportion below assay limit, show consistency between CD4 and clinical event. Murray acknowledged that the FDA has not formally validated the HIV viral load assay. Nevertheless, he said that, the time to loss of virologic response, i.e. how long it takes before a rise in viral load, is in a sense a clinical endpoint. He even said that the FDA believes in viral load. That statement gave me the shivers. The FDA should be in the business of evaluating evidence, not beliefs. Murray said that failure is defined as viral load rebound. He also said that active drugs do not arrest symptom progression and certainly does not return the patient to normal. This is probably why Markowitz never talks about how well his 27 patients are doing after 2 years on heart. Regarding safety, Murray said that toxicity studies in humans should last 48 weeks with 300 to 600 people evaluated over 6 months and a smaller number over 1 year. The FDA now asks for metabolism data for all trials. Jules Slevin of NADUP, a gay activist group in New York, told Murray that the community will be watching for the FDA to require metabolic abnormality measurements in clinical trials. During the question period, a guy in the audience proposed that the rise in viral load may not represent drug failure but actually immunological success. He based this twist of viral load interpretation on the rise in CD4 cells in the same patients. Following Murray's talk, William Cameron tore to pieces the viral load mania as I described at the beginning. David Ho's talk was Thursday evening, following the banquet. It was much ado about very little. He reported on 8 selected patients who had been on heart for some time and had no detectable viral load. They took biopsies from a variety of tissues and examined 175 different tissue sections for the presence of replicating HIV. They found 13 sections containing a grand total of 19 cells replicating HIV. I repeat, 19 cells in 8 people. Even if this were true and not an artifact, this number of cells is physiologically irrelevant. A guy in the audience asked Ho how significant were those 19 cells? Ho answered that when heart was stopped that the viral load rebounded, implying that those few cells were responsible for the rebound. Concluding, Ho said that long-term non-progressors have something important to tell us. They certainly do, but not what he wants to hear. Finally, I presented a poster on Tuesday by Peter Duesberg and me on the drugs AIDS hypothesis. Surprisingly, it went quite well. The 18 copies of the AIDS Dilemma paper by Duesberg and me were all taken during the poster session. I only took 18 because I thought hardly anyone there would want to be seen reading it. The 20 copies of my HIV kinetics paper were all gone in 30 minutes. That paper was certainly less threatening and could actually be of use to some of those folks. Some people even came up and asked questions. What amazed me the most was that instead of avoiding me at mealtimes, we all eat together at Gordon conferences. My table was almost always full even though I made a point of being the first to sit down. It just goes to show that things are hard to predict. End of article. The Aids Blunder. By David Rasnick. Mail and Guardian, South Africa, January 24, 01. The contagious, HIV hypothesis of AIDS is the biggest scientific, medical blunder of the 20th century. The evidence is overwhelming that AIDS is not contagious, sexually transmitted, or caused by HIV. I have come to realize that embarrassment is the main obstacle to exposing this simple fact. So why are we barraged, almost daily, by an endless litany of AIDS horrors and HIV statistics? Why do virtually all doctors and public health officials profess their unswerving allegiance to the unproven hypothesis that AIDS is contagious and sexually transmitted when the evidence is greatly against it? There are more than 100,000 doctors and scientists who have built their careers and reputations by simply accepting the articles of faith about AIDS. At this late date, it is simple human embarrassment that is the biggest obstacle to bringing the AIDS insanity to an end. It is the fear of being so obviously and hopelessly wrong about AIDS that keeps lips sealed, the money flowing and AIDS rhetoric spiraling to stratospheric heights of absurdity. The physicians who know or suspect the truth are embarrassed or afraid to admit that the HIV tests are absurd and should be outlawed, and that the anti-HIV drugs are injuring and killing people. We are taught to fear antibodies, and to believe that antibodies to HIV are a harbinger of disease and death 10 years in the future. When you protest this absurdity and point out to healthcare workers that antibodies are the very essence of antiviral immunity, your objections are met with either contempt or embarrassed silence. The National Institutes of Health, the Centers for Disease Control, the Medical Research Council of South Africa, and the World Health Organization are terrorizing hundreds of millions of people around the world by their reckless and absurd policy of equating sex with death. Self-preservation compels these institutions to not only maintain but to actually compound their errors, which adds to the fear, suffering, and misery of the world, the antithesis of their reason for being. The only way we can free ourselves from the AIDS blunder and bring an end to the tyranny of fear is to have an open international discourse and debate on all things AIDS. Anger will be a natural response to facing the enormity of the scandal of AIDS. Anger has its place, but it should be put aside quickly. It is a mistake to focus on villains and on whom to punish. The AIDS blunder is a sociological phenomenon in which we all share a measure of responsibility. Ultimately, the AIDS blunder is not really about AIDS, nor even about health and disease, nor even about science and medicine. The AIDS blunder is about the health of our democracies. A healthy democracy demands that its citizens keep a skeptical, even suspicious, eye on its institutions in order to prevent them from becoming the autonomous, authoritarian regimes they are now. The AIDS blunder shows that we need to rethink and restructure our institutions of government, science, health, academe, journalism, and media. We must replace the National Institutes of Health as the primary gatekeeper of research funding with numerous competing sources of funding. We must restructure the peer review processes of scientific publishing and funding so that they do not promote and protect any particular dogma or fashion of thought or exclude competing ideas. A robust and mean investigative journalism must be revived, rewarded, and cherished. Finally, as citizens we must take back the authority and responsibility for our own health and well-being and that of our democracies. End of article. Time to separate state and science. By David Rasnick. April 2001. Talk given at the International Conference on Science and Democracy, on 20 and April 21, 2001, in Napoli, Italy. Introduction. During my 25 years as a scientist, I have watched science go from being one of the most ennobling and enriching of human activities to being a dangerous and ineffective machine. As a young scientist, I paid attention to how my older and more experienced colleagues went about the business of being a scientist. You could not help seeing the energy, passion, enthusiasm, and just plain joy of being a scientist and putting wonderful questions to each other and nature. The science that I know and remember is, in a word, exhilarating. By its nature, science is one of the most democratic of human activities. But it is a democracy of a special kind. Scientific discourse is not limited to privileged individuals, nations, races, or world views. All scientists are equal participants. Thus, science is democratic in its freedom of thought and activities. But scientists have recognized over the centuries that majority opinion does not determine what is true. Scientists do not vote on what is true. This was more true in the past. As scientists, we accept that what is true is independent of whether we believe it or not. Nature is the ultimate judge of what is true. One of the most important and wonderful consequences of being a scientist is that we can change our minds when the evidence shows that we are wrong. I'm not saying that we do this easily. We fight vigorously for our views but eventually yield to superior argument and evidence. This democratic science was possible when it was the activity of independent individuals. Sadly, democratic science has been replaced by the billion-dollar institutions of government and industrial science. The direct consequence of this shift is that now truth is determined by majority opinion. Institutional science has murdered freedom of thought and discourse. Science is no longer the individual search for enlightenment and understanding but has become an instrument to further the particular goals of government and industry. Like most scientists, I was taught in school that science is a self-correcting activity. All hypotheses, no matter how precious, were put to the grindstone of the scientific process, which was designed to preserve what was true and destroy what was false. But this delicate state of affairs was possible only when science was free or, in fact, when science was broke, before the tragic union of government and science ushered in by the Manhattan Project and the Cold War. Nuclear physicist Ralph E. Lapp, a researcher and advisor on the Manhattan Project, remembers what science was like before the shift. In those days no scientist ventured to ask the federal government for funds. He gathered together what money he needed from private sources or earned extra pay as a consultant to pay for his own research. But mostly he acted as a jack of all trades and built his own equipment. Graduate students were required to take machine shop practice and learn glass blowing. If he needed Geiger counters he made them himself, and he wired his own electronic circuits. Before World War II, research and development funding for the sciences, public and private, amounted to about $250 million per year. Since 1980, U.S. taxpayers have spent more than $93 billion on AIDS alone. And what have those billions bought? A culture of conformity, whereby only HIV research is funded, creating the appearance that all researchers believe HIV is the cause of AIDS. The forced unanimity of thought is not restricted to democracies. In The Rise and Fall of T.D. Lysenko, Russian historian Zhores Medvedev describes the rise to power of an autocratic Soviet pseudoscientist, who over a period of decades corrupted and nearly destroyed Soviet biology and agriculture. Medvedev concludes that monopoly in science by one or another false doctrine, or even by one scientific trend, is an external symptom of some deep-seated sickness of a society. The general acceptance of Lysenko's perverted scientific theories designed to undermine Western science, primarily Darwinism, was heavily promoted by the government-supported media. The peculiarities of the Soviet press, Medvedev writes, made possible popular support for one or another scientific trend selected by the political leadership, and complete suppression of the opposition. Medvedev easily could have been describing the way the public health institutions of the United States have commandeered the AIDS debate. Because the NIH and Dr. Anthony S. Fauci, director of the National Institute of Allergy and Infectious Diseases, control funding of virtually all academic research on AIDS, they can with impunity cut off funds to dissenting voices. Editors of peer-reviewed journals are pressured not to publish papers critical of the HIV hypothesis. Journalists who interview dissenting scientists are denied access to government sources, and accused of acting immorally. The result is a world in which the once cherished process of scientific criticism is treated as social deviance and punished as such. In defending the purchased consensus, HIV researchers use statistical methodologies shown by their inventors to be invalid and conduct experiments without any controls. They take causes for effects, correlations for causations, and constants for variables. Most important, they haven't stopped AIDS. What they have done successfully is instilled fear into human sexual relations, an amorphous fear, which most AIDS professionals as well as journalists argue has been valuable. I doubt even George Orwell could have imagined that an autocratic regime would be able to successfully equate sex with death at the end of the millennium. The AIDS Blunder. George Orwell warned us. He even got the date right. The year 1984 saw the birth of the HIV insanity, complete with technobabble and AIDS speak. The contagious, HIV hypothesis of AIDS is the biggest scientific, medical blunder of the 20th century. Which makes it the biggest embarrassment that the National Institutes of Health, the Centers for Disease Control, the World Health Organization, and hundreds of thousands of individuals who have built their careers and reputations on HIV will have to deal with in the years to come. I have come to realize that the magnitude of this embarrassment is the main obstacle to exposing the simple, clear, and obvious fact that the central axioms of AIDS are false. 1. AIDS is not contagious. 2. AIDS is not sexually transmitted. 3. HIV does not cause AIDS. 4. The anti-HIV drugs are killing people. It may come as a surprise that there is not even one study in the vast scientific, medical literature showing 1. That a group of HIV-positive adults or children live shorter or poorer quality lives than a similar group of adults or children who are HIV-negative, or 2. That a group of HIV-positive adults or children who take the anti-HIV drugs live longer or better quality lives than a similar group of adults or children who are HIV-positive and do not take the drugs. To counteract the natural reaction of utter disbelief, I pose a simple challenge that should undermine your confidence in the central axioms of AIDS. Come up with the name or names of the person or persons who are documented to have shown that HIV causes AIDS, or that AIDS is contagious, or that it is sexually transmitted, or that the anti-HIV drugs actually promote life and health. The task is not to find a list of people who have made these claims. That list is a long one. No, the task is to come up with the names of the people who have produced the evidence that shows those claims to be true or at least likely. I have studied AIDS from the very beginning and I have not been able to find those names or the documents that contain the evidence supporting the axioms of AIDS. In fact, I do not know anyone who has found the names or documents. So why do we read in the newspapers or see on the television every day a growing litany of AIDS horrors and HIV statistics? Why do virtually all doctors and public health officials profess their unswerving allegiance to the dogma of HIV and the axioms of AIDS? The answer is simple once you see it. Advertising is a multi-billion-dollar industry because advertising works. As noted above, since 1980 American taxpayers have spent over $93 billion on AIDS. You can buy almost unanimous support for just about anything with that amount of money. The $93 billion does not include the billions of dollars that the drug companies have spent on their AIDS-targeted products and the billions more in revenues they have pocketed from the sale of those products. By way of comparison, American taxpayers spent $22 billion to put 12 men on the moon. We got our money's worth, we got to the moon. However, we have not yet saved the life of even one AIDS patient with those billions of dollars, and the first success is not in sight. The tens of billions of HIV dollars support the more than 100,000 doctors and scientists who have built their careers and reputations by simply accepting the HIV dogma and the axioms of AIDS. What these 100,000 HIV scientists and doctors have not done with that money, however, is produce the evidence that shows that the AIDS axioms are scientific facts or at least likely to be true. As Peter Duesberg has often said about AIDS funding, they could spend billions to study HIV on the moon if they wanted, but they can't afford $50,000 to prove themselves wrong. If you think big science is devoted to the free exchange of ideas and committed to open debate, you are in for a rude awakening. One thing critics discover very soon is that the high priests of HIV dogma rarely if ever address the specific criticisms of the AIDS axioms. Instead, they do everything possible to silence their critics. Terminating grant support to dissident scientists who question HIV dogma and the axioms of AIDS is the auto da fe of our day. To save their careers, most scientists stop asking embarrassing questions and prostrate themselves before the golden idol of HIV. The courageous, or stubborn, depending on your point of view, few who stick to their principles are forced to scrape up the money any way they can to do their research. Our lab, for example, relies on the generosity of wealthy individuals, private foundations, general donations, and we have even started a company in the hope that it will provide a long-term source of funds for our research. But even if you get the money to do the work, you won't be able to get your results published in American scientific or medical journals, and you will no longer be invited to professional meetings. If you publicly question HIV dogma too loudly, you risk ad hominem attacks and are accused of being a homophobe, or of encouraging people to stop taking AZT and the other DNA chain-terminating drugs, to which I plead guilty, or of causing people to stop using condoms. Since the middle 1980s, the United States has been engaged in a kind of medical McCarthyism, where anyone who asks questions about the HIV dogma is punished as a heretic. Those who are seen talking with a dissident are warned that they risk their careers and reputations if they continue. Even heads of state are not immune to threats and intimidation. South African President Thabo Mbeki continues to receive intense personal attacks because he included on his AIDS advisory panel last year a number of scientists and physicians from around the world who dispute the mainstream dogma of AIDS. Having failed to silence Mbeki, the AIDS establishment has orchestrated an international campaign to portray him as insane because he insists on getting answers to some very simple questions. 1. Why is AIDS in Africa so completely different from AIDS in the USA and Europe? 2. How does a virus know to cause different diseases on different continents? 3. How does a virus know if you are male or female, gay or straight, white or black? Journalists who interview dissidents almost never see their work published or broadcast, they are no longer invited to mainstream meetings, and are vilified by former friends and colleagues. On page 709 of his book Challenges, Serge Lang, the legendary Yale mathematician and member of the National Academy of Sciences, describes his unsuccessful effort to publish his commentary on Richard Horton's, editor of The Lancet, review of Peter Duesberg's book Inventing the AIDS Virus published in the New York Review of Books. Since the New York Review of Books would not publish his commentary, Lang sent a letter to the editor of The Lancet concerning the HIV scandal, but it was turned down. He then sent a check along with his letter to have it published in the advertisement section of the journal. Yielding to Lang's persistence, the editor of The Lancet finally published Lang's letter, in the Letters to the Editor section, and returned his check. There are countless more stories of censorship, intimidation, and financial and professional manipulation. But the discordant data still sits there, indestructible and unresolved. With so many careers dependent on, and billions of dollars invested in, the HIV dogma and the axioms of AIDS, it is easy to see what is at stake. If some or all of the AIDS axioms are false, I'm certain that all of them are false, then we are faced with the biggest blunder of the 20th century. It would require superhuman courage and integrity on the part of numerous government officials and the directors of the National Institutes of Health, the Medical Research Council, the World Health Organization, and the Centers for Disease Control, and of countless physicians, scientists, healthcare workers, journalists, celebrities, and average citizens, to admit that they made a big mistake, that they got it all wrong about AIDS. Many informed critics think that the billions of dollars at stake is the biggest roadblock to ending the AIDS insanity. That money is certainly a formidable weapon in the service of the HIV/AIDS establishment. However, I think it is simple human embarrassment that is the biggest obstacle to bringing this insanity to an end. It is the fear of being so obviously and hopelessly wrong about AIDS that keeps lips sealed, the money flowing and AIDS rhetoric spiraling to stratospheric heights of absurdity. The physicians who know or suspect the truth are embarrassed or afraid to admit that the HIV tests are absurd and should be outlawed, and that the anti-HIV drugs are injuring and killing people. We are taught to fear antibodies, and to believe that antibodies to HIV are a harbinger of disease and death 10 years in the future. When you protest this absurdity and point out to healthcare workers that antibodies are the very essence of antiviral immunity, your objections are met with either contempt or embarrassed silence. The National Institutes of Health, the Centers for Disease Control, the Medical Research Council, and the World Health Organization are terrorizing hundreds of millions of people around the world by their reckless and absurd policy of equating sex with death. Linking sex to death has put these organizations in an impossible situation. It would be intolerably embarrassing for them to admit at this late date that they are wrong, that AIDS is not sexually transmitted. Such an admission could very well destroy these organizations, or at the very least put their future credibility in jeopardy. Self-preservation compels these institutions to not only maintain but to actually compound their errors, which adds to the fear, suffering, and misery of the world, the antithesis of their reason for being. With AIDS, perhaps the most devastating effect of this new anti-science is in the realm of clinical trials. Most drugs that are approved by the FDA must complete 3 phases of human clinical trials: Phase I for toxicity, Phase II for short-term effectiveness, and Phase III, the most vital, for the ultimate measure of morbidity and mortality, that is, whether the drugs actually benefit patients. None of the lauded HIV protease inhibitors approved by the FDA has yet completed a Phase 3 clinical trial. In order to satisfy the requirements for licensing, however, 2 Phase 3 protease inhibitor clinical trials were initiated, a 1,200 patient Boston-centered study and a 3,300 patient trial in Europe. With AZT, only the Europeans kept their study going long enough to see the true results, despite the fierce protestations of activists and healthcare workers. In the end, the so-called Concord study gave us the answer about AZT. Not only did the drug not work, but there was a 25% higher mortality rate among those taking AZT compared to those that didn't. Seligman, M., et.al., 1994. Concord, MRC/ANRS randomized double-blind controlled trial of immediate and deferred zidovudine in symptom-free HIV infection, Lancet 343, 871-881. But the protease inhibitor studies were all stopped well before their designed completion dates. On February 25, 1997, a Boston Globe headline trumpeted, "AIDS trial terminated, 3-drug therapy hailed." The article reported that 63 of the 579 Boston trial subjects receiving 2 drugs had died or developed new AIDS-associated illnesses, while only 33 of the 577 individuals receiving the new 3-drug cocktail had died or gotten sicker. It also mentioned that, as late as mid-January, 1997, a peek at the results of the 2-drug regimens had concluded that they had not yet diverged enough to warrant stopping the study. When the triumphant results were reported, Fauci dramatically announced that the trial had provided evidence that combination treatments including protease inhibitors can reduce the risk of death from AIDS. You don't have to be a scientist to follow the logical difficulties here. It seems highly unlikely that between mid-January 97 and mid-February 97 the data had changed enough to stop the Phase 3 trial. Even the leader of the Boston trial admitted that there was no statistical difference between the deaths in the 2 treatment groups. When the study was concluded, there were 8 deaths among those taking 3 drugs, compared with 18 deaths among those taking 2. Using these mortality figures at face value is like stopping a basketball game in the first quarter as soon as your team is leading and declare victory. As everyone knows, the lead can oscillate back and forth throughout the game. The same is true of clinical trials. In short, we don't know if the combination therapies work to reduce the risk of death, because it has not been proved. So why did Fauci and his allies halt the Phase 3 trial before it yielded statistically significant results? Protease inhibitors were internationally hailed as miracle drugs in 1996, without the benefit of proof. As long as Phase 3 trials were underway, they posed a dangerous uncertainty. A completed trial that resulted in an unsatisfactory result would be difficult to explain away. From the HIV/AIDS establishment's perspective, the safest course of action was to stop the game, declare victory, and hope nobody would call them on it. AIDS research has become a virtual puppet for the titanic, symbiotic forces of industry and government. I recently attended a small, elite conference focusing on the chemotherapy of AIDS, where 43 of the 100 people present were pharmaceutical company representatives who ran to the phones after each session to call in the results. During one session, I asked a leading proponent of cocktail therapies how the patients receiving the cocktails were doing. He said that some were healthy enough to work. Then I asked whether, during the course of therapy, the 20 individuals did better, stayed the same, or got worse. He did not answer. It was an embarrassing moment for the audience. Then I asked, "Your patients should have done better, right?" Again, he was speechless. Even more disturbingly, one presenter suggested that clinical endpoints are dead in Phase 3 trials. In other words, he believes that clinical trials will no longer use morbidity and mortality as endpoints. They will no longer be designed to determine whether drugs actually work. The excuse given for dropping Phase 3 clinical trials is that they are unethical and too costly. We are henceforth supposed to assume that the drugs under evaluation reduce morbidity and mortality before this has actually been demonstrated. To date, there is still no clinical trial that has proved that the protease inhibitors either taken alone or in combination with other antiviral drugs reduce the mortality or improve the quality of life of AIDS patients. The prescience of Alexis de Tocqueville. Alexis de Tocqueville 170 years ago had anticipated the underlying political and sociological basis of the AIDS blunder. Instead of trying to recreate his magnificent achievement, below I quote from his masterpiece Democracy in America. Here is Tocqueville's illuminating analysis of the tyranny of conformity. I do not know any country where, in general, less independence of mind and genuine freedom of discussion reign than in America. In America the majority draws a formidable circle around thought. Inside those limits, the writer is free, but unhappiness awaits him if he dares to leave them. It is not that he has to fear an auto da fe, but he is the butt of mortification of all kinds and of persecutions every day. A political career is closed to him, he has offended the only power that has the capacity to open it up. Everything is refused him, every glory. Before publishing his opinions, he believed he had partisans. It seems to him that he no longer has any now that he has uncovered himself to all, for those who blame him express themselves openly, and those who think like him, without having his courage, keep silent and move away. He yields, he finally bends under the effort of each day and returns to silence as if he felt remorse for having spoken the truth. Chains and executioners are the coarse instruments that tyranny formerly employed, but in our day civilization has perfected even despotism itself, which seemed, indeed, to have nothing more to learn. Princes had so to speak made violence material. Democratic republics in our day have rendered it just as intellectual as the human will that it wants to constrain. Under the absolute government of one alone, despotism struck the body crudely, so as to reach the soul, and the soul, escaping from those blows, rose gloriously above it, but in democratic republics, tyranny does not proceed in this way, it leaves the body and goes straight for the soul. The master no longer says to it, "You shall think as I do or you shall die." He says, "You are free not to think as I do, your life, your goods, everything remains to you, but from this day on, you are a stranger among us. You shall keep your privileges in the city, but they will become useless to you, for if you crave the vote of your fellow citizens, they will not grant it to you, and if you demand only their esteem, they will pretend to refuse it to you. You shall remain among men, but you shall lose your rights of humanity. When you approach those like you, they shall flee from you as being impure, and those who believe in your innocence, even they shall abandon you, for one would flee them in their turn. Go in peace, I leave you your life, but I leave it to you worse than death." The power that dominates in the United States does not intend to be made sport of. The slightest reproach wounds it, the least prickly truth alarms it, and one must praise it from the forms of its language to its most solid virtues. No writer, whatever his renown may be, can escape the obligation of singing the praises of his fellow citizens. The majority, therefore, lives in perpetual adoration of itself. Only foreigners or experience can make certain truths reach the ears of the American. It is true that courtiers in America do not say "Sire" and "Your Majesty," a great and capital difference, but they speak constantly of the natural enlightenment of their master. They do not hold a competition on the question of knowing which one of the virtues of the prince most merits being admired, for they are sure that he possesses all the virtues, without having acquired them, and so to speak without wanting to do so. They do not give him their wives and their daughters so that he may deign to elevate them to the rank of his mistresses, but in sacrificing their opinions to him, they prostitute themselves. Two things are astonishing in the untied states: the great mobility of most human actions and the singular fixity of certain principles. Men move constantly, the human mind seems almost immobile. When once an opinion has extended over the American soil and has taken root, one would say that no power on earth is in a position to extirpate it. In the United States, general doctrines in the matter of religion, of philosophy, of morality, and even of politics do not vary, or at least they are modified only after a hidden and often insensible travail. The coarsest prejudices themselves are effaced only with inconceivable slowness in the midst of this friction of things and men repeated 1,000 times. What struck me in the United States is the trouble one experiences in disabusing the majority of an idea it has conceived and of detaching it from a man whom it adopts. Writings or discourses can scarcely succeed at this, experience alone overcomes it, sometimes it must be repeated. Anyone who knows my friend and colleague Peter Duisberg, and what he has endured and suffered simply because he persists in exercising not only his constitutional rights but also his rights as a human being, can't help but think of him when reading Tocqueville's words. I plagiarize Alexis de Tocqueville shamelessly in the next 3 paragraphs by replacing religion with science, but I hope to honor his genius in the process. As long as a science finds its force in the sentiments, instincts, and passions that one sees reproduced in the same manner in all periods of history, it defies the effort of time, or at least it can only be destroyed by something that is its superior. But when science is slave to a particular fashion of thought or the interests of government and industry, it becomes almost as fragile as all the other powers on earth. Alone, science can hope for immortality, bound to ephemeral powers, it follows their fortune and often falls with the passions of the day that sustains them. In uniting with different political powers, science can therefore contract only an onerous alliance. It does not need their assistance to live, and in serving them it can die. When governments seem so strong and laws so stable, men do not perceive the danger that science can risk by uniting with power. Insofar as a nation takes on a democratic social state, and societies are seen to incline toward republics, it becomes more and more dangerous for science to unite with authority, for the time approaches when power is going to pass from hand to hand, when political theories will succeed one another, when men, laws, and constitutions themselves will disappear or be modified daily, and this lasting not only for a time, but constantly. The late UC Berkeley professor Paul Feyerabend agrees with Tocqueville that the time is overdue for adding the separation of state and science to the by now quite customary separation of state and church. Science is only one of the many instruments people invented to cope with their surroundings. It is not the only one, it is not infallible, and it has become too powerful, too pushy, and too dangerous to be left on its own. Against Method, by Paul Feyerabend, 1993. Verso. Conclusion. Uncovering Watergate now seems trivial compared to what it will take to expose the 16 years of fraud, incompetence, and flagrant lying that have been going on behind a veil of scientific and medical jargon, credentials, and expertise. President Clinton did his bit to thicken the protective fog encasing the AIDS blunder. Last summer he declared AIDS to be a risk to the national security of the United States. That action allowed at least 3 additional federal institutions to play a direct role in maintaining and protecting the fiction of a global AIDS pandemic. These institutions are the Federal Bureau of Investigation, FBI, the Central Intelligence Agency, CIA, and the National Security Agency, NSA. The involvement of the FBI, CIA, and NSA in AIDS represents a far greater threat to our freedoms than to HIV. The most astounding thing to me about all of this is that the greatest threat to our democracies has turned out not to be goose-stepping soldiers in camouflage but rather the chronic fear peddled by white-coated scientists and physicians squandering billions of taxpayers' dollars annually and their sycophants in the media. Ultimately, the AIDS blunder is not really about AIDS, nor even about health and disease, nor even about science and medicine. The AIDS blunder is about the health of our democracies. I think it is highly unlikely that the AIDS blunder could have occurred or been maintained in a healthy democracy where continuous discourse and debate of all important issues is vigorous and healthy, where criticism flourishes and critics are cherished as national treasures. The only way we can free ourselves from the AIDS blunder and bring an end to the tyranny of fear is to have an open international discourse and debate on all aspects of AIDS. We will have to come up with some minimally embarrassing ways to do this, perhaps modeled on South Africa's Truth Commission set up to heal the wounds caused by apartheid. Anger will be a natural response to facing the enormity of the scandal of AIDS. Anger has its place, but it should be put aside quickly. It is a mistake to focus on villains and on whom to punish. The AIDS blunder is a sociological phenomenon in which we all share a measure of responsibility. The AIDS blunder has taught me that a healthy democracy demands that its citizens keep a skeptical, even suspicious, on its institutions in order to prevent them from becoming the autonomous, authoritarian regimes they are now. The Aids Blunder shows that we need to rethink and restructure our institutions of government, science, health, academe, journalism, and media. We must replace the National Institutes of Health as the primary gatekeeper of research funding with numerous competing sources of funding. We must restructure the peer review processes of scientific publishing and funding so that they do not promote and protect any particular dogma or fashion of thought or exclude competing ideas. A robust and mean investigative journalism must be revived, rewarded, and cherished. The Aids Blunder goes to the very core of our democracies. If we continue to be hoodwinked by techno-babble and institutional blather, and allow ourselves to be manipulated by cheap sentimentality and red ribbons, then freedom and democracy will slip through our fingers. Finally, as citizens we must take back the authority and responsibility for our own health and well-being and that of our democracies. David Rasnick, Ph.D. is a visiting scientist, University of California at Berkeley. End of article. How the San Francisco Department of Public Health turns a 30% decline in HIV infections among gay men into a twofold increase. By David Rasnick. May 2002. I have examined a relatively minor study from the San Francisco Department of Public Health, which was carried out in collaboration with the UCSF AIDS Health Project and the Stop AIDS Project. 1. To see if one of its conclusions is consistent with the evidence contained in the Departmenta Euro trademark's own statistics. The March 2002 study states that the fraction of gay men who have antibodies to HIV doubled since 1996, from 2.1% to 4.2%. 1. However, the Health Departmenta Euro trademark's own statistics show that there was actually a decline in new HIV infections. Unfortunately, the abuse of statistics by CATS et.al. is not unique. It is just the latest example of researchers, health officials, and community representatives manipulating their own data to make alarming points. The 4.2% HIV infection rate for gay men at anonymous testing sites in 1999 cited by the researchers is indeed true and can be located in the HIV testing and counseling document, which is compiled and published by the SFDPH, with funding provided by the Centers for Disease Control and Prevention. 2. The HIV Counseling, Testing, Referral, and Partner Counseling and Referral Services, CTR/PCRS, report for 1999 noted that there were 4,118 anonymous visits, and that a total of 2,439 HIV tests were performed, of which 102 were HIV positive, 4.2%. 2. However, in the CTR/PCRS report for 2000, the researchers state that there were 4,526 anonymous visits, and 2,791 tests for antibodies to HIV were administered, of which 83 were HIV positive, 3.0%. 3. So even though there was a surge in the number of visits, up 10%, and the number of tests, up 14%, in 2000, the HIV rate in fact fell significantly, plummeting from 4.2% in 1999 to 3.0% in 2000, while at the same time the blinded HIV rate was not going up. But if you only relied on the CATS et.al. study or news accounts, you would never learn about the drop of the HIV infection rate. Why isn't the drop of the rate of HIV infections acknowledged and discussed? The release of the SFDPH study generated fairly typical stories at gay online media sites. There were no challenges to the allegations being put forward by the CATS et.al. study. The only a community voice in print is from the CDC-funded Stop AIDS project under the headline, A Study, Drug Advances Propel Unsafe Sex that appeared on gay.com February 27, 2002. What evidence does gay.com share with readers to back up the claim by CATS et.al. that unsafe sex is rising? Gay.com offers this. At least one other sexually transmitted disease is on the rise. According to the study, the number of cases of rectal gonorrhea in the city rose from 72 in 1994 to 160 in 1999. The disease generally hits e bottom sa men who are on the receiving end of anal sex. Annual STD statistics are among the easiest things to locate at the SFDPH website, and should be read by all reporters who cover AIDS issues, if only because the Health Department trademark HIV programs are constantly making news. One would expect GAY.com to check out the latest annual STD report for San Francisco, 4, and either verify or debunk the increases of male rectal gonorrhea, and to inform readers of any mitigating reasons behind the upsurge in cases. These critical facts and numbers from the SFDPH annual STD report for 2000 were left out of the GAY.com story. In response to the citywide increases seen in 1996, we began testing more men who have sex with men, MSM, seen at City Clinic for rectal gonorrhea. Much of the increase in cases since 1996 is due to this increased screening. The number of cultures increased from 571 to 1,399, while the proportion of cases found decreased from 8.9% to 8.4%. 4. There was actually a slight reduction in gonorrhea among gay men in San Francisco. The online gay press is also guilty of failing to tell readers its one person quoted as a community representative, Stephen Gibson of the Stop AIDS Project, is an author of the CATS ETAL study, which makes him a guilty party to this faulty research on the sex lives of gay men and HIV rates. Gibson, as expected, does not raise any doubts about the research. San Francisco health officials have an extra special responsibility to be accurate and fully informative on the latest statistics, when they present their numbers in a study, which may have far-reaching influence beyond the City trademark's borders. And gay news outlets, online and in print, should look upon it as a duty to look at every study from the San Francisco Health Department in the larger context of all available data from the department that is at ONI trademark's fingertips on the agency trademark's website. What legitimate reasons could the health department have for concealing a significant drop in HIV infections in gay men at select testing sites? The answer may lie in the minutes from the San Francisco Health Commission trademark's December 18, 2001, meeting. The head of the Health Department trademark's AIDS office presented an annual report to the Commission. According to the minutes, AIDS office budget is more than $78 million, and sources are the General Fund, federal funds and grants, state funds and private foundation grants €5. Thus, there are at least 78 million reasons why the health department may need to be creative with its studies and findings. While it is understandable that the city wants to keep up its AIDS and healthcare budget, the desire for that funding should not be a license to turn a substantial decline in HIV infection among gay men into a twofold increase. End of article. Interview David Rasnick. Out of Africa. By Jean Mahoney. San Francisco Herald, October 2000. Recently, South African President Thabo Mbeki sought out AIDS dissident David Rasnick to offer alternative views regarding his nation's epidemic. Here's an all-too-brief interview I had with the scientist at his Silicon Valley home. Jean Mahoney, so tell us about yourself. David Rasnick, I have a PhD in chemistry from Georgia Tech and I've been in the pharmaceutical industry since 1978. I've developed enzyme inhibitors for tissue-destroying diseases like arthritis, cancer, emphysema, parasitic diseases, and I've studied AIDS for 19 years. I've written about it in technical journals. GM, 19 years ago did you think that HIV caused AIDS? Dr. 19 years ago HIV didn't even exist. It was 16 years ago, in 1984, that HIV was unleashed upon the world, at a press conference by Robert Gallo. Gallo used to be a member of the National Institutes of Health. He was one of the world's leading retrovirologists and he'd been working on the virus cancer hypothesis since the 70s and had to find viruses that caused cancers. He didn't find any. He tried to find something else useful or significant about retroviruses and that led to his claim that a retrovirus caused AIDS. Gallo's retrovirus, as we all know now, is called HIV human immunodeficiency virus. It is no such thing. It does not cause immunodeficiency. If HIV did cause AIDS, it would be one of the smartest viruses you could imagine, because it knows whether you're male or female, gay or straight, white or black. It even knows what zip code you live in and what country you live in. For example, in the United States 8 out of 9 AIDS cases are men. In San Francisco 99 out of 100 are men. 2/3 of AIDS cases in the USA and Europe are gay men. So that's a smart virus, and somehow that virus knows to cause Kaposi's sarcoma in gay men and not in hemophiliacs, not in pediatric AIDS cases, not in blood transfusion or so forth. So it's a very smart virus. You can either accept that, as the HIV establishment does, or you can be a little skeptical, as UC Berkeley retrovirologist Peter Duesberg, and the so-called dissidents are, that maybe that's not quite the cause of AIDS. Peter Duesberg and I are convinced that AIDS in the US and Europe is the clinical manifestation of the drug epidemic in both places. In Africa it's a completely different situation. It's so different that the WHO World Health Organization and other organizations, in 1985, had to come up with a different definition of AIDS in Africa because it didn't look anything like AIDS in the US and Europe. The Bongi definition came from a little town in Africa called Bongi. In fact, I'm pretty sure right now there's no such thing as an AIDS epidemic in Africa, from my previous 2 trips last May and this July. The reason I say that in brief is that we've looked and asked people, the government ministers, we asked the director of the Medical Research Council in South Africa, the Centers for Disease Control in the US, everybody we could ask, what are the numbers of AIDS cases in South Africa and how many AIDS deaths? No answer at all. 0. To this date we do not have an answer to that, and in fact, I don't think there is any such thing as AIDS going on in South Africa. It's just the same old things that Africans have been suffering and dying from for generations due to poverty, malnutrition, poor sanitation, bad water, that sort of thing. We're calling it AIDS now, instead of by the old-fashioned names that were more honest. I think most people don't realize there isn't a disease called AIDS per se, like cancer or leukemia. AIDS is a collection of, what is it up to now? 30 diseases? 30 some odd, depending where you want to go. But even that's very arbitrary, too. It's very arbitrary. There are at least 4 definitions of AIDS in the United States the CDC Centers for Disease Control has come up with, and there's no such thing as an AIDS disease. All of the so-called AIDS-defining diseases are known and old diseases. For example, dementia, diarrhea, Kaposi's sarcoma, cervical cancer, pneumonia, all these sorts of things, are only called AIDS if you have antibodies to HIV, then they're called AIDS. In the absence of those antibodies you have the old name of whatever the disease was. HIV itself has no symptoms. If you get a typical infectious disease like chickenpox, smallpox, or the flu or whatever, the symptoms go hand in hand with the causative agent. You know exactly what it is. The chickenpox virus doesn't cause dementia, it causes the chickenpox. The flu virus doesn't cause cervical cancer, it causes the flu. HIV has no symptoms of its own. Once a person becomes so-called antibody positive to HIV, 10 years down the road they can expect to get diarrhea, dementia, you name it. So this whole idea as AIDS as a disease, there's no such thing. As a matter of fact, the name itself speaks to what it is. It's called acquired immune deficiency syndrome. It means an immune deficiency that is acquired in some way. It is a syndrome. A syndrome is, think of alcoholism. Alcoholism is a syndrome. We know the cause. It's drinking too much. But it can have a spectrum of consequences that aren't necessarily going to show up in each individual. In some people alcoholism affects their central nervous system, some people it affects their liver, they get cirrhosis, some people have gastrointestinal problems. There are all sorts of things that can be a consequence of alcoholism. Generally syndromes are a consequence of some sort of environmental influence, cigarette smoking, alcoholism, that sort of thing. Infectious diseases are typically not syndromes. They're very well defined, and you have very precise symptoms that are attributed to infectious diseases. With syndromes that's not true. Anytime you have a syndrome, it's almost certainly not due to an infectious agent. So that's what AIDS is. It's not a disease, and HIV is an Orwellian deception. It's not an immune deficiency virus. It's just one of thousands of retroviruses. First of all, you can't even find it in a human being. No one has even obtained infectious HIV from a human being. That's why the tests look for antibodies to HIV. HIV itself, at least the proteins of it, are produced in laboratories. For example, they mix a person's blood with those proteins and see if there's a binding reaction of some sort. If there is, depending on its strength or whatever, you're claimed to be HIV positive. Normally an antibody reaction except for AIDS. AIDS is the only exception. If you have antibodies to the so-called putative cause of the disease, whatever it is, then you're considered immune, and you're safe. That's the whole principle of vaccination. That's why you have a little scar on your shoulder from smallpox vaccine. People from around the world are happy to be around you. Because they know that not only are you not likely to get smallpox because you're vaccinated from it, you're also not able to transmit it to other people because you're immune from it. Same is true with the measles, the mumps, and the chicken pox. Once you've ever had it, you're immune to it. And if you were to check for antibodies to that in a person, you would find them, because you are immune to it, and that's a good thing. HIV is the only exception. If you have antibodies to HIV, that is a death sentence. 10 years from now, as I said before, you're going to come down with AIDS-defining diseases and die. Which isn't true. The vast majority of HIV-positive people, well over 90% worldwide, are perfectly healthy. There's only a total of, the WHO reports, a little over 2 million AIDS deaths, total worldwide, and yet they tell us there are over 30-some-odd million HIV-positive people are still alive and living their lives happily on this planet. There's been a big push about giving the people of Africa AIDS drugs. Is there still as much of a push about AIDS drugs in the US as there used to be? Oh yeah. AIDS peaked in the US in 1992, according to the CDC's own publications. We've had 700-some-odd thousand AIDS cases in the US total. That's living and dead. What about HIV positives who are? No, I'm not talking about HIV positives. I'm talking about AIDS cases as documented the past 19 years. Having those diseases. Well, as of 1993 you don't even have to have a disease to be a full-blown AIDS case. You have 2 laboratory tests, fewer than 200 CD4 cells per microliter of blood, and have antibodies to HIV, and have no other symptoms. No indication of illness other than laboratory tests, and you're a full-blown AIDS case. Well over 60% of all new AIDS cases in the USA have no symptoms of the illness, but yet they're full-blown AIDS cases by the 1993 definition. And that's been true for over 50% of the AIDS cases in the past 4 or 5 years, having no symptoms of the disease. So based on whatever criteria the CDC chooses, even that very bizarre 93 definition of including healthy people as full-blown AIDS cases just on the basis of 2 laboratory tests, even including these tens of thousands of healthy people, there is still a grand total of 1 million Americans in 19 years total who are listed as AIDS cases. A little over 700,000 in fact. Curiously, even in Africa the total number of AIDS cases is almost the same as there are in the whole country of the United States, even though they have 2.5 to 3 times our population. I'm talking about AIDS cases, not HIV positives. When you say the same in Africa, are you talking on a per capita basis or actual? No, I'm talking about actual total numbers. The total number of AIDS cases that the WHO has published is under 1 million for the entire continent of Africa in 19 years. There are actually more sick people in the United States than the continent of Africa? There was for a while. About 2 years ago there were more documented AIDS cases in the US than the whole continent of Africa. Yet they have 2.5 to 3 times our population. GM, they can't possibly test every one of those people as being HIV positive in Africa. Do they? Dr. No. GM, do they just assume that they have AIDS? Dr. Yes. They basically assume they have AIDS. But using the Bongi definition, the 1985 definition of AIDS in Africa, it doesn't even require HIV as part of the definition, because they can't afford to do the test anyway, and the test is totally unusable in Africa because of the false positives with hepatitis B, malaria, tuberculosis, which are endemic of sub-Saharan Africa. They use clinical symptoms. There are 4 basic clinical symptoms in the Bongi definition. There's 10% weight loss, there's persistent fever and cough, and diarrhea. That's it. Think about it. I was in the Peace Corps in Papua New Guinea, and I had all of those. That makes me a long-term survivor based on that definition of AIDS. Think of it, in a place like Africa, where you have random poverty, malnutrition, poor sanitation, bad water, and parasitic diseases. Guess what the symptoms are? And tuberculosis, too. Tuberculosis is worldwide. Where you have poverty you have tuberculosis, including the United States and Europe. It's a disease of poverty, brought on by malnutrition. The world's leading cause of immune depression is malnutrition, which is typically due to poverty. Well-fed people who are exposed to TB do not get the disease TB. Anytime you have endemic TB in a society, it's a clear indication of the level of poverty in a society. One of the symptoms of TB is a persistent cough. In 1993 they actually added TB to the 1985 Bongi definition of AIDS. Isn't that interesting? Regular TB, which has been endemic there for how long, is now called AIDS in Africa. GM, the mainstream media is always reporting that dissidents like you and Duisberg have been discredited, but yet I never see them show any evidence of that, and they never interview you, just the HIV establishment doctors. I saw a recent piece on 60 Minutes and it just showed how these doctors were infuriated with you guys. Dr. I'm sure they are infuriated because people call us dangerous, and I agree with them completely. Peter Duisberg, I, and the other dissidents, we are very dangerous people. The question is, dangerous to whom? We're certainly not dangerous to HIV-positive people. We're not dangerous to hemophiliacs. We're not dangerous to Africans. But we are lethally dangerous to the HIV establishment. To the people who are on that $8 billion taxpayer gravy train, in the USA every year that goes to AIDS. The $1.8 billion that goes to the National Institute of Allergy and Infectious Diseases only for HIV research. We're very dangerous to those folks. We're dangerous to the careers and reputations of those 100,000 scientists and physicians who stake their careers and reputations on this bogus contagious HIV hypothesis. We are dangerous to those journalists, politicians, and celebrities who have also attached their names and reputations to this bogus HIV hypothesis. So indeed we are very, very dangerous people, and I admit that. But we haven't killed anybody. As a matter of fact, as a consequence of our work, there are certainly thousands of people who are alive today that would not be alive had they been left alone with the insanity of the HIV hypothesis to drag them down in that spiral of taking the drugs that eventually cause the AIDS diseases. You know, I heard this within this year, that we had been discredited. That was news to me. If we have been discredited, that's all fine and good. All I ask is where and by whom and when were we discredited, so I could go back and see how we were discredited, because it's all news to me. GM, where do you see the whole scenario going? Do you think the media still will be reporting that new AIDS drugs are on the way, etc.? Dr. No, it's over with. It's crumbling from within, just like the former Soviet Union. The foundations are so poor. AIDS attracts probably the poorest quality scientists and physicians you could imagine. I mean, David Ho is below mediocre in his capability. I've met many of these people in the last 2 or 3 years, and there's 1 or 2 I've met that are really top-notch scientists. It's a real pity that they have associated themselves with this stinking mess of HIV. The majority of them I've met are mediocre and below. Usually the higher up they are on the ladder the poorer quality they are. Oh, they're rich, there's no doubt about that. Like Peter Duesberg said, most of his colleagues at Berkeley are now multimillionaires. GM, 10 years it'll be gone? Dr. Oh, 10 years it'll be long gone. It's virtually disappeared in the US. There's almost no interest in it, even in San Francisco. GM, what about the recent news stories about how the epidemic has been exploding in San Francisco now? Dr. That's a sign of how fast it's disappearing. The fact that the AIDS HIV establishment in San Francisco, and other places, have to revive it. It's going away, so they go to these extremes and shoot from the hip and make these bogus statements that were in the newspapers recently about this burst of HIV infections and all that crap. They're lies. AIDS has always been fueled by lies, but now it's just getting more blatant. AIDS is disappearing in the US, that's why Africa is now in the newspapers and it'll be India probably later and maybe China eventually. You know what Texaco did when Texas started drying up? No more oil. They moved east to Saudi Arabia and places like that. The AIDS establishment doesn't want the gravy train to disappear. They're not the brightest people in the world, but they're not crazy. This goes to the heart of our democracy. Our institutions are corrupt. They need to be restructured. The National Institutes of Health, the Centers for Disease Control are both military organizations. They have uniforms and ranks. A lot of people don't know that. They come under the executive branch of government. The president is their ultimate boss. Clinton, this summer, made AIDS a national security issue, which automatically brings in the FBI, the CIA, the NSA, and the Joint Chiefs of Staff. That's the problem when you have a national security issue. You can abrogate civil rights. We haven't felt the ramifications of that yet, but I'm sure we will. GM, ironically, I remember many people, especially liberals like myself back then, being upset that Reagan ignored AIDS and didn't get the government involved enough. Dr. He did ignore it, but he screwed up. When he said something about it was in 1984 at that famous Gallo press conference which got the snowball rolling. It was an election year in 1984. The first 4 years of AIDS were the first 4 years of his administration. He never said a word about AIDS before 1984. Not one. Then there was a gay activist who was paraded around the White House in the late winter. I am convinced that the April press conference was a preemptive strike that was meant to erase AIDS as a campaign issue. A lot of people say it brought it to the fore. I'm convinced it had the opposite intent, to erase it from any importance as a campaign issue. The April press conference was perfect in diffusing AIDS as a potential campaign issue because it said we figured it out, and it was another triumph for American science and medicine because an American discovered what AIDS is and in 2 years we'll have a vaccine for it, which would have made it 1986, 2 years into Reagan's second term. GM, so if you think of it, the Reagan administration came up with. Dr. It did. It invented AIDS. But without thinking about it. It meant to diffuse it and take it off everyone's radar and say we solved it, it's over. As a consequence of that, he set off this avalanche we're now talking about, HIV/AIDS, without meaning to. He didn't mean to do it. It was a consequence of a political initiative by the head of state. GM, quickly sum up the AIDS drug epidemic correlation. Dr. We went from fewer than 10,000 chronic drug users in 1970, heroin, cocaine, amphetamines, etc., to 20 to 25 million in 1989. 2/3 of them were gay men. These guys were using drugs at astronomical levels, the ones who got AIDS, far higher than the heterosexuals who were also using all these crazy drugs. These guys, and IV drug users, which is a euphemism for heterosexual drug users, account for 95% of all AIDS cases. End of article. Articles by Ian Young. The AIDS Cult and its Seroconverts. By Ian Young. Continuum November/December 1996, February/March 1997. Purposely, the 20-something boys, who have never known a sex life without AIDS, fatalistically expose themselves to HIV as a test of ritual manhood. Jack Fritcher, Mapplethorpe, Assault with a Deadly Camera, 1994. Deliver me from blood gatherers, O God, Thou art the God of my health. Book of Common Prayer. At the local gay bars and dance clubs, the raves and fetish nights and AIDS fundraising events, a new style of body ornament is becoming fashionable. Young gay men are beginning to sport tattoos, usually in block letters on the upper arm, that spell out HIV, followed by a minus sign. The idea, of course, is that when you seroconvert, you pay a follow-up visit to your tattooist, who changes your minus to a plus. Simple. The convertible, one-way only, tattoos signal an unsettling phenomenon that is only now beginning to be acknowledged. An astonishing number of young gay men whose sexual activity began only after the implementation of the safe sex and AIDS education programs of the 80s and 90s, are seroconverting, testing positive for HIV, the virus widely believed to cause AIDS. One estimate has it that 1 in 3 20-year-old gay men will be HIV infected or dead of AIDS by the age of 30. Many of them, according to psychologist Walt Odets, not only recognize the possibility of AIDS for themselves, but accept it as a destiny about which they can do very little. A pair of recently published books, Odets' own In the Shadow of the Epidemic, Being HIV Negative in the Age of AIDS, and William I Johnston's HIV Negative, How the Uninfected Are Affected by AIDS, explore this new insouciance about seroconversion and offer some disturbing insights into contemporary attitudes. Odets is a clinical psychologist and psychotherapist. Johnston is the facilitator of a discussion group for gay, HIV-negative men. Working independently, they have amassed considerable evidence of what Odets describes as a psychological epidemic among uninfected gay men. Now in its 15th year, the protracted AIDS crisis has had an impact on everyone in the gay community, uninfected and infected alike. Odets writes that he sees innumerable examples of psychological problems among gay men that 7 years ago would have been unusual and noteworthy, but are now so common that they pass almost without comment. Many gay men are afraid to become close to anyone, as either lover or friend, for fear any intimate involvement will be terminated by early death. As one man put it, "I've never thought about having a relationship for more than a couple of years, because I've never dated anyone who was going to live longer than that." Odets and Johnston's books are the latest additions to a growing body of literature documenting the complex varieties of survivor guilt, now experienced by increasing numbers of uninfected gay men. Both authors discuss the finding that in today's breezy, out-of-the-closet gay ghetto, HIV-negative men tend to be profoundly clinically depressed, anxious, disoriented, hypochondriacal, uncertain about the future, sexually dysfunctional, deeply demoralized and psychically numb. Many abuse alcohol or drugs, and their physicians prescribe them millions of dollars worth of tranquilizers, sleeping pills, antidepressants, and sedatives every year. More and more uninfected men, Odets finds, now live in nearly every detail like a dying man, disoriented, piecemeal, and with no assumption of a future. From his years of intensive talks with friends, patients, and discussion group clients, Odets concludes that this widespread, endemic depression has its origins not only in reactions to the current health crisis, but also in a destructive mix of old developmental problems that have usually begun in childhood. Substance abuse is often chronic, reflecting mood disorders, loneliness and stress. In this, HIV-negative gay men probably differ little from their HIV-positive brothers. We may now be starting to recognize long-standing patterns of psychoimmune disturbance in a second generation of gay men, a generation that has come to sexual awareness during the AIDS era. A few years ago, when conservative commentator William F. Buckley, Jr. suggested that PWAs should all be forcibly tattooed, on the arm and/or the buttocks, for instant recognition, there was widespread disgust at the idea and embarrassment that the apparently urbane Buckley would suggest it. Now, such tattooing is available on a voluntary basis and there is no lack of takers. After a decade of propaganda about safe sex, a sizable cohort of young men becomes eligible every year for HIV and tattoos. Bill Buckley's American Auschwitz theme park is almost here, and no boxcars will be required. One effect of the ubiquitous official warnings about risk behavior and vectors of AIDS transmission is that more and more gay men now believe their body fluids to be dangerous, and define certain behaviors, such as anal sex or oral sex, as unsafe in and of themselves, without regard to whether one of the people involved had HIV. It is common, writes Odets, for gay men now to say that anal sex is unsafe even when practiced by two HIV-negative people. William S. Burroughs is fond of quoting one survey that found most people believe you can get AIDS from anal intercourse, whether or not HIV is present. Anxieties about gayness, and about intimacy, now frequently express themselves as fear of viral contamination, providing an ostensibly rational reason to avoid what has always been problematic. When HIV is identified with feared, and unconsciously desired, homosexual intimacy, the result is a powerful draw toward seroconversion. The uninfected men interviewed in both these books repeatedly express the view that HIV positives live richer, more complex, more authentic lives, get more attention, are better able to take risks, including, significantly, the risk of intimacy, and that only with such risk-taking can life be meaningful and full. This perceived link between HIV-positive status and emotional fulfillment is just one among many factors now propelling gay men toward seroconversion. These pressures emanate from the AIDS establishment's group assumptions about gay men, assumptions which are more and more clearly reflected in the ghettoized gay community itself. And it is the power and diversity of the pressures to seroconvert that constitute the central, disturbing message of both these books. After the Reagan administration pronounced in 1984 that HIV was the sole cause of AIDS, lucrative patents on HIV antibody tests were granted to leading AIDS researchers, and aggressive promotion of HIV antibody testing began. At first, most gay and AIDS advocacy groups considered testing to be dangerous and oppressive. In the mid-80s, people entering the test sites, a term eerily reminiscent of nuclear test sites, often had to make their way through lines of vocal gay demonstrators. Governments and pharmaceutical companies then directed a light dusting of money to selected recipients and the protests died down. Soon a broad consensus developed that testing was a virtue, a civic duty, and the smart thing to do. Testing positive, in the current wisdom, leads to early intervention, by which is meant the administration of large quantities of pharmaceutical products, the so-called antivirals, principally nucleoside analogues, whose devastating side effects often replicate AIDS symptoms. Whether subsequent illnesses are caused by the inevitable progress of the virus, or by a self-fulfilling prophecy is debatable. The quotations and first-person accounts by HIV-negative men in these studies suggest that while an HIV-positive test result was originally looked upon as a calamity, this is no longer always the case. This is partly because some PWAs are learning how to take care of themselves and are living longer, and partly because a growing number of gay men see HIV infection and subsequent AIDS not as something that can or should be avoided, but as, in Johnston's words, something fundamentally linked to gay identity. Certainly it has been represented to them that way. Heterosexuals and lesbians are told, AIDS doesn't discriminate. But gay men have come to perceive it as an inextricable part of their community, their identity, and their future. One female-to-male transsexual told his therapist that his transformation to a gay man would only be complete when he had contracted HIV. I have heard gay men repeat the homophobic joke, "Gay stands for got AIDS yet." In the 70s and early 80s, a ghettoized consumerism, fast food, fast drugs, fast sex, quick fix medicine, was packaged and sold as the gay lifestyle. Now AIDS is increasingly presented as the new gay lifestyle. In the gay community of the 90s, everything revolves around AIDS. This AIDS-centered vision of community life has even encroached on lesbian society. In 1994, after the founder of the British Organisation for Lesbians with HIV, Positive Strength, revealed that her claim to seropositive status was false, AIDS activist Simon Watney spoke of an imaginary epidemic of fantasy AIDS among British lesbians. Lesbian writer Robin Gorna wrote that although there are many gay men who also lie about their HIV status, it seems that some lesbians feel unable to articulate their own issues alongside the horror of AIDS. If you are a young dyke, your identity is all tied up with AIDS, yet it's not your stuff. She added that there was no evidence to suggest lesbian sex poses any significant AIDS risk. Lesbians with AIDS, she said, tend to contract it from drug use and/or sex with men, which she described as still a taboo subject in the lesbian community. In all the fracas about how many lesbians get AIDS, Gorna's remark that many gay men lie about having HIV seems to have been overlooked. Walt Odets draws our attention to the attitude, widespread in the gay community, that only PWAs and HIV positives have a right to express strong feelings. He recalls that when he voiced his concerns about the emotional well-being of HIV-negative gay men, he found it was considered inappropriate for HIV-negatives to experience feelings about their own lives worthy of discussion or worthy of the concern and attention of others. The feelings of those regarded as uninfected are widely felt to be selfish, inappropriate, or simply ridiculous. Often, HIV negatives are even seen as the enemy. One man, on the steering committee of a mental health conference, when told of an HIV-negative discussion group, retorted, "That's like Germans getting together, to congratulate themselves on not being Jewish." Society has never made the well-being of gay men a priority. On the other hand, if you have AIDS or are HIV positive, a range of social services, support groups, medical benefits, and other perks becomes immediately available. Suddenly, attention is paid. Variations of the same phrase crop up again and again in the sentimental AIDS literature. "I never knew how much I was loved until I got AIDS." It makes a great ad slogan, if AIDS is what you're selling. In the urban gay ghettos of the 80s and 90s, a whole AIDS culture has emerged, an AIDS community based on an ever-shifting melange of medical and subcultural assumptions. This new blood brotherhood is beginning to form a kind of inner order within the exoteric conglomeration of the lesbian and gay scene, and a growing number of glossy magazines now devote themselves to the perks and pleasures of the positive lifestyle. And one comes out into this lifestyle in one way only, by seroconverting. Seroconversion is the ritual that all who would join the cult must endure. Those who have lost friends, or, especially, one or more lovers, to AIDS may claim honorary membership. The cult's unofficial badge of honor is a looped red ribbon, usually pinned to the chest, or rather to the coat. Originally a fundraising favor, the red ribbon is now commercially available in many stylish designer forms. One can choose from ceramic, dyed leather, or 24-karat gold encrusted with red stones. Elizabeth Taylor is one of the few who can afford a diamond and ruby ribbon. Of course, fashion is fickle and the red ribbon is already coming to be regarded as somewhat passé, not to say kitsch. Under the pressure of protracted crisis, the transformation of signals, policies, and identities has been relentless. In the 80s and early 90s, the figure of the AIDS activist, the seething ACT-UP clone, body pumped under the white political t-shirt, head shaved, concentration camp style, became, for a while, a symbol of erotic resonance, a sexual icon. Having exhausted itself in unfocused anger, the fashion is less popular now than it was. The ongoing roster of AIDS dead, lots of blank space left on that memorial, how thoughtful, constitutes the raison d'etre of this new, prototypically postmodern, community. Obituaries and funerals are its social glue, its chief dramatic form is the memorial service. Every 2 weeks, when the new issue of Extra comes out, everyone turns to the obituaries first. The Toronto version of this Canadian gay newspaper Combine, for it has cloned itself, publishes an annual roster of AIDS dead, under the banner headline Proud Lives. Deaths from non-AIDS related causes are relegated to a separate, less prominent, section bearing the mundane and rather dismissive tag, Other Losses. HIV-positive decedents are sometimes placed in the Proud Lives section, even if they committed suicide or fell off a mountain. If you're positive, there's only one way to die, and we're going to hold you to it. The overshadowing of all other gay issues by the AIDS agenda, first pointed out by Daryl Yates Rist, and the frequent dismissal of HIV-negative concerns, has generated widespread feelings of disenfranchisement among uninfected gay men. These feelings are reinforced when the uninfected are told to behave as if they were infected, be good, have safe sex even if they are in a monogamous relationship with an uninfected partner. Walt Odets suggests that these injunctions have been ineffective in promoting safer sex, as well as psychologically disastrous. Within the urban gay community, the uninfected now constitute what William Johnston calls a psychic minority, one that appears increasingly eager to think positive and join the psychic majority, the HIV community. Though it would have been inconceivable only a few years ago, a positive HIV antibody test result, or even an AIDS diagnosis, now frequently results in a decrease in anxiety. The director of one health service agency reports that crisis responses requiring urgent counseling were generated by negative test results at a 3-to-1 margin over positive ones. Among the responses to being told of a negative test result, "All my friends are positive, how can I relate to them? Everyone's going to be very angry at me. I feel like I'm being left out of the great event of our time. I hoped I would be positive so it would give me an excuse to go back out and drink and drug. I feel as if I won't really have come out until I'm HIV positive. It's a lot simpler to think about AIDS than about being gay. Guys who get AIDS get a lot more attention. And, my own favorite, shit. I'm going to have to go to work tomorrow after all." One gay man told me recently that when he revealed to an acquaintance that he was HIV negative, he received the sneering, presumably rhetorical, reply, "How come? Didn't anyone want your tired old ass?" A gay student, who was relieved at his negative test results, nevertheless made a wryly revealing comment about the whole process and everyone's attitudes to it. "For once," he said, "I was glad I failed a test." One contributor to Johnston's book describes a gay man who eventually seroconverted after many attempts. He had a beatific glow on his face when he found out he was positive. He had been expecting this for so long, and finally the desired outcome was achieved. His lover, he feared, was about to dump him if he remained stubbornly negative. This new attitude, utterly unforeseen by the pundits of AIDS education or its consumers, leads Odets to ask whether counselors unconsciously suggest that a positive test result is more important than a negative one. The language used suggests they do. Certainly they focus almost exclusively on preparing their clients for positive results. The man with the beatific glow is one of a growing group of gay men who see their progress, this is the official term, to seroconversion and to AIDS as somehow desirable or inevitable. In scientific circles, HIV positives who remain healthy are referred to as non-progressors. For the burgeoning cohort of seroconverts, the assumption of HIV positive identity has become an important rite of passage in their lives as gay men. A beatific glow is a characteristic feature of religious conversion experiences, and in many ways, these men resemble the freshly inducted members of a cult. There is a growing perception that for a gay man today to be HIV positive is, well, positive. Connotations as fundamental as those suggested by the words positive and negative are deeply embedded in our interpretations of the terminology we use. People do not easily transpose black and white, or accept a positive result as negative. Nor can the frequent use of the word status be considered inconsequential. We are lectured about our antibody status, the subliminal suggestion being that testing positive, becoming body positive, and adopting a positive attitude involves gaining a positive status, becoming worthy of concern. 1. The phenomena of the courageous, positive seroconvert and his neurotic, negative twin have evolved out of the bizarre, dogmatic logic of HIV fundamentalism, what Walt Odets calls the contradictions, inconsistencies, and anomalies of AIDS. Odets writes that a return to unprotected sex among gay men after about 1988 is now widely recognized. Why in 1988, 4 years after the announcement of HIV as the cause of AIDS? My own experience from periodic visits to New York City, an AIDS epicenter, is that the years 1987 to 1988 constituted the height of what the novelist Andrew Holleran has succinctly called the fear Christopher Street was emptier than it has ever been, and many gay men were afraid even to kiss. Protracted, inhibited grief and paralyzing terror seemed, even to a visitor, to be causing all sorts of neuroses and a kind of mass mental breakdown. If the return to unprotected sex began in the late 80s as Odets believes, it may well have begun as a reactive symptom of that breakdown, an heroic defiance of fear by stoically embracing what was believed to be inevitable. As the AIDS crisis was about to begin, the poet and novelist George Whitmore wrote that we engaged in so many of our rebellious acts, like crawling around on all fours on the floor of the mine shaft at 4 in the morning, or participating in the dangerous sexual scenes that had become so popular, to show that we could do these things without flinching, that we were not, after all, sissies. John Ricci endowed sexually promiscuous gay men with heroic qualities, calling them the shock troops of the sexual revolution. Is the same defensive need to prove one's masculinity, one's courage, and one's in-group status now helping to create the phenomenon of the seroconvert? Survivor guilt often involves the feeling that one should not have survived, and the hope that one will not survive. The urban gay lifestyle is designed for youth, and for those committed to that lifestyle, the loss of youth may seem more terrible than a fatal illness. Michelangelo Signorile wrote in a recent column, too, that far too many gay men say they actually fear growing old in a gay world that puts the young and buffed on a pedestal while treating the over 35 crowd like lepers. He tells of one young guy who has unsafe sex because he doesn't want to live to be 50. He doesn't want to be another aging queen, being jeered at by people like himself. Another man said he felt so beneath the men he was attracted to that he'd do anything for them, including have unsafe sex. Walt Odets concludes that for some, the self-destructive aspects of unprotected sex are important incentives to practice it. This, he emphasizes, has nothing to do with complacency, nor will traditional AIDS education address it. The AIDS system now entrenched in the urban gay ghettos has aggressively promoted HIV antibody testing, the AIDS test, and most available AIDS education has been oriented toward encouraging people, particularly gay men, to get tested. Former presidential candidate Bruce Babbitt described the system as a voodoo health policy animated by the idea that if we keep sticking needles into people and taking blood tests, the disease will go away. The apparent non sequitur only begins to make sense if, unconsciously, it is not so much the disease but the seropositives who are being wished away, with the AIDS system constructed as a wish fulfillment around the group fantasy, and camouflaged as medical services. There are two ways to find out. Read a slogan on the outside of an envelope one gay man received in the mail: you can get tested. Or you can get sick. Even though AIDS was nowhere mentioned, he knew right away what this cryptic message meant. It felt, he said, like an assault. The letter was from Project Inform, a group that began as a dissident AIDS advocacy group and devolved into what one commentator called a power broker, coordinating sections of the AIDS industry with the appropriate government agencies. In a letter to the gay paper, the San Francisco Sentinel, one reader described Project Inform as a pharmaceutical pimp. Extensive sections of Johnston's HIV negative are contributed by various uninfected gay men, some identified, others using pseudonyms. And Odets' book, the more analytic of the two, contains many briefer quotes drawn from the author's extensive counseling experience. Among the remarks, negative men are like my family, they have no feelings. What I know is that I am going to follow my heart, and I think it's leading me to the kind of understanding that having HIV gives a person. They will have a cure for it by the time we get it. Another remark I have heard repeatedly is, if I test positive, I can start taking care of myself. There is a common feeling that to try to stay negative, to struggle to stay negative, as one man put it, is simply too difficult, too destructive of any joy in life. This is hardly surprising when the rules of safe behavior are at once so stringent and so slippery. Is oral sex safe? Is rimming with a dental dam okay, and if it is, why should we want to do it? Should I worry about that sharp pizza crust that might cut my lip and let the virus in? Am I condemned to stay around and watch all my friends die? In the shadow of such conundrums, becoming positive seems to some like a doorway to intimacy, light, and love, and life with AIDS, for all its horrors, begins to appear more rewarding, or just simpler, than life without it. Whatever the respective merits of these questions, the mental soil in which they grow is fertile ground for a positive choice. Eric Roefs of the National Gay and Lesbian Task Force, who provides an introduction to HIV-negative, describes himself and other uninfected gay men, the population of supposed survivors, as people left to walk the earth like robots or zombies, telling ourselves and others that everything's fine while we are actually numb, cut off from our emotions. This contrasts vividly with the dark, vampiric glamour of AIDS. Walt Odets refers to the appeal of illness. All these attitudes fuel the desire to seroconvert. Another common observation made of HIV testing is that testees often doubt or question their negative results, but seldom their positive ones. The psychologist Rachel Scochet found that the more bereavements men had experienced, the more they tended to doubt their own negative status, and the more they engaged in unprotected sex. This doubting of negative results is built into the administration of the testing system itself. Positive results, we are told, falsely, are never wrong, but negative results may be premature or false negatives, or unreflective of the virus' supposed window of opportunity. And so when we test negative, we are encouraged to restrain our relief, and to return regularly to the test site. If we did not keep coming back like a yo-yo, presumably we would snap our strings and go careening off, cavalierly spreading HIV around, to ourselves or to others, typhoid Mary off on a bender. In fact, the AIDS system, by failing to support thoughtful self-knowledge, and by subliminally suggesting that a positive outcome is inevitable and desirable, encourages the very behavior it ostensibly seeks to prevent. The constant state of anxiety it instills damages both the mental faculties and the immune system. The HIV antibody test, usually called the HIV test or the AIDS test, is surrounded by an enormous amount of stress, with unfortunate immunological consequences. Paul Fielding, a pseudonymous gay man quoted by Johnston, makes the point, you weren't supposed to have stress, because stress could destroy your T cells. So you had to try to smile living in a pressure cooker. Warnings about risk groups and risk behaviors strike a profoundly ambiguous note in a society where risk is associated with entrepreneurial behavior, glamorous chance-taking, and competition, and is highly valued. Risking danger has always provided a test of manhood for rebellious youth. Practicing unsafe sex is a challenge, a way of accepting a dare, a contemporary version of the chicken run depicted in Rebel Without a Cause. The French writer Hervé Guibert wrote of his lover Musil, who routinely visited the baths for sex, in spite of his poor health. Musil remarked that, "The baths have never been more popular, and now they're fantastic. The danger lurking everywhere has created new complicities, new tenderness, new solidarities. Before, no one ever said a word, now we talk to one another. We all know exactly why we're there." 3. The danger lurking is of course the demonized AIDS virus, whose alleged propensity for lurking, hiding, and other clever behavior is said to explain the many cases of HIV-negative AIDS. And the men are there to live dangerously. Pervasive pressure to seroconvert has produced the phenomenon of the compulsive repeat tester, the uninfected individual who is caught on a testing treadmill, making frequent visits to a test site, or to several test sites, is it a good lab, and always doubting negative results. Johnston discusses an attempt in Boston to start a discussion group for such compulsive retesters. The group didn't work, because they all wanted individual attention. They didn't want their story to compete with anybody else's, because their story was the most important. A compulsive need for attention is easily met by the ministrations of the AIDS industry, which is set up to provide all the attention needed, once seroconversion is achieved. The compulsive retester is a seroconvert in the making. The much vaunted safe sex and AIDS education programs of the 80s and 90s have been a spectacular failure. They are as counterproductive as the campaign against unmarried teenage pregnancies in the Black community, and for the same reason, the underlying causes of the phenomena remain unaddressed. In my own city, Toronto, promiscuous unsafe sex is a popular feature of the bathhouses which have been springing up again over the past few years. Some of them are now licensed to sell beer, which they supplement, unofficially, with poppers and crack cocaine, smoke it in your room, as additional perks. Here too, the rate of seroconversion among young men, and subsequent entry into the ramshackle labyrinth of the AIDS system, is climbing. An extras obituary column isn't getting any smaller. It is becoming apparent that the actual consequences of the AIDS system are at variance with its stated aims. There are unconscious factors at play here, unidentified, even unacknowledged. As Eric Rofe says in his foreword, something is happening to us which no one wants to face. Odets explains how the AIDS system's current approach to prevention is modeled on a public health/social marketing model composed of relentless propaganda, information and education, and the utilization of what he delicately describes as selected community leaders to mold group behavior. Complex psychosocial issues are avoided, feelings about sex and death, personal worth, goals, intimacy, and human needs remain for the most part unexplored outside a relatively few independent therapy groups. Its simplistic strategy is based on the assumptions that sex for gay men is merely a mechanical procedure without human meaning, and that immune suppression can be contracted only through intimate contact with the blood or semen of an infected partner. Public concerns about saliva, tears, and sweat are occasionally expressed, but so far have been fairly successfully dismissed. 4. The nature of the relationship of HIV to AIDS has been a subject of fierce dispute. Though the debate has been rather one-sided, the skeptics, who include a scattering of scientists and 3 Nobel Prize winners, present detailed critiques, which the HIV fundamentalists either ignore or respond to with abuse. 5. If, as seems increasingly likely, HIV turns out not to be the sole cause of AIDS, every AIDS education program on the continent will have to be rethought from the ground up, and some people might even be deaning out their desks. Naturally, critiques of HIV dogma are vehemently resisted by the growing army of HIV support staff. The question of how positive results are achieved seems equally problematic. HIV-positive test results have frequently registered in individuals who have been exposed to certain other pathogens such as malaria, or who have suffered a recent bout of influenza. The current tests, it seems, are not as specific as they might be. A groundbreaking paper from Australia, published in Biotechnology in June of 1993, demonstrated that the favored AIDS tests fail 3 basic criteria: they are not specific, there is no standard interpretation, and their results are not reproducible. 6. In addition, several series of research experiments have shown that under certain conditions, lab animals may develop antibodies to parts of HIV without ever having been in contact with the virus. When some animals in a group were exposed to viruses and developed antibodies, other, unexposed, animals in the same cohort also began to test positive. 7. Could gay men, too, be developing antibody-positive status in resonance with already infected members of their cohort? If so, it might help to explain the increasing number of anomalous seroconversions now being reported. The issue of drugs, both legal and illegal, provides another example of poorly examined assumptions generating a dangerously simplistic approach. Official AIDS education literature almost always warns that recreational drugs may impair judgment and so lead to unsafe sex, but the health risks and immunosuppressive qualities of many drugs are seldom mentioned. In the absence of community-based programs to counter heroin use, we are simply urged to bleach, and never share, the hygienically wrapped needles distributed by AIDS organizations. Many physicians regard drugs and alcohol as coping mechanisms and sanction their abuse by gay patients, negative and positive. Kicking a drinking or drug habit, like giving up promiscuous sex, is seen as a near impossibility for gay men, and substance abuse programs, particularly if peer-run, are often regarded as threatening to the doctor-patient relationship. The version of public health marketing that has come to dominate AIDS education is patterned on a model for the treatment of addictive/compulsive disorders. This is hardly surprising, as the medical establishment has traditionally assumed that gay men necessarily regard sex as a mechanical process without deeper meaning. Educational proposals that attempt to address spiritual matters are dismissed as unrealistic. Inquiry into the reasons for addictive/compulsive behavior would entail an examination of socio-economic pressures, motivations, and group beliefs, and is usually ruled out as too difficult, too dangerous, or too expensive. We encourage what we assume. The current AIDS system fosters the addictive/compulsive psychology that social beliefs ascribe to gay men. Group behavior is then played out according to social expectations, alternating between two phases representing control and release. The compulsive, control phase involves strict abstinence or avoidance, in this case, rigid adherence to the proclaimed principles of safe sex, which are presented as unclear, yet essential, even when there is no apparent reason for them, as with sex between negative partners. This attitude generates tension, confusion, demoralization, and suspicion. In the second, addictive, release phase, the restrictive psychic controls become too stressful and collapse into a slip or binge, involving deliberate self-exposure to HIV and other pathogens, often under the influence of immunosuppressive substances and mental states. Attempts are made to prevent, minimize, postpone, or substitute for the release phase. But such simplistic attempts at enforcing control, whether by propaganda or legal injunctions, rarely work, and when they fail, guilt feelings are reinforced. The notorious failure of most diet plans provides a typical example. One of Odette's most astute insights is that social organizations often act as containers for forbidden feelings. Shared, organizationally approved feelings are substituted for genuine ones, emotional impoverishment is masked, and anger repressed. Rather than encouraging thoughtfulness and understanding on the part of gay men, current AIDS education programs have insisted on politically correct scripts, placing us in the familiar role of dependent children. Odette sees HIV-positive gay men as allowing themselves to be cast in the role of the needy child in a family, with HIV-negative men assuming the role of the resentful, needless child, desperate for his share of attention from parental figures. If the sick sibling is perceived as getting all the attention, one solution is to become sick oneself. The metaphor of gay men as children or perpetual juveniles has been common and pervasive, even gay protesters have adopted it. Acting up is, after all, what children do to get attention. 8. And there is something else going on here. The growing ranks of seroconverts are approaching the seroconversion process as an opportunity for something that young men, and especially young gay men, in our society, desperately need, an initiatory rite of passage. Our society's ideology is a consumerist one, and its rituals tend to be the vapid pseudo-activities of consumerism: shopping, smoking, television watching, package holidays. But rites of passage, coming of age, for example, demand a special kind of ritual to mark the transition from one psychological and social state to another. Apart from the melancholy duties of draft and voter registration, the only such rituals now generally available to young men involve the acquisition of a driver's license and a first car, either purchased or stolen. Rites of passage signal the ritual death of the old self and a symbolic rebirth into a new identity, accepted and honored by the community. For young gay men, coming out once served this function, but as secrecy about being gay has lessened and sexual categories are blurring, coming out has become less meaningful and unsettlingly inconclusive. For the most part, significant gay rites of passage have simply been unavailable. Instead, we are offered rituals of addiction and compulsion, which we adopt as our own. Seroconversion fits the need for a gay rite of passage in the 90s. Journalist and AIDS dissident Celia Farber has aptly called HIV a demon, which we worship with our terror and attempt to placate with buildings, organizations, conferences, and global programs. No such cult can continue for over a decade without developing its own forms of ritual obeisance, and the AIDS system has proved to be no exception. The HIV testing ceremony is highly ritualized, demanding a visit to a special, rather fearsome place, a sacred place, the test site, with priests and acolytes in attendance, the various physicians, psychiatrists, social workers, peer counselors, and AIDS workers hovering or bustling about, many wearing their white robes of office. The ceremony involves a literal blood sacrifice, drawn with a hypodermic needle by a nurse or paramedic. Some initiates faint. It is accompanied by highly structured readings from sacred texts, AIDS education and safe sex scripts. It incorporates a time of trial, the stressful period of several days or weeks involved in waiting for one's results. During this time, one's thoughts are concentrated almost continuously on HIV as the shared object of fear and devotion. And, if the test is passed, if the results are positive, one is embraced into the community with new status, HIV positive status, and increased attention. One enters the AIDS system, the AIDS community. The very way we look at the phenomenon of AIDS has its psychological consequences. Belief in HIV as the cause of AIDS has led not only to a vast, self-perpetuating AIDS industry, but to the establishment of a medico-religious cult. A recent issue of a Canadian gay magazine contained a news item about a Toronto gay man, Sean Martin, who had been diagnosed as HIV positive. A year later, a second test reversed the verdict, and Martin is quoted as saying that though the HIV positive friends he had made were very nice to me about it, telling them he was negative was one of the toughest things he'd ever done. He couldn't help feeling that he was abandoning them, he said, and his new status made him feel he was breaking the faith. In his classic study of modern initiatory behaviors, the psychologist Luigi Zoja writes, the archetypal need to transcend one's present state at any cost, is especially strong in those who find themselves in a state of meaninglessness, lacking both a sense of identity and a precise social role. 10. This description would appear to fit many of the men interviewed in Odette's and Johnson's books. It is particularly applicable to seroconverts. The gay health crisis has reached a stage in which seroconversion is becoming institutionalized as the most important rite of passage in the life of a gay man. Significantly, its place in consumer society is a paradoxical one. The seroconvert, the young gay man who chooses positive and adopts the positive lifestyle is, like the drug addict, someone who participates in the social ritual, but denies the dominant social imperative, to be a responsible economic being. His positive status gives him the permission and the means to solve one of the perennial problems of youth, how to conform and rebel at the same time. In his consideration of drugs and ritual, Zoja points out that in our society, the addict is not absent from the economic picture, but rather present in a destructive way. The seroconvert is also motivated to be present in a destructive way. He drops out of the workaday world to live on disability or viatical benefits, income predicated on the assumption, the tacit agreement, that he will soon die. And after he progresses to full-blown AIDS he is even more present in a destructive way. 11. This suicide by degrees, abetted by so many forces, is the latest manifestation of the idea of the homosexual as sacrificial victim, unconsciously embodying remnants of ancient themes of ritual sacrifice. The sacrificial victim has finally become aware of his role, but not yet able to slough it off, has begun to accede to it with some degree of deliberation. The seroconvert sets out to prove himself worthy of the sacrificial ritual, the testing, that he undergoes. This quest exemplifies what Zoja calls the negative sacrifice, where only the destructive part of the act survives, and which is carried out by that person we call a negative hero. Of course, there is a positive side as well. The afflicted homosexual also becomes a cross-carrier, taking onto himself a complex of rejected and projected group feelings, fears, and impulses. With his death, all these are, temporarily, exorcised. In the classic pattern of initiation, desire for the death of the old self is followed by symbolic rebirth and the welcoming of the new self into the community of initiated peers. In the self-sacrifice of the seroconvert, this process is inverted. The old, negative self, rather than being overcome and sloughed off, is incorporated, with all its negativity, into the new self, who, instead of being enriched with new life, assumes new burdens of guilt and early death, burdens which novels, movies, and folklore have long projected onto the figure of the homosexual. Seroconversion induces both the expectation of a short life and the feeling that one's desirability as a lover is diminished. It is a combination that frequently leads to the feeling, I'm dying and no one will want me, so I may as well party with whatever short time I have left. And so the party becomes a dance of death. In his book The Savage Garden, the novelist and diarist Paul Reed muses that many of his friends have resumed a life that is in many ways similar to the life we pursued a decade ago, the gym, an afternoon rest, the clubs. The difference is that we now no longer work to pay the bills, we simply collect our disability checks. And we no longer feel that this is the beginning of a hot, fast life. It may be the last party, the final fling. 12. In the 90s, that final, AIDS-related fling has become both a phobia and a macabre obsession. One gay club in Manhattan recently hosted a creepy and popular new event called Resurrection, which consisted of a go-go boy feigning death in a pseudo-Victorian setting while horny revelers circled him and felt him up. Tres fin de siècle. It is becoming painfully evident that the AIDS establishment's overt admonition to gay men to stay healthy is proving less effective than its subliminal inducements to seroconvert, and enter a system predicated on early death. Old assumptions about the homosexual's social status as scapegoat and victim are easily assimilated by the victim culture of the 90s, which encourages troubled individuals to seek relief from their problems by adopting the role of irresponsible victim, conferred by illness, addiction, or past abuse. It is curious that the authors of both these studies apparently adhere to the belief that, in Odette's words, a quirk of nature and timing has brought this epidemic to gay communities. One can only wonder which epidemic is being referred to. AIDS? Or the psychological epidemic that has grown up alongside it? Or are these concurrent epidemics merely aspects of the same overall pattern of psychoimmune disturbance, with the same underlying psychic, socio-economic, and environmental causes? The health crisis in the gay community did not begin with the onset of AIDS in 1981, it was preceded by many years of psychological disturbance and chronic depression, reactions to a homophobia that was endemic and corrosive. In the 70s, the already high instance of alcoholism and venereal disease among gay men was compounded by epidemics of drug abuse, hepatitis, and intestinal parasites. By the first notices of what would come to be called AIDS, the immune systems of most men living the gay lifestyle had already been severely compromised. In the early 90s, the psychohistorian, medical researcher, and AIDS activist Casper Schmidt described a shared sequence of psychoimmunological events in the gay men who developed AIDS. Their immune disturbances, he found, began with chronic depression, rooted in childhood unhappiness and related to socially induced guilt, internalized homophobia, and a protracted fight-or-flight syndrome. As these feelings somatized into the body, the result was a chronically increased level of cortisol production, a steady depletion of T cells, frantic overproduction of antibodies, and eventual immune collapse. The evidence presented by Johnston and Odette suggests a continuation of this pattern, with the ominous difference that now, with the phenomenon of the seroconvert, gay men's identification of illness and early death as their destiny has moved more fully into group consciousness. Accepting the subliminal logic of HIV fundamentalism, gay men are beginning to see seroconversion and entry into the AIDS system as a gesture of solidarity with their fellows, a rite of passage, and a political act. It is unlikely that anyone with a strong sense of self-worth would deliberately seek to seroconvert. But for a gay man who has internalized the negative judgments placed on him by family and society, it may well be a lot simpler to think about having AIDS than about being gay. The film Interview with the Vampire, a work replete with coded references to a variety of contemporary fears, euthanasia, AIDS, immigration, gay families, contains the telling line, "If you think you deserve to die and you don't kill yourself, that makes you evil." To many, the evil of AIDS seems preferable to the perceived evil of living as a homosexual. AIDS itself may be horrible, but contracting AIDS is a relatively easy, and pleasurable, form of suicide. AIDS today is not what it was in the early 80s when the term was coined to avoid the embarrassing acronym GRID, gay-related immune disorder. The definition has changed. Illnesses which were once considered key AIDS symptoms are now excluded if HIV is discovered not to be present. Even the official record now lists well over 4,000 such cases. Pelvic inflammatory disorder in women may now result in an AIDS diagnosis if HIV is shown or assumed to be present. T-cell counts, ignored in the early years of AIDS, are now combined with the ever-changing list of disorders to produce diagnoses on a 1 from column A, 2 from column B basis. Pneumocystis carinii, long considered a protozoan, is now acknowledged to be a fungus. Consensus is growing that Kaposi's sarcoma, once regarded as a hallmark of AIDS in gay men, is not caused by HIV, and investigations into a suspected KS virus are underway. 13. The most popular AIDS drug, AZT, has been discredited, and physicians are reduced to offering their HIV-positive patients the experimental drug, or cocktail, of the moment on a try it, you might like it basis. Many of these drugs are highly toxic, especially when combined, and their side effects read like a list of AIDS symptoms. In short, things are a mess. Meanwhile, the AIDS conveyor belt rolls on, providing employment for an ever-increasing army of support personnel. And every week, the roll of sick and dying young men grows longer. 14. Gay men have long served as repositories for a complex of group fears and fantasies about sex, sickness, and death. Psychohistorian Lloyd Demouse has drawn attention to society's periodic killing off of its own ID representatives, its youth, who represent itself in the life phase when it was most sexual and most aggressive. 15. In the past, this filicidal syndrome has usually been acted out through war. The frequent employment of war metaphors in AIDS literature of all kinds suggests that in the 80s and 90s, AIDS is taking the place of war, or has become a new kind of war. Under the veneer of a compassionate liberalism, psychobiochemical assault is being inflicted on gay men, not as a conscious intention, but as the result of policies predicated on certain unconsciously held ideas. It is time to rethink this crisis, to begin to understand how we might extricate ourselves from the nightmare that has overtaken us, and enveloped us now for almost 2 decades. We will not understand the phenomenon of the seroconvert until we begin to investigate the destructive hold of unconscious belief systems in which we all participate. Until then, all the AIDS education and safe sex information in the world will not prevent new cohorts of young men from summoning up their courage and heading from the test site to the tattoo parlor to take up their cross *. Ian Young was born in London. His involvement on the gay movement as activist, writer, and publisher began in the 1960s. His books include the groundbreaking gay psychohistory The Stonewall Experiment, as well as poetry, literary anthologies, bibliography, and history. Director of a communications consultancy firm and a frequent contributor to the gay press, he lives in Toronto and Banff, Alberta. End of article. Cocktails for 1. AIDS Treatment as a Social Sacrament. By Ian Young. HIV Realist, December 1998. Though some of the initial magic has worn off, drug company cocktails still retain something of the aura of an elixir among the proud citizens of the HIV-positive community. Many people, most of them gay men, pregnant black women or drug addicts, have now been prescribed these medicinal combinations as they sit, stunned and inattentive, in their doctor's offices, having just received their positive test results. Though the official terminology suggests something rather devil-may-care in a martini glass with an olive and a paper umbrella, it also signifies the joining of cock and tail. A sexual union, sex, whether overt or subliminal, is always good advertising. Sometimes cocktails even replace sexual union, as many of the men taking them are rendered impotent. It is curious that these medicinal cocktails have arisen just as the alcoholic cocktail is making a social comeback. The prescribed cocktails, though, are not drinks but capsules combining various conventional nucleoside analog drugs, DNA chain terminators such as AZT and its surrogates, together with varieties of the newest official AIDS treatment, protease inhibitors. The inhibitors, there is a growing list of them as Abbott, Merck, and Roche patent their own varieties, ostensibly target a particular class of enzymes by interrupting the assembly of viral proteins. This process is supposed to prevent the virus that causes AIDS from infecting new cells and killing people. The problem is that when tested in humans, the inhibitors showed no beneficial effects on the actual health of the test subjects. But the manufacturers were undeterred and somehow the cocktail hit the market, a lucrative combo of new and old toxins with a festive new label. The cocktails have been aggressively promoted, not only to physicians through drug company literature, but directly to potential consumers through large, full-color ads in AIDS lifestyle magazines like POZ. These ads show cocktail consumers crossing oceans in small boats and climbing high mountains with their buddies. Some people have been unable to endure the cocktails or have succumbed to heart attacks after taking them. Others have developed severe gastrointestinal problems, diarrhea, vomiting, liver damage or diabetes. But the most notorious consequence is a syndrome of wasting limbs and other unpleasant physical oddities with names like Crick's belly and buffalo humps that are familiarly known as the Quasimodo effect or, more discreetly, the Q effect. Nevertheless, TV and the rest of the mass media have concentrated on a flurry of accounts of spectacular, almost immediate recoveries. There are stories and compelling video evidence of KS lesions going into remission, pneumonias quickly clearing up, and people rising, like Lazarus, from their deathbeds and returning, unlike Lazarus, to their tennis games. For some reason, recovering the ability to play tennis is frequently mentioned by reporters enthusiastic about the Lazarus phenomenon. Perhaps they are thinking of Arthur Ashe, the most prominent heterosexual claimed as an AIDS death, Magic Johnson being apparently reluctant to take his place. Of course there are the party poopers. Among them is the protease expert Dr. David Rasnick. Rasnick doubts that protease inhibitors can do HIV and people any good. As the inhibitors must, like communion, be taken for life, Rasnick suggests that over the long term, they will inhibit essential intestinal enzymes, preventing the absorption of nutriment from food. Inhibitors fed to animals cause their guts to shrivel. No drug on its own has worked in AIDS, he says, so they're hoping that by throwing it all together in one big ball, something or the other will have an effect. What, then, is happening here? Is it possible that protease inhibitors may be toxic over the long haul, but initially beneficial to some seriously ill people? Perhaps. But it seems to have been largely forgotten that phenomena similar to the current positive accounts about protease inhibitors accompanied the introduction of Wellcome's AZT, its surrogates from rival manufacturers, and Sandoz/GeneLab's less widely distributed GLQ223, compound Q. As each of these drugs became the treatment of choice for a wide range of HIV and people, its mass prescription was heralded with a flurry of claims and corresponding accounts of spectacular benefits. These phenomena diminished somewhat as large numbers of patients found they could not tolerate the drugs, as side effects became more widely known, as independent tests failed to confirm, or contradicted, initial claims, and as patients failed to recover their health or, after an initial rally, died. Even so, the assertions and expectations surrounding each of the drugs have not disappeared, but rather been subsumed by claims for new combinations of products. The much televised baboon bone cure offered a variation on a theme. Remember the baboon bone cure? Everyone wanted it after the handsome young man on the evening news revived so quickly, refreshed in body and spirit. From coast to coast, gay men demanded that baboon bones be made widely available. Angry activists clamored for monkey marrow. They insisted on it as their basic civil right. And then the courageous young man who was the star volunteer, the fool who rushed in where angels feared to tread, died. And baboon bones were never heard of again. No money in them. But just because a drug is discredited does not mean it is no longer prescribed. If it is profitable, it is merely combined with other, hopefully more effective, drugs. Product combination ensures that each drug company retains its share of the market. Another characteristic of the cocktail has been the stringent accompanying instructions regarding self-administration. It is absolutely essential, we are told, that patients take their cocktails at regular intervals during the day, the cocktail hour, and never miss a dose. Should even a single dose be skipped, the virus, which is as clever as it is deadly, will fiendishly seize its opportunity, and all previous doses may well be rendered ineffective. In California, the fetish of the regular dose is so strong that San Francisco's Director of Public Health, Dr. Sandra Hernandez, has proposed the practice of DOT, directly observed therapy, enforced, closely monitored medication. Like the host and the communion wine, the cocktail must be consumed repeatedly. Repetitive regularity is no less important than consumption as an act of faith and obedience guaranteeing salvation. For the person diagnosed as HIV+, the cocktail's scientific combination of host and wine replaces Holy Communion with sacred consumption. The meticulous dosing schedule is not a new phenomenon. In the early days of AZT, the little blue and white capsules bearing the silhouette of a unicorn came in a Micronta drug timer, a slick plastic box with a loud alarm that sounded like a truck backing up. Dr. Robert Gallo had likened getting HIV to being hit by a truck. This device went off every 4 hours, day and night, and recipients of the drug were warned that it was essential not to miss a dose. Thus, dedicated AZT users were never allowed to get a good night's sleep. As many men simply turned off the timer, or ignored it, or threw the drugs away, the rules were later changed. This, it seems, was forgotten. Severe regimens have been reintroduced, and once again have had to be modified. AZT monotherapy was virginal. Traditionally, the unicorn is attracted by chastity. But in combination, its significance changes with the terminology, it becomes more eroticized, more appealing. Even so, the relentless schedule of the cocktail, more pills to take than ever before, still encountered the same strong resistance as the earlier AZT monotherapy. In a consumerist society, people are eager to find salvation in a pill. Thomas Zass said that many people would rather take a medicine that kills than no medicine at all. But it seems we want a single pill, one that doesn't keep us up at night or consume our life. Consumers can be demanding, and manufacturers are rushing to meet those demands. The new cocktails are new, improved, easier to take. And once one is on them, one must never stop, on pain of death. The cocktail is the perfect product, as Oscar Wilde said of the cigarette, it leaves one totally dissatisfied. The cocktail has become the elixir, the grail, of the positive lifestyle. All medicines have a sacramental component and drug consumption is almost always ritualistic. And any medicine endowed with the magical rejuvenating properties claimed for the cocktail will also engender a powerful placebo effect. Only the inhibitors and terminators embedded in the grail, i.e. its substance, its materiality, undermine its promise of salvation. In his seminal 1984 paper, The Group Fantasy Origins of AIDS, Dr. Caspar Schmidt drew attention to a number of outbreaks of hysterical or iatrogenic illness that were initially, and incorrectly, diagnosed as infectious. But illness is not the only phenomenon to be affected by mass trance and group fantasy. Recovery is also susceptible to the same shared mental factors. Attitudes to sickness and disability are easily affected by the unconscious wishes, beliefs, and fantasies of patients, physicians, caregivers and social groups. During the 1970s and 1980s, a breakthrough in communicating with autistic and severely retarded people was widely heralded. Application of a simple new technique known as facilitated communication resulted in people who had never communicated before suddenly revealing complex, sophisticated thoughts, and revealing them in well-written sentences and paragraphs. The facilitated communication technique consists of assisting mentally, and often physically, impaired children and adolescents by holding and supporting a wrist or forearm while the child's fingers indicate letters on a keyboard or printed chart. Once these previously unresponsive youngsters were facilitated by their therapists and social workers, many expressed their frustration at their plight and their love for their parents and caregivers. FC was promoted as a revolutionary technique demonstrating that whole groups of people previously thought to have severe learning difficulties were actually suffering only from neuromotor impairment. Acceptance of FC spread rapidly as parents and teachers welcomed a technique that allowed them, for the first time, to enjoy communicating with their children. FC quickly became a social movement as autistic people, accompanied by their paid facilitators, were integrated into regular schoolrooms and apparently semi-comatose people earned university degrees. Under the sway of FC, psychologists and speech pathologists revised their diagnoses, physicians altered their prescriptions, IQ test results were scrapped and program recommendations were retailored to accord with new facilitated findings. And a raft of new career possibilities opened up in the fast-expanding field of FC. Some skeptical voices were raised, but few people wished to play the role of wet blanket. Then something ominous began to happen. Until this point, the messages that disabled FC clients were tapping out on their computers and letterboards had largely been charming, childlike poems or poignant descriptions of love and frustration. Now, first in just one or two places, but soon spreading rapidly across North America, the nature of the messages began to change. The facilitated children and adolescents began, en masse, to allege horrendous sexual abuse by family members, and sometimes others, usually recounted in explicit, pornographic detail. As the new rash of messages proliferated, school and program administrators, physicians, social services, and police agencies became involved. Charges were laid, families were broken up, and everyone involved was subjected to a long, horrendous ordeal. Eventually, the whole business collapsed. Rigorous testing revealed that test subjects' apparent recognition even of cards showing single letters or simple pictures ceased once the facilitators were prevented from seeing the cards. Testing was extensive and varied, the results were the same. Like the users of a Ouija board, the facilitators were communicating without knowing it. And their benign, unconscious group fantasy of love and communication had turned into a malign, equally unconscious group fantasy of mass sexual abuse. FC is still used, and taught, in some American institutions. All manner of rationalizations are employed to justify it. But the technique is discredited, and the bubble has burst. How does this relate to AIDS treatment? Dr. Gina Green, an expert in the fields of autism and mental retardation, has made a careful study of facilitated communication. Observing that many novel treatment techniques share similar characteristics and surrounding phenomena, she has suggested 9 components of novel treatments that, she believes, often combine to make up the structure of what might be considered a social movement. Though these components were developed from her study of facilitated communication and other treatments for the developmentally handicapped, she has remarked that parallel phenomena occur in other areas, such as treatments for AIDS. Even some of the terminology is identical. Novel techniques in both fields are called interventions, suggesting benign intrusion into an otherwise unalterable state or process. Here are Dr. Green's 9 characteristics of treatment as a social movement. 1. Assertions that a new technique produces remarkable effects are made in the absence of solid objective evidence, or what little evidence there is becomes highly overblown. 2. Excitement about a possible breakthrough sweeps through the communities of parents, teachers, service providers, and others concerned with the welfare of individuals with disabilities. 3. Eager, even desperate for something that might help, many invest considerable financial and emotional resources in the new technique. 4. In the process, effective or potentially effective techniques are ignored. 5. Few question the basis for the claims about the new treatment or the qualifications of the individuals making them. 6. Anecdotal reports that seem to confirm the initial claims proliferate rapidly. 7. Careful scientific evaluation to determine the real effects of the technique are not completed for some time, and can be made more difficult than usual by the well-known and powerful effect of expectancies. 8. Some of these techniques have small specific positive effects, or at least do minimal harm. 9. Eventually they fall out of favor, sometimes because they are discredited by sound research, sometimes simply because experience reveals their lack of efficacy, but probably most often because another fad treatment has come on the scene. Each retains some adherents, however, and some go relatively dormant for a while only to emerge again. Dr. Green's suggestion that her characterizations are relevant to AIDS treatments seems well taken. Every one of her categories could be applied to currently popular AIDS drugs. The whole story of facilitated communication illustrates how powerfully expectation and group fantasy can influence the therapeutic process. If we believe autistic children are enraged at their abusive parents, they will tell us precisely that. If we believe gay men are destined to die young, we will contrive, quite unintentionally, to bring it about. Both conditions, autism and HIV positivity, are generally regarded as intractable, causing frustration, depression and burnout in caregivers. Cures are desperately needed. In both situations, the initial benign results of new therapies have been followed by more disturbing effects. Like facilitated communication, AIDS combination therapies fit Dr. Green's criteria of a social movement. In addition, their sacramental nature invests them with a key role in the cult phenomena surrounding AIDS, the testing ritual and the positive lifestyle. Group fantasies are often acted out as group rituals, social sacraments. The group fantasy of mass parental sexual abuse was acted out in the social sacrament of facilitated communication/communion. The group fantasy of the homosexual as doomed grotesque is acted out in rituals of the HIV test, now the principal rite of passage for young gay men in North America, and of the cocktail hour, the regular ingestion of chemical toxins. The PWA is the modern equivalent of the leper, like what was called leprosy in the pre-modern world. AIDS is a term that covers many different afflictions. This modern sexual leprosy is imagined to be healed by the cleansing scourge of teratogenic, and often anaphrodisiac, toxins. And the homosexual rises from his deathbed, to play tennis. This is the much talked about Lazarus effect, the biblical Lazarus being associated with resurrection and leprosy. Resurrection from a leprous death is imagined to be the ultimate result of the Quasimodo cocktail. Once awarded the dreaded, yet repeatedly sought, positive diagnosis, the patient is given a choice between leprosy, AIDS, and resurrection, if only as a monstrosity. And here the social sacrament implodes, into solitude, fear, despair, dementia, and suicide. Unlike some earlier medicines, like aerosolized pentamidine, that 2 or 3 could inhale together, this is definitely a cocktail for one. We are back at Jekyll and Hyde, that primal fable of male duality that suggests both the homosexual and his discoverer, the scientist. In Stevenson's classic tale, the good doctor's wicked alter ego is thought by some to be his lover, living with him in their blackmail house. Today, of course, many AIDS doctors are themselves AIDS patients. In any case, the relationship is often an unusually close one. My doctor is a sweetheart. How often we hear those words. They have become another of the slogans of our brave, unquestioning HIV-positive community. One acquaintance of mine, a long-term survivor, offers his rule of never taking any proposed new treatment for at least a year or 18 months after it has come into general use. He finds that very often, after that prudent wait, the fad has passed, many of the enthusiasts have either died or moved on, and yet another lucrative new treatment is making its much heralded debut. Asterisk. End of article. Articles by Kary Mullis. What causes AIDS? It's an open question. By Charles A. Thomas Jr., Kary B. Mullis, and Philip E. Johnson. Reason June 1994. Most people believe they know what causes AIDS. For a decade, scientists, government officials, physicians, journalists, public service ads, TV shows, and movies have told them that AIDS is caused by a retrovirus called HIV. This virus supposedly infects and kills the T cells of the immune system, leading to an inevitably fatal immune deficiency after an asymptomatic period that averages 10 years or so. Most people do not know because there has been a visual media blackout on the subject about a long-standing scientific controversy over the cause of AIDS. A controversy that has become increasingly heated as the official theory's predictions have turned out to be wrong. Leading biochemical scientists, including University of California at Berkeley retrovirus expert Peter Duesberg and Nobel Prize winner Walter Gilbert, have been warning for years that there is no proof that HIV causes AIDS. The warnings were met first with silence, then with ridicule and contempt. In 1990, for example, Nature published a rare response from the HIV establishment, as represented by Robin A. Weiss of the Institute of Cancer Research in London and Harold W. Jaffe of the U.S. Centers for Disease Control. Weiss and Jaffe compared the doubters to people who think that bad air causes malaria. We have been told, they wrote, that the human immunodeficiency virus, HIV, originates from outer space, or as a genetically engineered virus for germ warfare which was tested in prisoners and spread from them. Peter H. Duesberg's proposition that HIV is not the cause of AIDS at all is, to our minds, equally absurd. Viewers of ABC's 1993 Day 1 special on the cause of AIDS, almost the only occasion on which network television has covered the controversy, saw Robert Gallo, the leading exponent of the HIV theory, stomp away from the microphone in a rage when asked to respond to the views of Gilbert and Duesberg. Such displays of rage and ridicule are familiar to those who question the HIV theory of AIDS. Ever since 1984, when Gallo announced the discovery of what the newspapers call HIV, the virus that causes AIDS, at a government press conference, the HIV theory has been the basis of all scientific work on AIDS. If the theory is mistaken, billions of dollars have been wasted and immense harm has been done to persons who have tested positive for antibodies to HIV and therefore have been told to expect an early and painful death. The furious reactions to the suggestion that a colossal mistake may have been made are not surprising, given that the credibility of the biomedical establishment is at stake. It is time to think about the unthinkable, however, because there are at least 3 reasons for doubting the official theory that HIV causes AIDS. First, after spending billions of dollars, HIV researchers are still unable to explain how HIV, a conventional retrovirus with a very simple genetic organization, damages the immune system, much less how to stop it. The present stalemate contrasts dramatically with the confidence expressed in 1984. At that time Gallo thought the virus killed cells directly by infecting them, and US government officials predicted a vaccine would be available in 2 years. 10 years later no vaccine is in sight, and the certainty about how the virus destroys the immune system has dissolved in confusion. Second, in the absence of any agreement about how HIV causes AIDS, the only evidence that HIV does cause AIDS is correlation. The correlation is imperfect at best, however. There are many cases of persons with all the symptoms of AIDS who do not have any HIV infection. There are also many cases of persons who have been infected by HIV for more than a decade and show no signs of illness. Third, predictions based on the HIV theory have failed spectacularly. AIDS in the United States and Europe has not spread through the general population. Rather, it remains almost entirely confined to the original risk groups, mainly sexually promiscuous gay men and drug abusers. The number of HIV-infected Americans has remained constant for years instead of increasing rapidly as predicted, which suggests that HIV is an old virus that has been with us for centuries without causing an epidemic. No one disputes what happens in the early stages of HIV infection. As other viruses do, HIV multiplies rapidly, and it sometimes is accompanied by a mild, flu-like illness. At this stage, while the virus is present in great quantity and causing at most mild illness in the ordinary way, it does no observable damage to the immune system. On the contrary, the immune system rallies as it is supposed to do and speedily reduces the virus to negligible levels. Once this happens, the primary infection is over. If HIV does destroy the immune system, it does so years after the immune system has virtually destroyed it. By then the virus typically infects very few of the immune system's T cells. Before these facts were well understood, Robert Gallo and his followers insisted that the virus does its damage by directly infecting and killing cells. In his 1991 autobiography, Gallo ridiculed HIV discoverer Luc Montagnier's view that the virus causes AIDS only in the company of as yet undiscovered cofactors. Gallo argued that multifactorial is multi-ignorance and that, because being infected by HIV was like being hit by a truck, there was no need to look for additional causes or indirect mechanisms of causation. All that has changed. As Warner C. Green, a professor of medicine at the University of California, San Francisco, explained in the September 1993 Scientific American, researchers are increasingly abandoning the direct cell-killing theory because HIV does not infect enough cells. Even in patients in the late stages of HIV infection with very low blood T4 cell counts, the proportion of those cells that are producing HIV is tiny, about 1 in 40. In the early stages of chronic infection, fewer than 1 in 10,000 T4 cells in blood are doing so. If the virus were killing the cells just by directly infecting them, it would almost certainly have to infect a much larger fraction at any one time. Gallo himself is now among those who are desperately looking for possible CO factors and exploring indirect mechanisms of causation. Perhaps the virus somehow causes other cells of the immune system to destroy T cells or induces the T cells to destroy themselves. Perhaps HIV can cause immune system collapse even when it is no longer present in the body. As Gallo put it at an AIDS conference last summer, the molecular mimicry in which HIV imitates components of the immune system sets events into motion that may be able to proceed in the absence of further whole virus. But researchers have not been able to confirm experimentally any of the increasingly exotic causal mechanisms that are being proposed, and they do not agree about which of the competing explanations is more plausible. When the New York Times interviewed the government's head AIDS researcher, Anthony Fauci, in February, reporter Natalie Angier summarized his view as a sort of stew of all the leading possibilities. HIV overexcites some immune signaling pathways, while eluding the detection of others. And though the main target of the virus appears to be the famed helper T cells, or CD4 cells, which it can infiltrate and kill, the virus also ends up stimulating the response of other immune cells so inappropriately that they eventually collapse from overwork or confusion. No other virus is credited with such a dazzling repertoire of destructive skills. Perhaps it is the HIV scientists who are collapsing from overwork or confusion. The theory is getting ever more complicated, without getting any nearer to a solution. This is a classic sign of a deteriorating scientific paradigm. But as HIV scientists grow ever more confused about how the virus is supposed to be causing AIDS, their refusal to consider the possibility that it may not be the cause is as rigid as ever. On the rare occasions when they answer questions on the subject, they explain that unassailable epidemiological evidence has established HIV as the cause of AIDS. In short, they rely on correlation. The seemingly close correlation between AIDS and HIV is largely an artifact of the misleading definition of AIDS used by the U.S. government's Centers for Disease Control. AIDS is a syndrome defined by the presence of one or more of 30 independent diseases when accompanied by a positive result on a test that detects antibodies to HIV. The same disease conditions are not defined as AIDS when the antibody test is negative. Tuberculosis with a positive antibody test is AIDS, tuberculosis with a negative test is just TB. The skewed definition of AIDS makes a close correlation with HIV inevitable, regardless of the facts. This situation was briefly exposed at the International AIDS Conference in Amsterdam in 1992, when the existence of dozens of suppressed AIDS without HIV cases first became publicly known. Instead of considering the obvious implications of these cases for the HIV theory, the authorities at the CDC, who had known about some of the cases for years but had kept the subject under wraps, quickly buried the anomaly by inventing a new disease called ICL, idiopathic CD4 plus lymphocytopenia, a conveniently forgettable name that means AIDS without HIV. There are probably thousands of cases of AIDS without HIV in the United States alone. Peter Duesberg found 4,621 cases recorded in the literature, 1,691 of them in this country. Such cases tend to disappear from the official statistics because, once it's clear that HIV is absent, the CDC no longer counts them as AIDS. In a 1993 article published in Bio/Technology, Duesberg documented the consistent failure of the CDC to report on the true incidence of positive HIV tests in AIDS cases. The CDC concedes that at least 40,000 AIDS cases were diagnosed on the basis of presumptive criteria, that is, without antibody testing, on the basis of diseases such as Kaposi's sarcoma. Yet these diseases can occur without HIV or immune deficiency. Perhaps some of the patients diagnosed as having AIDS would have tested negative, or actually did test negative, for HIV. Physicians and health departments have an incentive to diagnose patients with AIDS symptoms as AIDS cases whenever they can, because the federal government pays the medical expenses of AIDS patients under the Ryan-White Act but not of persons equally sick with the same diseases who test negative for HIV antibodies. The claimed correlation between HIV and AIDS is flawed at an even more fundamental level, however. Even if the AIDS test were administered in every case, the tests are unreliable. Authoritative papers in both Bio/Technology, June 1993, and the Journal of the American Medical Association, November 27, 1991, have shown that the tests are not standardized and give many false positives because they react to substances other than HIV antibodies. Even if that were not the case, the tests at best confirm the presence of antibodies and not the virus itself, much less the virus in an active, replicating state. Antibodies typically mean that the body has fought off a viral infection, and they may persist long after the virus itself has disappeared from the body. Since it is often difficult to find live virus even in the bodies of patients who are dying of AIDS, Gallo and others have to speculate that HIV can cause AIDS even when it is no longer present and only antibodies are left. Just as there are cases of AIDS without HIV, there are cases of HIV-positive persons who remain healthy for more than a decade and who may never suffer from AIDS. According to Green's article in Scientific American, it is even possible that some rare strains of HIV are benign. Some homosexual men in the US who have been infected with HIV for at least 11 years show as yet no signs of damage to their immune systems. My colleagues and I are studying these long-term survivors to ascertain whether something unusual about their immune systems explains their response or whether they carry a virulent strain of the virus. The faulty correlation between HIV and AIDS would not disprove the HIV theory if there were strong independent evidence that HIV causes AIDS. As we have seen, however, researchers have been unable to establish a mechanism of causation. Nor have they succeeded in confirming the HIV model by inducing AIDS in animals. Chimps have repeatedly been infected with HIV, but none of them have developed AIDS. In the absence of a mechanism or an animal model, the HIV theory is based only upon a correlation that turns out to be primarily an artifact of the theory itself. In light of the importance of the correlation argument, it is astonishing that no controlled studies have been done for 3 of the major risk groups: transfusion recipients, hemophiliacs, and drug abusers. 2 ostensibly controlled studies involving men's groups in Vancouver and San Francisco purportedly show that AIDS developed only in the HIV-positive men and never in the control group of HIV negatives. These studies were designed not to test the HIV theory but to measure the rate at which HIV-positive gay men develop AIDS. They did not compare otherwise similar persons who differ only in HIV status, did not control effectively for drug use, and did not fully report the incidence of AIDS-defining diseases in the HIV-negative men. The research establishment accepted these studies uncritically because they give the HIV theory some badly needed support. But the main point they supposedly prove has already been thoroughly disproved: AIDS does occur in HIV-negative persons. According to the official theory, HIV is a virus newly introduced into the American population, which has had no opportunity to develop any immunity. It follows that viral infection should spread rapidly, moving from the original risk groups, gays, drug addicts, transfusion recipients, into the general population. This is what the government agencies confidently predicted, and AIDS advertising to this day emphasizes the theme that everyone is at risk. The facts are otherwise. AIDS is still confined mainly to the original risk groups, and AIDS patients in the United States are still almost 90% male. Healthcare workers, who are constantly exposed to blood and bodily fluids of AIDS patients, have no greater risk of contracting AIDS than the population at large. Among millions of healthcare workers, the CDC claims only 7 or 8, poorly documented, cases of AIDS supposedly developed through occupational exposure. By contrast, the CDC estimates that accidental needle sticks lead to more than 1,500 cases of hepatitis infection each year. Even prostitutes are not at risk for AIDS unless they also use drugs. Far from threatening the general heterosexual population, AIDS is confined mainly to drug users and gay men in specific urban neighborhoods. According to a 1992 report by the prestigious U.S. National Research Council, the convergence of evidence shows that the HIV/AIDS epidemic is settling into spatially and socially isolated groups and possibly becoming endemic within them. This factual picture is so different from what the theory predicts, and so threatening to funding, that the AIDS agencies have virtually ignored the National Research Council report and have continued to preach the fiction that AIDS does not discriminate. Not only is AIDS mostly confined to isolated groups in a few U.S. cities, but HIV infection is not increasing. Although a virus newly introduced to a susceptible population should spread rapidly, for several years the CDC has estimated that a steady 1 million Americans are HIV positive. Now it appears that the figure of 1 million is finally about to be revised downward. According to a story by Lawrence Altman in the March 1 New York Times, new statistical studies indicate that only about 700,000 Americans are HIV positive, and the official estimate will accordingly be reduced sometime this summer. While HIV infection remains steady at this modest level in the United States, World Health Organization officials claim that the same virus is spreading rapidly in Africa and Asia, creating a vast pandemic that threatens to infect at least 40 million people by the year 2000, unless billions of dollars are provided for prevention to the organizations sounding the alarm. These worldwide figures, especially from Africa, are used to maintain the thesis that everyone is at risk in the United States. Instead of telling Americans that AIDS cases here are almost 90% male, authorities say that worldwide the majority of AIDS sufferers are female. With the predictions of a mass epidemic in America and Europe failing so dramatically, AIDS organizations rely on the African figures to vindicate their theory. But these African figures are extremely soft, based almost entirely on clinical diagnoses, without even inaccurate HIV testing. What this means in practice is that Africans who die of diseases that have long been common there, especially wasting disease accompanied by diarrhea, are now classified as AIDS victims. Statistics on African AIDS are thus extremely manipulable, and witnesses are emerging who say that the epidemic is greatly exaggerated, if it exists at all. In October 1993, the Sunday Times of London reported on interviews with Philippe and Evelyn Krynen, heads of a 230-employee medical relief organization in the Kagera province of Tanzania. The Krynens had first reported on African AIDS in 1989 and at that time were convinced that Kagera in particular was in the grip of a vast epidemic. Subsequent years of medical work in Kagera have changed their minds. They have learned that what they had thought were AIDS orphans were merely children left with relatives by parents who had moved away, and that HIV-positive and HIV-negative villagers suffer from the same diseases and respond equally well to treatment. Philippe Krynen's verdict: there is no AIDS. It is something that has been invented. There are no epidemiological grounds for it, it doesn't exist for us. Krynen's remark calls attention to the fact that AIDS is not a disease. Rather, it is a syndrome defined by the presence of any of 30 separate and previously known diseases, accompanied by the actual or suspected presence of HIV. The definition has changed over time and is different for Africa, where HIV testing is rare, than for Europe and North America. The official CDC definition of AIDS in the United States was enormously broadened for 1993 in order to distribute more federal AIDS money to sick people, especially women with cervical cancer. As a direct result, AIDS cases more than doubled in 1993. Absent the HIV mystique, there would be no reason to believe that a single factor is causing cervical cancer in women, Kaposi's sarcoma in gay males, and slim disease in Africans. The HIV paradigm is failing every scientific test. Research based upon it has failed to provide not only a cure or vaccine but even a theoretical explanation for the disease-causing mechanism. Such success as medical science has had with AIDS has come not from the futile attempts to attack HIV with toxic antiviral drugs like AZT but from treating the various AIDS-associated diseases separately. Predictions based on the HIV theory have been falsified or are supported only by dubious statistics based mainly on the theory itself. Yet the HIV establishment continues to insist that nothing is wrong and to use its power to exclude dissenting voices, however eminent in science, from the debate. Like other leaders of the scientific establishment, Nature editor John Maddox is fiercely protective of the HIV theory. He indignantly rejected a scientific paper making the same points as this article. When Duisberg first argued his case in 1989 in the prestigious proceedings of the National Academy of Science, the editor promised that his paper would be answered by an article defending the orthodox viewpoint. The response never came. The editors of the leading scientific journals have refused to print even the brief statement of the Group for the Scientific Reappraisal of the HIV/AIDS Hypothesis, which has over 300 members. The statement notes simply that many biomedical scientists now question this hypothesis and calls for a thorough reappraisal of the existing evidence for and against this hypothesis. Such a reappraisal would include the following elements: genuinely controlled epidemiological studies of all the major risk groups: homosexuals, drug users, transfusion recipients, and hemophiliacs. The studies should employ an unbiased definition of AIDS. Too often we have been told that HIV always accompanies AIDS, only to learn that this is so because AIDS without HIV is named something else. The studies should be performed by persons who are committed to investigating the HIV theory rather than defending it. There is reason to suspect that properly controlled studies of transfusion recipients and hemophiliacs in particular will show that the incidence of AIDS-defining diseases is independent of HIV status. An audit of the CDC statistics to remove HIV bias and thereby allow unprejudiced testing of the critical epidemiological evidence for the theory. Every effort should be made to determine how many AIDS patients were actually tested for antibodies and the testing method that was employed. Because even the most reliable antibody test generates many false positive results, researchers should try to validate the tests by examining random samples of AIDS patients to determine whether significant amounts of replicating HIV can be found in their bodies. Statistics have been kept as if the purpose were to protect the HIV theory rather than to learn the truth. Research focusing on the cause of particular diseases rather than the politically defined hodgepodge of diseases we now call AIDS. The cancer-like skin disease called Kaposi's sarcoma, KS, is one of the best-known AIDS-defining conditions, but leading KS and HIV experts Marcus Conant and Robin Weiss now say that dozens of non-HIV KS cases are under study in the United States and that KS is becoming much less frequent in gay male AIDS patients than it formerly was. Conant, Weiss, and other AIDS researchers now frankly attribute KS to an unknown infectious agent rather than to HIV, but KS is nonetheless still called AIDS when it occurs in combination with HIV. Duesberg attributes KS in gay males to the use of amyl nitrates, poppers, as a sexual stimulant. His theory is eminently testable, and it ought to be given a fair chance. Another example, hemophiliacs in the age of AIDS are living longer than they ever did in the past, but they still often die of conditions related to receipt of the blood concentrate called factor VIII. Research published in The Lancet in February confirms earlier reports that symptoms diagnosed as AIDS are best treated by providing a highly purified form of factor VIII. Researchers should study the role of blood product impurities in causing disease in hemophiliacs, without the distortion that comes from arbitrarily assuming that HIV is responsible whenever an HIV-positive hemophiliac becomes ill. A critical re-examination of the statistics for AIDS and HIV in Africa and Asia. Researchers should perform new, controlled studies of representative African populations to test the relationship of confirmed HIV infection to the incidence of AIDS-defining diseases. It will not do to rely upon presumptive diagnoses or extrapolations from single antibody tests that are now well known to generate many false positives. The HIV establishment and its journalist allies have replied to various specific criticisms of the HIV theory without taking them seriously. They have never provided an authoritative paper that undertakes to prove that HIV really is the cause of AIDS, meaning a paper that does not start by assuming the point at issue. The HIV theory was established as fact by Robert Gallo's official press conference in 1984, before any papers were published in American journals. Thereafter, the research agenda was set in concrete, and skeptics were treated as enemies to be ignored or punished. As a result, the self-correcting processes of science have broken down, and journalists have not known how to ask the hard questions. After 10 years of failure, it is time to take a second look. Asterisk. Charles A. Thomas Jr., a biochemist, is president of the Helican Foundation in San Diego and secretary of the Group for the Scientific Reappraisal of the HIV/AIDS Hypothesis. Kary Mullis is the 1993 Nobel Prize winner in chemistry for his invention of the polymerase chain reaction technique, for detecting DNA, which is used to search for fragments of HIV in AIDS patients. Philip E. Johnson is the Jefferson E. Pazer Professor of Law at the University of California, Berkeley. End of article. The Medical Establishment vs. the Truth. Book excerpt. By Kary Mullis. Penthouse, September 1998. Dr. Mullis was awarded the 1993 Nobel Prize in Chemistry. This article is excerpted from his forthcoming book, Dancing Naked in the Mind Field, to be published by Pantheon. When I first heard in 1984 that Luc Montagnier of France's Pasteur Institute and Robert Gallo of America's National Institutes of Health had independently discovered that the retrovirus HIV human immunodeficiency virus caused AIDS, I accepted it as just another scientific fact. It was a little out of my field of biochemistry, and these men were specialists in retroviruses. 4 years later I was working as a consultant at Specialty Labs in Santa Monica. Specialty was trying to develop a means of using PCR polymerase chain reaction, AD.N.A amplification method conceived by Mullis to detect retroviruses in the thousands of blood donations received per day by the Red Cross. I was writing a report on our progress for the project's sponsor, and I began by stating, HIV is the probable cause of AIDS. I asked a virologist at Specialty where I could find the reference for HIV being the cause of AIDS. You don't need a reference, he told me. Everybody knows it. I'd like to quote a reference. I felt a little funny about not knowing the source of such an important discovery. Everyone else seemed to. Why don't you cite the CDC report, he suggested, giving me a copy of the Centers for Disease Control's periodic report on morbidity and mortality. I read it. It wasn't a scientific article. It simply said that an organism had been identified. It did not say how. It requested that doctors report any patients showing certain symptoms and test them for antibodies to this organism. The report did not identify the original scientific work, but that didn't surprise me. It was intended for physicians, who didn't need to know the source of the information. Physicians assumed that if the CDC was convinced, there must exist real proof somewhere that HIV was the cause of AIDS. A proper scientific reference is usually a published article in a reliable scientific magazine. These days the magazines are on slick glossy paper with pictures on the front and lots of advertisements, a lot of editorial material by people who are professional journalists, and a few pictures of girls selling you things you might want to buy for your lab. The advertisers are the companies that make things for scientists to buy and the companies that make drugs for doctors to sell. Therefore there are no major journals without corporate connections. Scientists submit the articles in order to report their work. Preparing articles describing their work and having them published is crucial to a scientist's career, and without articles in major journals they will lose their rank. The articles may not be submitted until experiments supporting the conclusions drawn are finished and analyzed. In primary journals every single experimental detail has to be there either directly or by reference, so that somebody else can repeat exactly what was done and find out whether it comes out the same way in their hands. If it doesn't, somebody will report that, and the conflict eventually has to be resolved so that when we go on from here we know where here is. The most reliable primary journals are refereed. After you send in your article, the editors send copies of it to several of your colleagues for review. They become the referees. The editors are paid for their work on the journal, the colleagues are not. But what they do gives them power, which most of them like. I did computer searches. Neither Montagnier, Gallo, nor anyone else had published papers describing experiments which led to the conclusion that HIV probably caused AIDS. I read the papers in Science for which they had become well known as AIDS doctors, but all they had said there was that they had found evidence of a past infection by something which was probably HIV in some AIDS patients. They found antibodies. Antibodies to viruses had always been considered evidence of past disease, not present disease. Antibodies signaled that the virus had been defeated. The patient had saved himself. There was no indication in these papers that this virus caused a disease. They didn't show that everybody with the antibodies had the disease. In fact, they found some healthy people with antibodies. If Montagnier and Gallo hadn't really found this evidence, why was their work published, and why had they been fighting so hard to get credit for the discovery? There had been an international incident wherein Robert Gallo of the NIH had claimed that his own lab had not been able to grow the virus from the sample sent to him by Luc Montagnier in Paris. The virus he was able to grow, he said, came from samples collected at his end from putative AIDS patients. Gallo had patented the AIDS test based on these samples, and the Pasteur Institute had sued. The Pasteur eventually won, but back in 1989 it was a standoff, and they were sharing the profits. I was hesitant to write HIV is the probable cause of AIDS until I found published evidence that would support it. Mine was the most minimal statement possible. In my progress report I wasn't trying to say that it absolutely did cause AIDS, I was just trying to say that it was likely to cause it for some known reasons. Tens of thousands of scientists and researchers were spending billions of dollars a year doing research based on this idea. The reason had to be there somewhere, otherwise these people would not have allowed their research to settle into one narrow channel of investigation. I lectured about PCR at innumerable meetings. Always there were people there talking about HIV. I asked them how it was that we knew HIV was the cause of AIDS. Everyone said something. Everyone had the answer at home, in the office, in some drawer. They all knew, and they would send me the papers as soon as they got back. But I never got any papers. Nobody ever sent me the news about how AIDS was caused by HIV. I finally had the opportunity to ask Dr. Montagnier about the reference when he lectured in San Diego at the grand opening of the UCSD AIDS Research Center, which is still run by Bob Gallo's former consort, Dr. Flossie Wongstall. This would be the last time I would ask my question without showing anger. In response, Dr. Montagnier suggested, "Why don't you reference the CDC report?" "I read it," I said. "That doesn't really address the issue of whether or not HIV is the probable cause of AIDS, does it?" He agreed with me. It was damned irritating. If Montagnier didn't know the answer, who the hell did? One night I was driving from Berkeley to La Jolla and I heard an interview on National Public Radio with Peter Duesberg, a prominent virologist at Berkeley. I finally understood why I was having so much trouble finding the references that linked HIV to AIDS. There weren't any, Duesberg said. No one had ever proved that HIV causes AIDS. The interview lasted about an hour. I pulled over so as not to miss any of it. I had known of Peter when I was a graduate student at Berkeley. He had been described as a truly brilliant scientist who had mapped a particular mutation to a single nucleotide in what was to become known eventually as an oncogene. In the 1960s, that was a real feat. Peter went on to develop the theory that oncogenes might be introduced by viruses into humans and cause cancer. The idea caught on and became a serious theoretical driving force behind the research that was funded under the unfortunate name War on Cancer. Peter was named California Scientist of the Year. Not satisfied resting on his laurels, Peter torched them. He found flaws in his own theory and announced to his surprised colleagues who were working on demonstrating it that it was highly unlikely. If they wanted to cure cancer, their research should be directed elsewhere. Whether it was because they were more interested in curing their own poverty than cancer, or that they just couldn't come to grips with their mistake, they continued to work fruitlessly on the viral oncogene hypothesis for 10 years. And they didn't seem to notice the irony. The more frustrated they got, the more they chastised Peter Duesberg for questioning his own theory and their folly. Most of them had been trained to obtain grants from the government, hire people to do research, and write papers that usually ended with the notion that further research should be done along these same lines, preferably by them and paid for by someone else. One of them was Bob Gallo. Gallo had been a friend of Peter's. They had worked in the same department at the National Cancer Institute. Of the thousands of scientists who had worked fruitlessly to assign a causal role in cancer to a virus, Bob was the only one who had been overzealous enough to announce that he had. No one paid any attention because all he had demonstrated was an anecdotal and very weak correlation between antibodies to a harmless retrovirus, which he called HTLV. and an unusual type of cancer found mainly on 2 of the southern islands of Japan. In spite of his lack of luster as a scientist, Gallo worked his way up in the power structure. Peter Duesberg, despite his brilliance, worked his way down. By the time AIDS came along, it was Bob Gallo whom Margaret Heckler approached when President Reagan decided that enough homosexuals picketing the White House was enough. Margaret was the Secretary of Health, Education, and Welfare, and thereby the top dog at the NIH. Bob Gallo had a sample of a virus that Luc Montagnier had found in the lymph node of a gay decorator in Paris with AIDS. Montagnier had sent it to Gallo for evaluation, and Bob had appropriated it in the pursuit of his own career. Margaret called a press conference and introduced Dr. Robert Gallo, who suavely pulled off his wraparound sunglasses and announced to the world press, "Gentlemen, we have found the cause of AIDS." And that was it. Gallo and Heckler predicted that a vaccine and a cure would be available within a couple of years. That was 1984. All the old virus hunters from the National Cancer Institute put new signs on their doors and became AIDS researchers. Reagan sent up about $1 billion just for starters, and suddenly everybody who could claim to be any kind of medical scientist and who hadn't had anything much to do lately was fully employed. They still are. It was named human immunodeficiency virus by an international committee in an attempt to settle the ownership dispute between Gallo and Montagnier, who had given it different names. To call it HIV was a short-sighted mistake that preempted any thought of investigation into the causal relationship between acquired immune deficiency syndrome and the human immunodeficiency virus. Duesberg pointed out wisely from the sidelines in the proceedings of the National Academy of Sciences that there was no good evidence implicating the new virus. He was ignored. Editors rejected his manuscripts, and committees of his colleagues began to question his need for having his research funds continued. Finally, in what must rank as one of the great acts of arrogant disregard for scientific propriety, a committee including Flossie Wongstall, who was feuding openly with Duesberg, voted not to renew Peter's Distinguished Investigator Award. He was cut off from research funds. Thus disarmed, he was less of a threat to the growing AIDS establishment. He would not be invited back to speak at meetings of his former colleagues. We live with an uncountable number of retroviruses. They're everywhere and they probably have been here as long as the human race. We have them in our genome. We get some of them from our mothers in the form of new viruses, infectious viral particles that can move from mother to fetus. We get others from both parents along with our genes. We have resident sequences in our genome that are retroviral. That means that we can and do make our own retroviral particles some of the time. Some of them may look like HIV. No one has shown that they've ever killed anyone before. There's got to be a purpose for them. A sizable fraction of our genome is comprised of human endogenous retroviral sequences. There are those who claim that we carry useless DNA, but they're wrong. If there is something in our genes, there's a reason for it. We don't let things grow on us. I have tried to put irrelevant gene sequences into things as simple as bacteria. If it doesn't serve some purpose, the bacteria get rid of it right away. I assume that my body is at least as smart as bacteria when it comes to things like DNA. HIV didn't suddenly pop out of the rainforest or Haiti. It just popped into Bob Gallo's hands at a time when he needed a new career. It has been here all along. Once you stop looking for it only on the streets of big cities, you notice that it is thinly distributed everywhere. If HIV has been here all along and it can be passed from mother to child, wouldn't it make sense to test for the antibodies in the mothers of anyone who is positive for HIV, especially if that individual is not showing any signs of disease? Picture a kid in the heartland of America. His lifelong goal has been to join the Air Force when he graduates and become a jet pilot. He's never used drugs and he's had the same sweet girlfriend, whom he plans to marry, all through high school. Unbeknownst to him, or anyone else, he also has antibodies to HIV, which he inherited from his mother, who is still alive, when he was in her womb. He's a healthy kid, it doesn't bother him in any way, but when he is routinely tested for HIV by the Air Force, his hopes and dreams are destroyed. Not only is he barred from the Air Force, but he has a death sentence over his head. The CDC has defined AIDS as one of more than 30 diseases accompanied by a positive result on a test that detects antibodies to HIV. But those same diseases are not defined as AIDS cases when the antibodies are not detected. If an HIV positive woman develops uterine cancer, for example, she is considered to have AIDS. If she is not HIV positive, she simply has uterine cancer. An HIV positive man with tuberculosis has AIDS. If he tests negative, he simply has tuberculosis. If he lives in Kenya or Colombia, where the test for HIV antibodies is too expensive, he is simply presumed to have the antibodies and therefore AIDS, and therefore he can be treated in the World Health Organization's clinic. It's the only medical help available in some places. And it's free, because the countries that support WHO are worried about AIDS. From the point of view of spreading medical facilities into areas where poor people live, AIDS has been a boon. We don't poison them with AZT like we do our own people because it's too expensive. We supply dressing for the machete cut on their left knee and call it AIDS. The CDC continues to add new diseases to the grand AIDS definition. The CDC has virtually doctored the books to make it appear as if the disease continues to spread. In 1993, for example, the CDC enormously broadened its AIDS definition. This was happily accepted by county health authorities, who receive $2,500 from the feds per year under the Ryan-White Act for every reported AIDS case. In 1634, Galileo was sentenced to house arrest for the last 8 years of his life for writing that the Earth is not the center of the universe but rather moves around the Sun. Because he insisted that scientific statements should not be a matter of religious faith, he was accused of heresy. Years from now, people looking back at us will find our acceptance of the HIV theory of AIDS as silly as we find the leaders who excommunicated Galileo. Science as it is practiced today is largely not science at all. What people call science is probably very similar to what was called science in 1634. Galileo was told to recant his beliefs or be excommunicated. People who refuse to accept the commandments of the AIDS establishment are basically told the same thing: if you don't accept what we say, you're out. It has been disappointing that so many scientists have absolutely refused to examine the available evidence in a neutral, dispassionate way. Several respected scientific journals have refused to print a statement issued by the Group for the Scientific Reappraisal of the HIV/AIDS hypothesis simply requesting a thorough reappraisal of the existing evidence for and against this hypothesis. I spoke publicly about this issue for the first time at a meeting of the American Association for Clinical Chemists in San Diego. I knew I would be among friends there. It was a small part of a much longer speech. At most I spoke for 15 minutes about AIDS. I told the audience how my inability to find a simple reference had sparked my curiosity. The more I learned, the more outspoken I became. As a responsible scientist convinced that people were being killed by useless drugs, I could not remain silent. The responses I received from my colleagues ranged from moderate acceptance to outright venom. When I was invited to speak about PCR at the European Federation of Clinical Investigation in Toledo, Spain, I told them that I would like to speak about HIV and AIDS instead. I don't think they understood exactly what they were getting into when they agreed. Halfway through my speech, the president of the society cut me off. He suggested I answer some questions from the audience. I thought it was incredibly rude and totally out of line that he cut me off, but what the hell, I would answer questions. He opened the floor to questions, and then decided that he would ask the first one. Did I understand that I was being irresponsible? That people who listened to me might stop using condoms? I replied that fairly reliable statistics from the CDC showed that in the United States, at least, the number of reported cases of every known venereal disease was increasing, meaning people were not using condoms, while using the initial definition of AIDS, the number of reported cases of AIDS was decreasing. So, no, I didn't understand that I was being irresponsible. He decided that that was enough questions and ended the meeting abruptly. Whenever I speak on this issue, the question always comes up: if HIV isn't the cause of AIDS, then what is? The answer to that is that I don't know the answer to that, any more than Gallo or Montagnier knows. Knowing that there is no evidence that HIV causes AIDS does not make me an authority on what does. It is indisputable that if an individual has extremely close contacts with a lot of people, the number of infectious organisms that this individual's immune system is going to have to deal with will be high. If a person has 300 sexual contacts a year, with people who themselves are each having 300 contacts a year, that's 90,000 times more opportunity for infections than a person involved in an exclusive relationship. Think of the immune system as a camel. If the camel is overloaded, it collapses. In the 1970s we had a significant number of highly mobile, promiscuous men sharing bodily fluids and fast lifestyles and drugs. It was probable that a metropolitan homosexual would be exposed to damn near every infectious organism that has lived on humans. In fact, if you had to devise a strategy to collect every infectious agent on the planet, you would build bathhouses and encourage very gregarious people to populate them. The immune system will fight, but the numbers will wear it down. The scientific issue gets tangled up with morality. What I'm describing has nothing at all to do with morality. This is not God's wrath or any other absurdity. A segment of our society was experimenting with a lifestyle, and it didn't work. They got sick. Another segment of our pluralistic society, call them doctor/scientist refugees from the failed war on cancer, or just call them professional jackals, discovered that it did work. It worked for them. They are still making payments on their new BMWs out of your pocket. I was invited by the Glaxo pharmaceutical company to speak at a conference. They sent me a letter in December of 1993 asking me to be the November 1994 symposium banquet speaker. If that time was not convenient for me, they wanted me to speak at the November 1995 banquet. Dr. John Partridge, who was the director of the Chemical Development Division, had not met me personally but had heard about a lecture I had given in 1991 at the Gordon Research Conference that, in his words, was the most highly praised lecture that I have ever heard about from my academic and industrial colleagues. He was looking for particularly articulate scientists who bridge the biochemical and medical disciplines and routinely engage in out-of-the-box thinking. Well, that certainly was me. Dr. Partridge wrote that he would be pleased to pay all my travel and accommodations, as well as an honorarium of $1,500. I thought this sounded all right, but I figured Glaxo could pay me a little more. What made this invitation particularly interesting to me was the fact that Glaxo was the largest drug company in the world, and one of their profitable drugs was the cellular poison being used against AIDS, AZT. It kills cells like a cancer chemotherapeutic does. It keeps them from reproducing by preventing them from making new DNA. It also kills. In cancer, there is a rationale at least for using them, although I personally would never use chemotherapeutics on myself, cancer or not. But here's the way the explanation goes. I think it stinks of an old therapy they used to use against syphilis, arsenic. The syphilis was surely going to kill you, the arsenic might kill you, but maybe it would kill the syphilis first and you would live to fraternize again. The use of poisonous chemotherapeutics in cancer follows the same line. The cancer is surely going to kill you. The chemotherapeutic surely will also, but maybe it will kill the cancer cells before it kills you. It's a gamble. We will give you almost enough to kill you and hope it's sufficient to kill the cancer. I wouldn't go for it myself. I don't need to take drugs that make my hair fall out. But what the hell, if somebody wants to take this kind of gamble, it does have a sort of logic to it. Nothing fun. Nothing you would do for a headache. But it's a chance somebody might want to take when the alternative is to die too young to watch their kids grow up. And some people do recover from cancer even after they have taken chemotherapeutics. In the case of AIDS, the same strategy took a diabolic turn. AIDS might kill you, AZT might also. It will surely make you sick. It will prevent the proliferation of any rapidly growing cells in your body, including the CD4 immune cells that your doctor thinks you need now more than anything. It may kill the HIV. It kills it in petri dishes. But that may not cure you. The damage to you may have already been done, whatever it is. The complete absence of all HIV from your body, even if it is accomplished, may not cure you of AIDS. No one has ever recovered from AIDS, even though they have recovered from HIV. And we are not going to give it to you in a limited dose as we do in the case of cancer chemotherapy, where we are gambling that although we are hurting you, we are hurting the cancer more and maybe you will survive longer. Here we are not gambling. No one has ever recovered from AIDS. We cannot expect that you might recover. We are going to ask you to swallow this poison until you die. About 500,000 people went for it. No one has been cured. Most of them are dead. The ones who are not are also taking another drug now, a protease inhibitor. Who knows what it will do? The manufacturers didn't know when they started selling it. The FDA didn't require them to show that it would cure AIDS and not kill the patient, any more than they required them to show that about AZT. They only required that a surrogate goal be met. A surrogate goal means that something that we think may be related to the disease in question may be improved by the drug, like the level of CD4 cells, whatever the fuck they are. It's a way to get around the notion that a drug ought to be effective in curing the disease that it is sold for before it can be sold. The surrogate goal bullshit is an indication that our FDA no longer serves our needs. Or at least it does not serve our needs unless we own stock in the pharmaceutical industry and don't give a shit about health care. I was interested in giving a seminar about things like this to the scientists assembled in North Carolina by Glaxo, formerly Burroughs Wellcome, and by the University of North Carolina in the name of Frontiers in Chemistry and Medicine. I was thinking that this technique of killing people with a drug that was going to kill them in a way hardly distinguishable from the disease they were already dying from, just faster, was really out there on the edge of the frontiers of medicine. In previous interviews and seminars I had said that I thought AZT was not only useless against AIDS, but in fact it was poisoning people. There were large-scale medical studies done in Europe, called the Concord study, that indicated just this. AZT was worthless against AIDS and harmful even to healthy people. This conclusion was reached despite the fact that the study was heavily funded by Glaxo. I wondered if these people knew how I felt about their product when they issued the invitation. I notified Dr. Partridge that I was pleased to accept if they would raise the ante a little. On January 26, 1994, I received a letter from M. Ross Johnson, the Vice President of the Division of Chemistry. They were very happy that I had accepted, and wrote that they would send me first-class airfare for 2, accommodation expenses, and an honorarium of $3,000. In closing, he asked me for the title of my banquet presentation. So far, so good. I responded as requested, explaining that I intended to speak to this audience about a subject that should be of tremendous concern to the entire scientific community. I would speak about the fact that there is no scientific evidence that HIV is the probable cause of AIDS and that I believed people taking AZT were being poisoned. On October 14, 1994, a month before the meeting, I received another letter from Glaxo, this time from Gardner F. H. Smith. No title. He was sincerely regretting having to inform me that they could no longer accommodate my presentation. He said that they would send me a check for $1,000 to compensate me for any inconvenience. I responded with the following letter. Dear Mr. Johnson. Enclosed, please find a copy of a fairly uninformative letter from a Mr. Gardner Smith, with whom I have not been in contact or correspondence previously. As you know, my overall schedule is compact and very difficult to rearrange on short notice. I have declined, as a result of my commitment to Glaxo, income from other potential engagements. With Mr. Smith, I sincerely regret that your company had been forced into the changing of the structuring, whatever that means to Mr. Smith, of the above referenced event. Unfortunately, I have made arrangements to attend several non-profit institutional functions in the Southeast in connection with this trip, appearances which I will not cancel. Therefore, your company's reluctance, as related perfunctorily by Mr. Smith, to abide by the terms of your previous Correspondence represents a considerable loss of income as well as an unanticipated expense to me personally. Mr. Smith's unexplained offer of $1,000 compensation for my time and trouble adds a bit of mystery here as to who Mr. Smith is and what he must misconceive to be the value of my time and trouble. I do not understand what Mr. Smith is exactly apologizing for in his letter, but I will be kindly expecting immediately, with or without an explanation from some more cordial and informed representative of Glaxo, a check for $6,048. For Mr. Smith's information, round-trip airfare between San Diego and Raleigh-Durham first class for two is $3,048. Addition of our agreed-on honorarium of $3,000 results in the above figure. One more thing you might consider, Dr. Johnson. A number of attendees at your meeting will likely have something to say to me about my failure to appear. You should be careful to explain there publicly precisely why Mr. Smith felt the need to inform me that your company has taken the liberty of restructuring in such a way as to be unable to accommodate my presentation. I am not in the habit of cancelling public appearances at such short notice, and would not care to gain such a reputation on your account. I hope you understand that this is not for me or for Glaxo, a trivial matter. Cordially, Dr. Kary B. Mullis. On November 30, 1994, I received another letter from Mr. Smith. It was quite brief, saying that he had received a copy of my letter to Dr. Johnson. Enclosed was a check from Glaxo in the amount of $6,048. This was the most money I had ever made specifically for not doing something. And it occurred to me that, with my growing reputation for creating controversy, there might be many groups or individuals who did not want to hear me speak. Certainly that was their right, but if people did not want to hear ideas that would make them uncomfortable, they ought to be willing to pay not to hear them. With that thought in mind, I drafted the following offer. Have slides, we'll stay home. Dr. Kary B. Mullis wants to talk to you and your associates, your friends, your sons and daughters. Is there anything you can do about it? Yes. But you must act now. Special offer. Dr. Mullis won the Nobel Prize in Chemistry in 1993 and promptly launched a worldwide lecture tour universities, research institutes, conventions, high schools, businesses, community groups. He even addressed Connect, a joint project of UCSD and the San Diego biotech industry, right on the beach in front of his very own apartment, which has been described in the national press as rented rooms filled with his tools of seduction. He is usually invited to lecture on the polymerase chain reaction, but when the lights go down and the slides come on, well. John Martin, president of the European Society for Clinical Investigation, said in Nature, his Dr. Mullis's only slides, or what he has called his art, were photographs he had taken of naked women with colored lights projected upon their bodies. He accused science of being universally corrupt with widespread falsification of data to obtain grants. Finally, he impugned the personal honesty of several named scientists working in the H.I.V field. The Council of the European Society for Clinical Investigation will not be inviting Dr. Mullis to further meetings. Really, do you need this in your community? Of course not. And now, for a limited time only, you can be assured that Dr. Mullis will not ever lecture at your society, school, research lab, etc. You personally, and confidentially, can assure it. Call now at my phone number, and ask for my beautiful assistant. Have your Visa or MasterCard ready. Prevention rates begin at $500 per year guaranteed, and are progressive with the size and sensitivity of your organization. You may request personal anonymity, or for $79.95 plus shipping we will send you a special service award embossed with your name and a special inscription commending your judgment, foresight, and unselfish devotion to your community. Custom inscriptions are a little extra but can be especially commemorative. Think about honoring your boss or one of your associates by taking advantage of our special Help a Friend Stop Mullis offer. Call for details. Don't delay. Only one offer of complete protection per year can be extended to any single organization. Be first, be smart. Be safe. Recently, Glaxo Pharmaceuticals found it necessary to send Dr. Mullis a check for $6,048 simply to prevent him from speaking at their annual Chemistry and Medicine at the Frontiers Conference in Chapel Hill, MC. No one at Glaxo had seen fit to acquire protection from a Mullis seminar, and, haplessly Dr. Ross Johnson, now no longer with Glaxo, had invited him. I must report that the response to this offer has been underwhelming. Neiman Marcus has not chosen to include it in their famed Christmas catalog. So I have continued to speak out to any forum when I have been given the opportunity. It is not too late, however, if you would like to give the gift of my silence to an individual or an organization, all reasonable offers will be accepted. Note, this offer is not open to family members or employees of Kary Mullis, who are doomed to have to listen to what I say. Asterisk. End of article. Foreword for Inventing the AIDS Virus, 1996. By Kary Mullis. In 1988 I was working as a consultant at specialty labs in Santa Monica, setting up analytic routines for the human immunodeficiency virus, HIV. I knew a lot about setting up analytic routines for anything with nucleic acids in it because I had invented the polymerase chain reaction. That's why they had hired me. Acquired immune deficiency syndrome, AIDS, on the other hand, was something I did not know a lot about. Thus, when I found myself writing a report on our progress and goals for the project, sponsored by the National Institutes of Health, I recognized that I did not know the scientific reference to support a statement I had just written: HIV is the probable cause of AIDS. So I turned to the virologist at the next desk, a reliable and competent fellow, and asked him for the reference. He said I didn't need one. I disagreed. While it's true that certain scientific discoveries or techniques are so well established that their sources are no longer referenced in the contemporary literature, that didn't seem to be the case with the HIV/AIDS connection. It was totally remarkable to me that the individual who had discovered the cause of a deadly and as yet uncured disease would not be continually referenced in the scientific papers until that disease was cured and forgotten. But as I would soon learn, the name of that individual, who would surely be Nobel material, was on the tip of no one's tongue. Of course, this simple reference had to be out there somewhere. Otherwise tens of thousands of public servants and esteemed scientists of many callings, trying to solve the tragic deaths of a large number of homosexual and/or intravenous, drug-using men between the ages of 25 and 40, would not have allowed their research to settle into one narrow channel of investigation. Everyone wouldn't fish in the same pond unless it was well established that all the other ponds were empty. There had to be a published paper, or perhaps several of them, which taken together indicated that HIV was the probable cause of AIDS. There just had to be. I did computer searches, but came up with nothing. Of course, you can miss something important in computer searches by not putting in just the right keywords. To be certain about a scientific issue, it's best to ask other scientists directly. That's one thing that scientific conferences in faraway places with nice beaches are for. I was going to a lot of meetings and conferences as part of my job. I got in the habit of approaching anyone who gave a talk about AIDS and asking him or her what reference I should quote for that increasingly problematic statement: HIV is the probable cause of AIDS. After 10 or 15 meetings over a couple years, I was getting pretty upset when no one could cite the reference. I didn't like the ugly conclusion that was forming in my mind: the entire campaign against a disease increasingly regarded as a 20th century Black Plague was based on a hypothesis whose origins no one could recall. That defied both scientific and common sense. Finally, I had an opportunity to question one of the giants in HIV and AIDS research, Dr. Luc Montagnier of the Pasteur Institute, when he gave a talk in San Diego. It would be the last time I would be able to ask my little question without showing anger, and I figured Montagnier would know the answer. So I asked him. With a look of condescending puzzlement, Montagnier said, "Why don't you quote the report from the Centers for Disease Control?" I replied, "It doesn't really address the issue of whether or not HIV is the probable cause of AIDS, does it?" "No," he admitted, no doubt wondering when I would just go away. He looked for support to the little circle of people around him, but they were all awaiting a more definitive response, like I was. "Why don't you quote the work on SIV simian immunodeficiency virus?" the good doctor offered. "I read that too, Dr. Montagnier," I responded. "What happened to those monkeys didn't remind me of AIDS. Besides, that paper was just published only a couple of months ago. I'm looking for the original paper where somebody showed that HIV caused AIDS." This time, Dr. Montagnier's response was to walk quickly away to greet an acquaintance across the room. Cut to the scene inside my car just a few years ago. I was driving from Mendocino to San Diego. Like everyone else by now, I knew a lot more about AIDS than I wanted to. But I still didn't know who had determined that it was caused by HIV. Getting sleepy as I came over the San Bernardino Mountains, I switched on the radio and tuned in a guy who was talking about AIDS. His name was Peter Duesberg, and he was a prominent virologist at Berkeley. I'd heard of him, but had never read his papers or heard him speak. But I listened, now wide awake, while he explained exactly why I was having so much trouble finding the references that linked HIV to AIDS. There weren't any. No one had ever proved that HIV causes AIDS. When I got home, I invited Duesberg down to San Diego to present his ideas to a meeting of the American Association for Chemistry. Mostly skeptical at first, the audience stayed for the lecture, and then an hour of questions, and then stayed talking to each other until requested to clear the room. Everyone left with more questions than they had brought. I like and respect Peter Duesberg. I don't think he knows necessarily what causes AIDS, we have disagreements about that. But we're both certain about what doesn't cause AIDS. We have not been able to discover any good reasons why most of the people on Earth believe that AIDS is a disease caused by a virus called HIV. There is simply no scientific evidence demonstrating that this is true. We have also not been able to discover why doctors prescribe a toxic drug called AZT, zidovudine, to people who have no other complaint than the presence of antibodies to HIV in their blood. In fact, we cannot understand why humans would take that drug for any reason. We cannot understand how all this madness came about, and having both lived in Berkeley, we've seen some strange things indeed. We know that to err is human, but the HIV/AIDS hypothesis is one hell of a mistake. I say this rather strongly as a warning. Duesberg has been saying it for a long time. End of article. Dissenting on AIDS. The Case Against the HIV Causes AIDS Hypothesis. By Kary B. Mullis, Philip E. Johnson and Charles A. Thomas Jr. The San Diego Union Tribune, May 15, 1994. Every day we hear and read about HIV, the virus that causes AIDS. Perhaps no other medical issue in history has received such sustained attention by the media, the entertainment industry, popular literature, and the federal government. Therefore it is understandable that most people, as well as most physicians and medical scientists, have come to believe that the entire world is in the grips of a pandemic that is relentlessly spreading throughout every segment of society. For more than 10 years, this apocalyptic prospect has been drummed into everyone ever since that memorable day in April 1984 when Margaret Heckler, then Secretary of Health and Human Services, announced that the probable cause of AIDS has been found. At that point, Robert Gallo, a research scientist at the National Institutes of Health, took the microphone and declared that AIDS was an infectious disease, that HIV was the culprit, and that medical scientists at the National Institutes of Health had come to the rescue and would soon have a vaccine for HIV and have the problem under control. They didn't. The decision to blame AIDS on HIV was a political one, certainly not a scientific one, for at that time no scientific papers had been published, and the normal critical procedures of the scientific community had not been allowed to operate. Gallo's papers that followed did not establish a causal relationship, and subsequent official inquiries demonstrated them to be flawed for other reasons as well. Nonetheless, the prospect was seen to be so threatening that the federal government began pumping millions, then billions of dollars into AIDS research, which meant research on HIV, because HIV was the virus that causes AIDS. So here we are 10 years later. According to the U.S. Public Health Service, more than $22 billion in tax money has been expended since 1982, and this spending continues at the rate of $6 billion per year on treatment and research. Virtually all this spending is based upon the idea that AIDS is an infectious disease and that HIV is the cause. Therefore, 7 major points will come as some surprise to the general reader. 1. Although more than 75,000 scientific papers have been published on AIDS, no paper has seriously considered all relevant evidence and attempted to prove that HIV causes AIDS. Some papers respond to specific objections but begin by assuming that HIV causes AIDS, which is the very question at issue. If such a paper were possible to write, it would have been written, and been the most widely cited scientific publication of this century. Since such papers do not exist, it is impossible to refute or substantiate the arguments they might contain. Papers on HIV and AIDS exist, of course, but they assume HIV causes AIDS, which is the very question at issue. 2. The number of AIDS cases enumerated by the Centers for Disease Control, CDC, has shown an annual increase, but since the beginning, the percentage increase has been decreasing for 11 years in a row. Epidemics are supposed to show an increase before decreasing. The numbers are inflated from time to time by changing the definitions, as the CDC did in 1987 and then again in 1993. For example, according to the Los Angeles County Department of Health Services, which follows the CDC definitions, there were 1,566 reported cases of AIDS during the first 6 months of 1992, and using the same definition only 1,397, 11% fewer, for the first 6 months of 1993. However, if the expanded 1993 definition is used, the numbers are increased to 4,102, a 162% increase, which of course fosters the fear of a continuing epidemic and maximizes funding. Perhaps the cruelest deception fostered by the AIDS industry is the false idea that AIDS is spreading throughout the entire population and that everyone is at risk. Nothing could be farther from the truth. The CDC's own records show that AIDS cases are 90% male and largely restricted to homosexuals and IV drug consumers. Actuary Robert W. Maver has examined the latest CDC database and finds that the number of teenage, 13 to 19, cases of AIDS not involving homosexual or IV drug behavior is only 5. 5 kids in the entire United States. The comparable number for 20 to 24-year-olds is 55. These minuscule numbers could be even smaller because teenagers, and young adults, have been known to lie about their behavior. Even so, the chance of ending up as an AIDS case if you avoid homosexual and drug behavior is less than the chance of being struck by lightning. Nonetheless, on the basis of these vanishingly small numbers, school children throughout the United States are subjected to safe sex education. The definition of AIDS needs some explanation. First of all, AIDS itself is not a disease, it is a collection of other diseases that have been recognized by medical science for many years. People have been dying of these diseases for centuries. What is new is the definition of AIDS itself. AIDS has been defined by the CDC as the presence of one or more of the 25 to 30 different AIDS diseases, provided that the individual has some evidence of being infected by HIV. Ordinarily, this is a positive HIV antibody test, the presence of which generally indicates that the body has successfully fought off the HIV infection. You don't need to be a medical scientist to see at once that HIV is associated with every AIDS case. If you have tuberculosis and no evidence of HIV, you are a tuberculosis case. If you have the same disease and show a HIV-positive antibody test, then you are an AIDS case. By definition, this would mean that every official AIDS case would have an antibody to HIV. Ironically, the CDC does not even apply its own definition in recording AIDS cases. Frequently, no HIV testing has been done, a presumptive diagnosis is made and it is included in the tabulations as an AIDS case. The CDC admits to 40,000 such cases, but molecular biologist Peter Duesberg argues that the number must be much higher. The list of AIDS diseases keeps lengthening with new additions. For example, the CDC's most recent additions were CD4 cells lower than 200, tuberculosis, recurrent pneumonia and invasive cervical cancer. The last edition is said to embarrass some CDC officials because of its transparent political origin, because 90% of the past AIDS cases were men. More than 150 chimpanzees have been infected with HIV, and they show mild flu-like symptoms just as humans do, but after a week or two their immune systems rally and the virus concentration in the blood is reduced to negligible levels and the animals recover. They now seem to be living out the rest of their lives without the characteristic ravages of AIDS. In this regard, they respond just as many known HIV-positive people, many of whom have been living for more than 11 years without ill effects. In the Scientific American, UC San Francisco professor of medicine Warner C. Green explains this anomaly as follows. It is even possible that some strains of HIV are benign. It is time to ask whether any strain of HIV is harmful. For by sampling large numbers of people, the CDC has estimated that about 0.4% of the population of the United States is HIV+, that is, has antibodies to HIV, an indication of prior infection by the virus. This percentage, which has not changed for 9 years, calculates out to 1 million Americans. According to Lawrence Altman in the March 1 New York Times, new CDC surveys indicate only 600,000 to 800,000. So much for the epidemic of HIV infection. 5. In contrast with the unwillingness of the AIDS research community to produce a definitive scientific paper summarizing the reasons for hypothesizing that HIV causes AIDS, Peter Duesberg, the highly accomplished virologist from UC Berkeley and member of the National Academy of Sciences, has carefully documented and published the reasons why the HIV causes AIDS hypothesis fails every scientific test. His arguments have never been answered. His research funds have been terminated. Perhaps more disgraceful is the fact that this monstrous situation has received very little attention by the general media. 6. Perhaps Duesberg's most telling point is that he has found in the published literature accounts of 4,621 cases, 1,691 in the United States, of individuals with AIDS diseases who show no evidence of having been infected by HIV. This means that something else must be causing AIDS in these cases. So why can't this something else be causing AIDS in most other cases? When evidence of this kind was presented at the International AIDS Conference in Amsterdam in 1992, authorities at the CDC admitted that they had known about a number of cases like this for some time, but apparently kept this information hidden. It now turns out that the number of such cases could be quite large indeed. If left unchallenged, this observation alone would demolish the HIV causes AIDS hypothesis. To explain this anomaly, the CDC invented a new disease called ICL, idiopathic CD4+ lymphocytopenia, a totally forgettable name that means AIDS without HIV. It should be noted that physicians and health departments have an incentive to diagnose patients with AIDS symptoms as AIDS cases whenever they can, because the federal government pays the medical expenses of AIDS patients under the Ryan-White Act, but not for people equally sick with the same diseases who test negative for HIV antibodies. 7. The reason that the public is unaware of the significance and seriousness of the HIV dissenters is because they have been prevented from publishing. For instance, the editors of the leading scientific journals have refused to print even the brief statement by the Group for the Scientific Reappraisal of the HIV/AIDS hypothesis, which now has over 400 members, including the present authors. This 4-sentence statement notes simply that many biomedical scientists now question the HIV causes AIDS hypothesis and calls for a thorough reappraisal of existing evidence for and against this hypothesis. Such a reappraisal of the HIV/AIDS hypothesis should include the following: carefully controlled epidemiological studies of all major risk groups, homosexuals, drug users, transfusion recipients, and hemophiliacs. These studies should use an unbiased definition of AIDS, not requiring HIV as part of the definition, and be conducted by people who are truly committed to testing the HIV hypothesis rather than defending it. An audit of the CDC database to remove HIV bias and thereby to allow the fair testing of the critical epidemiological evidence for and against the HIV hypothesis. It should be determined how many of the AIDS patients were actually tested for HIV antibody and by what procedures. The antibody test itself is not perfect and many false positives are known under certain circumstances. The CDC's statistics have been assembled as if the purpose were to protect the HIV theory rather than learn the truth. Research focusing on the cause of a particular disease rather than the politically defined collection of disparate diseases now called AIDS. For example, Kaposi's sarcoma, KS, was originally one of the best AIDS-defining conditions. However, leading KS experts now say that there are dozens of cases of KS without HIV. It is quite possible that Peter Duesberg is right that the use of amyl nitrite, poppers, by male homosexuals is the true cause of KS. This proposal is easily testable and the work should proceed. A critical re-examination of the epidemiology of AIDS and HIV in Africa and elsewhere. Most AIDS in Africa is diagnosed using very manipulatable definitions. Antibody testing, if done at all, is suspect because of cross-reacting antibodies produced as a consequence of other endemic infections such as malaria. Given the 10 years of total lack of progress on AIDS, the billions of dollars that have been wasted, the human heartache that this issue has caused so many Americans, it seems only sensible that we should re-examine the question of what really causes AIDS. At issue here are not only the lives of those diagnosed with AIDS who are being treated improperly, but also of those who are tormented by the fear of AIDS for themselves and their children. We can't allow the scientific bureaucrats at the CDC and NIH to prevent this reappraisal from happening. Asterisk. Mullis of San Diego is the 1993 Nobel Prize winner in chemistry for his invention of the polymerase chain reaction technique, which is often used to search for fragments of HIV sequences. Johnson is the Jefferson E. Pazer Professor of Law at the University of California, Berkeley. Thomas, a molecular biologist, is the president of the Helican Foundation in San Diego and secretary of the Group for the Scientific Reappraisal of the HIV/AIDS.